This is just to show you what they've used in the past, and that's all the more reason for you to find out what your hospital is chosen for quality metrics. CMS charting rules, they're not guidelines, they're rules. And if you don't follow the rules, you're going to get downcoded. So 95 is the easiest one they came out with. They have ones that are subsequent to that, but they're harder. So obviously overcharting is better than undercharting. I'll show you something about that in a minute. So we're going to talk about 5 levels of service critical care. So the chief complaint is one complaint. You can't have chest pain, vomiting, sweating, Chief complaint, chest pain. All those other things are other things that go along with that. Chief means one. And you got a one box for the chief complaint. And then you talk about history of present illness. And they want 4 of those 8 descriptions in there. In your history of present illness, if you're doing a level 4 or level 5, they want 4 of those 8. 4 of those 8. So interdigitate those into your 4 of the 8. Review of systems. Now this could be done by a scribe, because when you go to a doctor's office, they give you a clipboard, and they want you to put down all of this review of system stuff for you, and this way a person's asking you, and they'll probably do a better job in asking you than if you were just filling out a piece of paper. This is weird too, because these are not systems. Are you familiar with the eye system? No, that's not a system. It's part of the brain. Ear, nose, and throat system? I don't think so. So CMS says there's 14. So you need 4 to get it. Level 4, 2 to 9. Level 4, 2 to 9. And I think that you probably have ways to kind of guide you, to remind you. Level 4, 2 to 9. Level 4, 2 to 9. 5 is 10 and more. Now, the problem with this, obviously, is there's this little box that says all other systems reviewed and negative. Well, first of all, you didn't review all those other systems. So how can you know they're negative? You haven't reviewed them. This is a lie. This is a great lie where you do a couple, check the box, and you think you do the ones that are appropriate to the problem with the person's there, but did you get 2 to 9? Did you get? See, that's easy, because 2 to 9 is easy to do. It's to 10, and once you hit the 10 thing, you do have to ask them 10. And then you can hit the box and it'll give you the other 4. Technically speaking, if you only need to ask one question per element, like review of systems for headache or CNS. Do you have a headache? No. That's it. You don't have to say anything further, fever, neck pain, anything like that. That's technically what you need to do. But obviously, if you're going to do something that focuses on the headed neurologic system, you've got to put down more than just one response. But technically, Medicare only says 1. Here is a great study. This was from UCLA. They tried to hide the fact that it was from UCLA by not putting down the name of the hospitals where these residents were. They initially started with 10 residents, but 1 left, and I'll tell you why. But anyways, it was 9 residents at UCLA asked to see 20 patients apiece, 20 patients, and they were shadowed on those patients, watching their histories and physicals. They were not told what the purpose of the shadowing was. They made up some other reason for this shadowing, but they recorded their history and physical. They recorded their history at least, and maybe what they said during the physical. There were people physically there, trained to observe whether they did all of these systems kind of thing. And they were fooled. They didn't know that what they were being asked to do. So they just went along their business. And for review of systems, audio records documented a mean of 5 systems asked. 5 systems asked. They documented 14. Every patient that they saw, of the 180 patients, had 14 because they check that box. They were taught to check that box, so they lied on this one. Physical exam. Physical exam, they were observed to do 5.5 systems on average, 5.5 systems. You need 8. They documented that they did eight systems. So each one coded a level 5, level 5, level 5, level 5. But the fact of the matter is that when they were watched and what they actually did, particularly on the physical, 5.5 items versus 8, claiming 8. So they were taught level 5. But you can see with the fabrication that goes into making a level 5 with all other systems were checked in negative, and these guys basically just blew right through on their physical exam. There were 10 people who started out. The 9th person, when the study was done and everybody knew what the study about, he refused to allow his data to be published. You can see why. So past family and social history. Obviously, the past history is much more important than the family history or social history. We don't care if you smoke, but we want to know the fact that you've had your gallbladder out, your appendix out, you've had a hernia repair, you've had triple bypass. We'd like to know about your past history. That's number one. So these are not equal. Certainly, that's the one you get for level 4. Level 5, you need 2 of them. So pick one of the other. Scribes are allowed to enter this and generate this from the patients as well. Physical exam has 12 systems. Review of systems at 14. Physical exam is 12. There's that eye system again. There's that ear, nose, and throat system again. But this is the way Medicare wants to do it. So that's the way they do it. Level 4, 5 to 7. You needed 8. That's exactly the numbers that the residents at UCLA put down. They put down 8 physical exam components. That means you've got a level 5. This is a part of the most important part of the chart, medical decision making. And they basically talk about the more medical decision making, the more complex it is. There's a lot of things to take into consideration. There's like 5 different systems that are involved here. They're diabetic, hypertensive, renal insufficiency, etc. Data points, we have, not only did they have CBC, they have you had a chem panel, a panel for this, a panel for that. They did an x-ray of the chest, they did a CT of the abdomen. So these are all data elements. And the fact that there's a lot of data elements helps you make a level 5 decision-making process. So there are certain rules, and you have a page there which is very hard to read, but you can read it if you try, and basically says that if you need 2 of the highest levels to claim that level. It says it on here. This stuff has been approved to be CMS valid by CMS. Here's what they have as a paragraph of medical decision making. Multiple possible diagnoses for a patient's chest condition. Well, that's good. He's already started that there's multiple choices here. After reviewing the patient's record, lab, and the radiology, and discussing the case of the patient's PMD, that's good. Doubt PE as pulse oximetry normal. Well, here's where you get into trouble. Most PEs have normal blood gases, oxygenation, and most PEs do not have tachycardia. I know that they say that. So that's misleading. Dissection unlikely as presentation not consistent with the diagnosis. I don't know. ACS unlikely as normal EKG and no risk factors. Normal EKG and no risk factors, does that exclude ACS? No, sir. No, sir. So the most likely diagnosis is whatever it was, and there's a moderate risk of complications having that diagnosis. So this is what they think is a good example of medical decision making. And part of it is good, but to say that you've ruled out certain things by those two elements, the person who's going to be testifying against you will say, doctor, are you allowed to have a tachycardia? A normal heart rate with PE? The answer is yes. normal PO2? Answer's yes. So, and that PE that you have is not the one we're concerned about. It's the next one that's going to follow. Because if you have a big one to begin with, you know, you got right ventricular strain, you got your neck veins are distended, you're very short of breath, there's no blood going into your lungs kind of thing. That is more obvious for sure. Additional elements, this is good things to chart, like, well, prescription given, that'll be automatically done. Imaging studies reviewed with the radiologist. You get a lot of extra points there if you go in there and review it. What do you think, Frank, on this x-ray? You also get some points if you review the films yourself. It's great to go into the patient and say, you know, I reviewed your x-rays and the radiologist reviewed your x-rays and we think they're okay. You know, it's like you read them and the radiologist read them, both of them, you know, kind of thing, rather than just taking the word. None of you have ever seen a missed radiologic report, have you? Of course not. Review of old records. You just can't say old records reviewed. You have to say what were the pertinent things that you found in the review of the old records. Family conference. You can't put this family conference. You have to say we discussed whether we should intubate or not intubate the patient and give comfort care. So you have to be specific for those things to be good. Critical care, the first half hour of critical care is given to the government. They get it free. So you start charting critical care in the second half hour. And the coders will know that there are certain procedures that are done that really you can't bill separately now because they're bundled in with the critical care that you're building. So you just basically have to write notes frequently. Do you have to stand beside the bed the entire time? Not really. But this is a serious patient, and they have to have a lot of your time and attention. Aftercare, no rules. You can do anything you want. We think they're extraordinarily important, however, for the benefits of the patients and the follow-up physician. Who are those aftercare instructions for? They're usually for the family physician. You're going to see the family physician in a couple of days or a week or something like that. What did you think was wrong? Well, here's what the family physician wrote. And you don't write otitis media. This is not about being in Latin. You write middle ear infection. Oh, I had a middle ear infection? Yeah, middle ear infection. So you write it in plain English. You give the patient a copy of all their lab and all their reports. You seal it, put down on the envelope the patient's name, medical records, and you give that so that when they show up, now some places they can look up all the information on their computer system that's linked to the hospital. If that's not the case where you are, give that stuff with them because the doctor who they're going to see and follow up whoever it is going to know what did they do? Did they do a CAT scan, or was it they were concerned about a spinal epidural abscess and they did a CAT scan? Well, that doctor will know. You know, you can't do that. You got to do a MRI here. You have to make sure that the follow-up is going to be pretty consistent. I always say three things. If you have any new or worsening symptoms, new or worsening, that's the only things that can do on new or worsening. If you have any new or worsening symptoms, come back to this emergency department as soon as possible. I might even use the word immediately, because I don't want to make little doctors trying to figure out after you handed them a sheaf of 15 pages about their cough and their backache and their this and that and the other thing. No, you just tell me if there's new or worsening. If you start vomiting with the belly pain, that's kind of a new symptom. We want to see you back. If the pain's getting worse, that's a worsening symptom. We want to see you back. New or worsening. You come back to the emergency ward because you don't know whether the family doctor's home going to be around to see this person next week. He's on vacation, or they don't understand that when the patient's calling in for a revisit, that it was from an emergency department referral. And so that would get you into any doctor, but because they're referred from the emergency department. So new and worsening, come back immediately. I don't think you need to give them all the the pupils look like this. They don't even know what a pupil is, kind of thing. I say, well, it's the black part of the eye. By the time your pupils are unequal, you are decorticate. Ask them if they look like this. or that's a decorticate. In any case, you ought to know a few prices here and there. You can't prescribe something knowing the patient cannot afford this ridiculously expensive antibiotic. They will just say, did you have any idea what this cost, doctor? And Mr. Jones, did you ask him if he had any money? So you can get a prescription at your hospital or give him some medicines for hold them a day or two if they need to. But that's technically not legal. You can't be handing out here's some pills unless you have the ability to dispense pills appropriately, where the bottle is labeled with expiration dates, instructions, and all the stuff that's supposed to be on a bottle of drugs dispensed by somebody. So that's just a few concepts. We'll do more. We'll get more specific.
So if you think about it, high sugar for a while, which is what has to happen initially with this whole DKA process, the high sugar for a while causes people to get dehydrated. They get osmotic diuresis. This is the polys you ask about, right, with people who have diabetes. Are you thirsty? Are you eating a lot? Are you peeing a lot? The polys, are you polyuric, polydipsic, polyphagic? So these people will come in dehydrated because they've been peeing for a while, which is trying to get your body saying, well, I'm going to just pee out this sugar. So they can come in dry. Now, the thing about DKA, though, is because in the meantime, your body's looking for another energy source, and it's going and you're forming these keto acids from breaking down other parts of your body, you end up with you end up kind of sick. Think about it. If you were to not eat for a day or two, and we've all done this, right? You just skip meals and you're at the end of your day, you feel headachy, you feel nauseated, and if you dipped your urine, you would have starvation ketosis. You feel gross. People with DKA feel gross. They get that nausea, they get headachy, they just feel nasty, they just feel terrible, and they get sicker and sicker as the acidosis gets worse. So the dehydration, while absolutely real, is usually anything from 2 to 5 liters down. Because in the meantime, before they get uber dry, they end up getting sick and they come to see you. So while people who have DKA are dehydrated, they're not 10 liters down. They're 2 to 5 liters down, which is important to kind of factor in. They may not look super, super dry. They do, though, as their body makes acid, need to get rid of it. Your body's like, okay, whoa, dude, we don't like having acid. We've got to get rid of it. The way you get rid of this metabolic acid, this acid's being produced by breaking down parts of me, is to blow it off. I can blow it off. I can breathe it off. And that's that respiratory rate we're going to honor now, because we're going to watch how somebody breathes, and we're going to see those deep, small respirations. They're hyperpnic breathing. It's almost like the belly breathing you see in kids. They can be breathing normally for you, but their breaths are huge, and they're blowing off all that they can, the CO2 they can, to try to get the acid out of their system through their respiratory tree. So watch for those small respirations. If you're someone who can smell it, and about 25% of the population can, if you're in a room with somebody with DKA, they smell like fingernail polish remover. My husband can smell it, I can't. But he said, oh yeah, I can tell DKA from 20 feet away. So some people can actually smell the ketones on somebody's breath. If this goes on long enough, people will go, frankly, into a coma. They will die. I mean, they get more and more acidotic. Your body can't use the sugar it's in there. You're making all this acid to try to get some sort of energy source. They get super sick. The reasons this happens, why would somebody even go into DKA in the first place? So say you make the diagnosis. Yay for me. I listened to Diane's lecture. I got those small respirations down. I figured it out, the diabetes thing. It was great. You are not done. If you make the diagnosis of DKA, you've got to now go figure out why. So those two things have to go together forever in your career. If somebody comes in with DKA, you've got to go figure out why. Here's the list of why people go into DKA. Infection, 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 infection. Please look for it. And you're going to look funny places. You're going to look for, you're going to see if they have PID. You're going to check for a perirectal abscess. You're going to look up their nose for mucor. You're going to look funny places in addition to your usual, is it pneumonia? Is it a UTI? Is it just they got a cold? So you're going to think about other places. You may not necessarily go searching there, but you'll go back and ask questions about it. Have you had a really stuffy nose? Any problems when you any discharge down there? Any problems when you poop? So you actually cover all the bases where infection might be, because infection is the most common cause of this. But the second most common cause of this is what we call infraction. Somebody just didn't do what they were supposed to do to keep their diabetes in control. Didn't take their insulin, it was a birthday party, they had a bunch of cake, something where they threw things out of whack. And then there's a whole bunch of other things in it. These are what we call the eyes of DKA. And this is how I remember to go make sure I cover the list in somebody who comes in DKA. I've made the diagnosis, yay for me. Now I go to this list. I make sure they're not infected anywhere. I make sure there's nothing infarcting. So I'm going to double check that neuro thing, make sure that's okay. I'm going to ask them about whether they're eating and taking their medicines appropriately. Are they newly pregnant or gestational diabetes? That will do it. Strokes will do it, heart attacks will do it, illicit drugs. Now, illicit drugs are usually because when they're doing the illicit drug, they're not doing the right thing for their diabetes. So it's kind of a combo, but that is often a trigger, especially, by the way, in teenagers with diabetes. They don't like having diabetes anyway. If they're insulin dependent, it's a nightmare. They hate it. They hate it. They hate it. And it's a time where you experiment with drugs. And so it's just this whole cluster with teenagers in particular. We do it sometimes. Give me a drug. You tell me. Give me a drug where we put somebody's diabetes out of whack. Steroids, we do it all the time. All the time. So if you have somebody who's a brittle diabetic, whose steroids are on your plate as something you can use to treat them for something, make sure they really need it. If they really need it, do it. Absolutely. Terrible asthma, absolutely, go for it. But if it's just I'm not sure if it's going to help you, be careful, because you can throw their diabetes out of whack. And then nuance it. Sometimes they come in, and this is the kids, right, the little guys, where they come in and we just don't know yet. We just don't know. It's just nuance it. It's idiopathic. I didn't know you had it yet. That's why they come in with this. And we're seeing it with some meds and things as well. Some of the COVID has done this to some people. But mainly this is the list. To remember, if you've diagnosed DKA, go to this list and make sure you pick something on there that's causing it. Now, to diagnose it, let's say you're out in fast track and somebody comes in and they're looking at their breathing and it's like, wow, they've got some small respirations and they're talking about polyuria and they're feeling kind of nauseated and headachy and you're out in fast track and you're like, wow, maybe this is DKA. Looks like small to me. I can't smell those ketones, but maybe. You know what you can do? You can do a finger stick sugar, which will be critical high, and dip their urine, which will be positive for ketones, and you're going to be 97% of the time correct in diagnosing DKA just that way. So you can actually pick it up out in triage. You can pick it up out in an urgent care. You can pick it up in a neighbor who has the dips and the finger stick stuff. You can pick this up from simple tests. We do much more because we need to follow things as we treat them, but that is a slam dunk diagnosis. 97% of the time that's accurate, those two things. Also, though, when you're checking labs, you're always, when you get to the treatment point, you've got to know their potassium. I'm going to get into that in some detail. If you do dip a urine, the urine is positive for glucose and ketones, absolutely. And they're going to have, when you do your labs, a metabolic acidosis, which means we need to get the right labs to determine that. It's an anion gap acidosis. So you're going to go ahead and get a full chem panel. So you're going to go ahead, you need to have all of it because you need to calculate the anion gap. You have to know the potassium, and you're on purpose going to look at that potassium. Because your eyes are going to be drawn over to the sugar of 450 or drawn over to the bicarb of 8. Put your eyes on that potassium because that is going to make a difference when you start the insulin. So make absolutely certain that you look at the potassium early. Consider doing whatever tests are appropriate for what you think caused the problem. So if you think the person has an infection, chase it. Go find it. Get the chest x-ray if that's what's indicated. Get blood cultures if you think that's what's indicated. Do it. Go ahead and get the CBC. Just the white count a little bit, but go ahead and pay attention. We have to pay attention to the white count. But go ahead and check and see if that will help you with what's wrong with them. And again, just the tests that are appropriate. Urine often is a thing you check for, not only for seeing if there's sugar in it, but if there's an infection. Do think about, remember, infarction is one of the things that can cause DKA, and if there's no real reason that this very well-controlled diabetic is now coming in out of control, you might want to consider, getting an EKG and thinking about, could this be a silent heart attack of this person? And that's not common, but just something to think about. And then you consider sending serum ketones and lactate to help you kind of determine what's causing all these acidosis problems. The thing to know when you get all those labs is there's one more thing that you're going to need to know to be able to manage them thoroughly for their DKA, and that is the corrected serum sodium. So it is extremely common for you to be taking care of somebody with DKA or hyperosmolar state, and to get the lab to call you back and say, we have a critical value, we have a sodium of 124. And they call you with that, that's a critical value. We'll talk about electrolytes tomorrow. But your first thing to do if you have a low sodium is to go look at the sugar. Because an elevated sugar will falsely decrease your sodium. And the problem with that, if you flip it around, where now I've got the high sugar and I need to figure out what the sodium is I need to know what kind of fluids to give somebody. I need to know, do I do half normal saline? Do I do normal saline? When do I change that? You need to correct for that elevated sugar that's making that lower falsely. It's not totally false, but making it lower as far as how you manage somebody. So you're going to go to MD Calc. You're going to get that app out that Martha just told you about this morning, and you're going to put in, what is the sodium? What is the sugar? And it's going to tell you basically what the corrected serum sodium is. And I'll show you where that works in a minute. So the things you need to know are, get the chemistry, focus on that potassium, make sure there's an anion gap, that helps us figure out DKA, find out what that initial sugar is, you're going to watch that potassium, and you're going to correct this. You're going to correct the serum sodium. Because what we need to do now is fix it. Now remember, people with DKA are about 2 to 5 liters down. So I can pretty much with impunity dump in at least a liter, unless they have terrible congestive heart failure. I can dump in a liter. And I'll tell you, rehydrating makes people start to feel better anyway. They pee out ketones, they feel better. Whether you use normal saline or a balanced crystalloid is of quite some debate, I have to tell you. If you're a balanced crystalloid person, that's fine. But do know that at some point you're going to have to address the sodium content of that. So either one is fine. Either one is fine. You're right either way. It's just if you start with normal saline, at some point you're going to have to cut that sodium down when you start to rehydrate somebody. You are going to determine how aggressively you hydrate based on their clinical status. If they are just like so dehydrated, their blood pressure's low, they look awful, hydrate them for heaven's sakes. Go in, and even if it's a little kid, hydrate them. Don't go berserk. You're going to get them you're going to basically give them fluids, watch, give them fluids, watch. Check them out in between each, but give what they need, especially in kids. We know that kids can get cerebral edema who have DKA when we treat them, but if they're super sick and super dry, they need hydration. They absolutely need hydration. So I'm sure each of you has a different protocol where you work, but hydration is absolutely key. Either of the types of fluid is fine to start. Normal saline is fine. The balanced crystalloid is fine to start. What you're going to end up having to do at some point, though, is add insulin. Now, please do not start with insulin. There is no hurry. There is absolutely no hurry to aggressively hit somebody with insulin. Hydrating is key. That helps people a lot. That helps them start to drop their sugar just by hydrating them alone. You can kill somebody with insulin. You can clean kill them with insulin. And that's why you're going to go look at that potassium. Most of the time, people with DKA have either a normal or a high potassium. But remember, they're acidotic. When someone's body has a lot of acid in it, the potassium scooches out of cells and raises up in the actual bloodstream itself. Your blood ends up with more potassium in it. It's shoved out of the cells into the periphery, into the bloodstream. So the potassium is elevated, but their total body potassium may be low. And remember, let me flip it. If we're treating hyperkalemia, we often add insulin. If I'm going to give insulin to somebody, whatever their potassium is, it's going to go down. So I need to know right now, before I start that insulin, what their starting potassium is. If it's under 3.3, you're not going to start the insulin until you give them some potassium back. Really important, because once you start that insulin, that 3.3 is going to drop, and it can drop to dangerous levels. So, and I'll show you, there's a wonderful algorithm that has all this together. The dosing of insulin is you don't have to prime the tube. It's 0.1 per kilo. It's just fine. And you're going to check sugars after that. This algorithm has been around for quite some time. It is superb. It's from the American Diabetic Association. And it's up to date. You can Google it. It's actually in a lot of the apps that you heard about this morning. It has 4 things we're doing when we're treating DKA patients. The first is those IV fluids on the left. So you're going to do those IV fluids. If they're dehydrated, you're going to do full-on isotonic whatever and tank them up. Once they're quasi-tanked, I'm going to calculate that sort of sodium depth, that corrected serum sodium, because if it corrects up to normal, I'm going to put them on half normal saline. I don't need to add a ton of more sodium to those people. I'll make them acidotic, so I don't want to do that. I'm going to drop them to half normal. Again, just follow this algorithm. It is brilliant. But the thing about this algorithm I want you to notice is under that potassium column, there are 3 boxes. If the patient is high or tweener, you can go ahead and start insulin in those groups. But those people, you're going to be adding potassium to the tweener and the low group, which sounds weird, right? Why would I add potassium to somebody with a normal potassium? Because it's going to go down once you start that insulin. So those 3 boxes are vital. And you only start the insulin once you are sure it is safe to do so, to get their potassium up to a level where you're not going to drive it down to a dangerous level. The column on the right, I completely ignore. I don't care if somebody's pH is 6.8. I do not give bicarb. And this is a huge debate. There is no absolutely right answer, but there is some evidence that giving bicarb can worsen outcomes because it drives all that acid into somebody's brain. So just know that column, it's tempting to want to fix it, right? I have bicarb, I'll just give them bicarb for their acidosis. No, you want them to metabolize back, get back insulin on board, quit breaking down all my fats and go back to normal metabolism. That's what I want to do. So IV fluids, start isotonic. At some point, calculate your corrected serum sodium and adjust as needed. Insulin, you're only going to start after you've checked that potassium box and done the right thing on that potassium box. And then when it comes to insulin dosing itself, go ahead and start it, but you're going to have to follow the sugars. Because at some point, you may need to actually add a little bit of sugar back until they completely clear all their keto acids. So it's actually incredibly fun, not as complicated as all of that sounded. And the stumbling blocks for you are, start with some fluids, make sure you give it to them. Check a potassium before you ever give insulin. Replace the potassium if you need to. Boom. By then, you've usually admitted the patient and they're long gone. But you've done the right thing. And you've gone back and figured out why they went into DKA. You went back to your eyes. That's what you need to know about DKA. But if somebody has really high sugars, another thing that can happen is they just become the human rock candy. So type 2 diabetics tend not to go into DKA. They tend to just get super, super high sugars. Like super high sugar. What's the highest sugar you've seen in this room? Mine's 1,600. What's the highest you've seen? Anybody over 2,000? Yeah, so look at this. I mean, this is insane, right? But 2,000, for heaven's sakes, that's insane. What happens in your body with a sugar of 2,000 or 1,600 is so your body's like, oh my God, let's get rid of this. And you try to pee it out. You drink and drink and drink and drink, and your body tries to pee it out and pee it out and pee it out. But you still have insulin. You still can use it. It's just more than you need. You're insulin resistant. I still have insulin in my system. I can still use it. I don't need to become ketoacidotic. I got plenty of sugar. I just have too much of it. I can't bring it. It's more than I need. What these people do is pee like crazy and end up so dry. They are 8 to 10 liters down. This is the person where it's like, wow, you are really, really dry. They are rarely ketotic, if ever, and it's only tiny amounts of ketosis, mainly just because anyway, it's not a big part of this. It's just their sugars are super high. So rehydration is vital in this group, absolutely vital. You've got to get them tanked up again. And this is where probably using balanced crystalloid is better. Balanced crystalloid you want to use because you don't want to give them another hyperchloremic acidosis from too much normal saline. A little more stuff. The reality is just go ahead and grab Ringer's lactate in this group. It's probably the best thing to do. And eventually you'll drop it down once you do the corrected serum sodium. This is the same algorithm you just saw, but it's missing that acidosis column because they're not acidotic. And pretty much everything here is the same as far as when you add the insulin, when you add the potassium, all of it is the same. The thought processes are exactly the same. You just don't have to worry about acidosis, and you're gonna probably wanna add sugar back a little bit earlier because these people have had a high sugar for a while. It takes a while to get this sick. They can days and days with this sort of thing. So they can be home with this for a week. So you're gonna actually sort of add back a little bit of sugar earlier. These two algorithms, please cement in your brain, find a place where you can find them. They are just absolutely fabulous. So please use these algorithms. Now, the flip side is hypoglycemia, and we know this definitely happens. The hypoglycemic person that just passes out. And they have lots of symptoms, right? So I didn't eat dinner last night, I didn't eat breakfast this morning. I sat back there this morning talking to somebody. I got lightheaded, I got sweaty, I got tachycardic, my watch went crazy, I got tachycardic. I was like, whoa, what's wrong? I was hypoglycemic. I'm not a diabetic, I just hadn't eaten. So we know that people can get, the symptoms are, they pass out, they get sweaty, it's all the symptoms that go with being hypoglycemic. In type 1 diabetics, it's almost always too much insulin, too little food, or burning too many calories, either because they are now on a new exercise plan and they didn't integrate it into their system, or they're sick, like they have sepsis or an infection that's making them catabolic. So it's basically either too much insulin, too little food, or they're burning too many calories. The treatment for that is either give them the sugar. So I skipped breakfast this morning and I'm a diabetic, give them the sugar. Go ahead and give them something to eat if they can. And they usually have those little gummy things in their bags, and they know this. Type 1 diabetics know this. Give sugar. If they're out of it, go ahead and give the sugar intravenously or glucagon IM. All of this is fine. All of this is fine. The key is to go ahead, if they're type 1 diabetic, get them back to whatever's baseline and then feed them. Go ahead and let them eat something, feed them, and watch them for a little while. If they're on long-acting insulin, you're gonna have to watch them for a couple of hours, maybe even as long as 6. If they're on the shorter, just the regular insulin, that's gone in 30 minutes. So just find out what your insulin profiles are. The conundrum for us, though, is the type 2 diabetic. Now, the type 2 diabetics that we really care about in this category are the ones on the oral hypoglycemics that are sulfonylureas. The sulfonylureas have really long half-lives. So what a sulfonylurea does is I'm an insulin-resistant person with type 2 diabetes. I have plenty of sugar in my body, but I don't really have enough insulin to metabolize it. So I take a pill that lets my own insulin boost for a little while and drops my sugar. Cool, perfect. That's what the sulfonylureas do, and they last a long time, so I get a long duration of that. Excellent. The only problem with that is they last a long time and they bump my insulin. So think about this. I now am hypoglycemic from a pill that I took that's gonna last 24 hours, and let's say I just didn't eat, so I don't have enough sugar. This pill is in there still doing its thing. It has this little extra insulin floating around in here. So what I do to fix that as an emergency person is I give you a bolus of sugar. Boom, sugar, lots of sugar for you. What does my body do with that? It says, oh, sugar, I need to release a little more insulin. You have seen these patients in your career, I guarantee it. They come in hypoglycemic, you give them the sugar, they wake up, ta-da! You walk away, you're doing something else, and the nurse comes up and says, you know the patient in bed too? Sugar's back to 40. It's like, what? Just gave him some. What's up with that? Do it again. Okay, fine. You can do this multiple times because they already have this too much insulin floating around from the sulfonylurea. We give them sugar, their insulin jerks up again, it drops. I mean, it's this crazy thing. The way to fix it, octreotide. And you thought octreotide was only for varices. Oh no, this works for this as well. So octreotide, which is a somatostatin blocker, works beautifully. The dosing is the same as you would use for varices. It is magic. It's considered an antidote for this. But I want you to know, an oral hypoglycemic sulfonylurea taking person who comes in hypoglycemic is at least an OBS person, if not a frank admission. Because you're chasing your tail for a while in this until they can get that sulfonylurea to metabolize and get back to some sort of baseline we can work with. So assume admission or OBS in these patients. If they're doing this over and over again thing, try octreotide, and boom, get them admitted, get them in. Let's jump up to the neck. Let's go to the thyroid. So thyroid diseases are uncommon, but we see them in the emergency department. We definitely see these in the emergency department. And the way we diagnose these in the ER is not with a thyroid hormone level. We can't get those anyway acutely, but it's with a TSH level. So your thyroid hormone is here. Your brain, your pituitary is telling it what to do. And it sends thyroid stimulating hormone down to your thyroid saying, dude, make some thyroid, okay? We need it. We need this for metabolism. We need this to live. We need thyroid. If my thyroid says, I'm done, I'm not doing it anymore, it shuts down. So my thyroid isn't working anymore. So I end up hypothyroid. My TSH goes really high. It's like yelling down at the thyroid saying, what are you doing? Do something. Versus the thyroid that goes rogue, and it says, oh, I'm going to make thyroid on my own. I don't need you. So the brain turns off. The pituitary says, whatever, fine, I'm going to sleep. So the TSH drops in people with hyperthyroidism. So high TSH is low thyroid, hypothyroidism. Low TSH is high thyroid, hyperthyroidism. That lab, if you can get that, it took us decades to get this as a stat lab in our ER, but it is a godsend. And I can't tell you how many thyroid disease patients we've picked up since. Your thyroid, depending where it's high or low, affects incredible amounts of your body. It affects so many things. It affects your hair, it affects your skin, it affects your bowel movements, it affects your energy, it affects everything. It is remarkable, your mental status, it does all kinds of stuff for you. Your heart for sure, your blood pressure for sure. So hyperthyroidism is where it's basically, I think of it as, and it's not exactly true, but I think of it as like having too much adrenaline. It's like your thyroid is sort of like an adrenaline light. So it's basically making my heart go too fast. I get weight loss, I get a tremor, I feel terrible, I have palpitations. If they come in, you see them with, that's the person sitting there with a heart rate of 105 for no reason. Like, why do you have a heart rate of 105 every time I go see you? What is up with that? Well, maybe they're hyperthyroid. So often if they really go into storm is where now it's anarchy. It has gone to the point where you have altered mental status. You are just out. You are altered. And thyroid storm is a true, honest to God emergency. You've got to pick that up, which is why having a TSH available stat is very helpful. Nuance at AFib is another rhythm you can see with this as well, but that's not commonly why people have nuance at AFib. When you treat people with thyroid storm, I think about thyroid storm as an out to in treatment. I start out with fluids. I get their tank filled, okay? I go ahead and give them fluids, and because they're hypermetabolic, I add some sugar. So it's D5 something. I add some sugar because they're hypermetabolic. If they're a little bit febrile, remember, it's the metabolic part of why your temperature can be up. I'm gonna go ahead and treat that. I'm gonna give them a little bit of acetaminophen if give that a try. Cooling measures if I need to. But now I need to take those end organs that are getting battered with the thyroid, and I need to stop that, and I use beta blockers. I bring the heart rate down, that's great. I saw that it helps the heart. I bring the blood pressure down a little, which is great. And I decrease the conversion of thyroid hormone out in the periphery to the more active form. Cool. Now I'm gonna, and whatever, it doesn't make any difference which one. Propranolol has been studied the most, it doesn't make a difference. Just get them beta blocked. And then I come back to the thyroid. So I've gone out to in. Now I'm at the thyroid and I'm gonna tell the thyroid to quit. And you use something like antithyroid drugs. PTU is black box now, so methimazole is what most people use, but you're gonna go here. And by the way, by the time you're doing this, you have just blown away the endocrinologist you got on the phone by slam dunking the diagnosis, getting everything started, and they are gonna take it from there. They can shut the thyroid down completely with iodine for a while, but the reality is you have picked it up by the symptoms and by checking a TSH. The flip side of it, hypothyroidism, is extremely rare. We hardly ever see this. In the United States, we tend to see this in people who have had thyroid eradication from one reason or another. They've either had it removed, so if somebody comes in you think is in myxedema, look here. Look for the scar. More often in the US, though, it's been radiated out with I-131, iodine 131, so you won't see a scar. And if they're out of it, if they're kind of lethargic or comatose, they may not tell you that. So you may have to check a TSH, which is going to be super high. This is really rare. These people go into this slowly. It's not something, if somebody stops taking their thyroid medicine today, thyroid medicine, if you're a thyroid medicine person who takes it, lasts weeks. The half-life of a thyroid medicine is literally weeks. So if I stop taking it today, I'm not going to go into myxedema coma today or tomorrow, next week. I probably won't even go into it till after Christmas if I stop it now, and I'm 100% dependent on that drug. So the reality is this is something that's often insidious, and people don't notice that grandma's a little slower, and her skin is looking a little funny, and her hair is falling out, getting all brittle. They don't necessarily notice that. So stressors and cold may precipitate this, and you're going to check a TSH. And the treatment for this is find out what tipped them over today. So you're going to look for infection. We always do that. If you have to fix it where they're truly comatose and you need to give them thyroid hormone today, which we rarely do, the only thing you have to know as an emergency, so say you call the endocrinologist and they say, good for you, you picked up myxedema, you're so smart. Give them thyroid hormone, IV, cool. Okay, well, we can do that. The problem is that person's adrenal glands are also kind of chilling. And now you hit them with a lot of thyroid hormone, and you can put them into adrenal crisis. So just give them a little bit of hydrocortisone, and then go ahead and give the thyroid hormone, and you're good to go. It's amazing what can change with people when they have thyroid treatment. All right, we have 1 minute to do acid-base disorder. It'll actually take about 3, so I'm going to go over a couple minutes. But let's talk about acid-base disorders. And I'm going to come down to the quick and dirty. I do not want you thinking about triple deficit disorders, and I don't want you to do that. Know that what you're looking at is it from a metabolic process or a respiratory process, and are they acidotic or alkalotic? That's what I care about. Okay, that's it. That's all I want to know. That's all I want to know. I also know that my respiratory system can work really fast, but for all the metabolic stuff to get fixed takes a while, or to get out of whack takes a while. So you right now can give yourself respiratory alkalosis right now, by hyperventilating, because it's quick. I shift it around really fast. That's quick. Metabolic takes longer. You know your blood gas gives you pH. Okay, that's one of the things we need the blood gas for the pH. That's crucial. I can check a PCO2 and a PO2 other ways, like pulse ox, etc. But a blood gas gives me all the things that I need, especially if I'm worried about an acid-base disorder. I'm not going to talk about base excess. It's too complicated. It's kind of weird. But what you need to know to figure out acid-base disorders is the pH, the PCO2. Those are from the blood gases. Then from the chemistry panel, I need the bicarb, and I need the anion gap, which is calculated for most of us now. It just gets spit out. You don't have to do any formulas. It's just calculated for you. If you want to know the formula, it's here. For most of us, it's already spit out on your printout, on your computer screen. This is how I recommend you look at these to help figure out what's what. So this little algorithm I put together for residents years ago. And you start with the pH. Okay, just first go there. If the pH is greater than 7.4, that person is alkalemic. There's too much alkali in their blood. So now I'm going to look at the PCO2. I'm going to go look now at my labs, and I'm going to look at that, or the blood gas, look at that PCO2. If the PCO2, when they're alkalotic, is low, that's what you can do right now. My PCO2 is low. I'm blowing off CO2 for whatever reason. This is a respiratory alkalosis. If that PCO2 is high, they're retaining that. That is a metabolic alkalosis. Flip it to the other side, my pH is now acidemic. My pH is 7.2. If my PCO2 is low, 10, 12, my PCO2 is less than 40, that means I have a metabolic alkalosis. I'm trying to blow off CO2 because I have a metabolic acid. If it's high, though, say you hold your breath here, or you're taking care of a COPDer who's retaining CO2, they get an acidosis. It's all respiratory. It's just they have extra CO2 in their system that's turning into an acid in their body. This division will help you decide whether it's a respiratory process or a metabolic process, and whether it's acidotic or alkalotic. If it's a metabolic acidosis, you have one more step you've got to do. You've got to go ahead and calculate the anion gap. So go to your labs, look at your anion gap. If it's acidosis that's metabolic with an anion gap, those are the killers. Those are the killers. Those are the things that we are the most concerned about as far as killing people in the emergency department. If you're interested in additional disorders, I added these for your information. Please don't waste brain space. Everything you need to know is up above that cutoff. The differential diagnoses of these, we all have different sort of mud piles equivalents. There's updated versions of mud piles, but the killers on this list are the things that have an elevated anion gap. That's the salicylate overdose. That's the person who drinks ethylene glycol or methanol. Those are the killers on this list. DKA's in there, you'll notice. People have a normal anion gap acidosis. It's almost always because they've been pooping too much, the bicarb's going out their backside, or they have something wrong with their kidneys. Here's a couple other lists for you. If people are metabolic alkalosis, there's some information for you as well. Here are 2 charts just for your information. I include these only for your information, but to cut to the chase, don't freak out. If it is a metabolic acidosis, super easy algorithm to get there. If there's an elevated anion gap, figure out the mnemonic and see if there's a life threat. No anion gap, it's usually an RTA or they have diarrhea. If it's a respiratory acidosis, that's somebody who's retaining CO2, we can fix that with ventilation. Easy peasy, not hard to do at all. Sorry, I ran over a little bit. You have it all down. Endocrine and acid base, you're set to go. You're going to hear about, I think, head trauma now, right? Yes. All right. Michael Gucci's going to teach you about head trauma. Thanks, you guys.
Thank you. Well, good morning, everyone. I had the pleasure of meeting some of you yesterday, but I'm Michael Gooch, for those of us that were here for the pharmacology workshops yesterday. I'm from Nashville. I practice and teach at Vanderbilt there in Nashville doing flight and emergency medicine. And talk a little bit about head trauma and some of the things we run into. And I know I'm the last speaker before lunch, so we'll try to make it somewhat exciting and enjoyable as we talk about the management of these patients. And as we'll talk about, major trauma is easy. That is ABC or CABC. But sometimes those minor patients we have to focus on, they can be a little bit more challenging. So unfortunately, we know that we live in a litigious society. But we do have some clinical decision tools that we'll talk about that are out there that can kind of help us guide our care and really focus on our assessment and trying to figure out what patients really need imaging versus maybe observation versus just discharge home with a responsible adult. Now that unfortunately sometimes is the challenge because whoever they're there with was probably part of the other process that got them there in the first place. But clinical presentation can vary a lot depending upon what type of trauma they have. Sometimes it's that very focal, localized injury that we get some specific things. It may be a speech, or it may be mental, or memory, or cognition, or it may be motor, or sometimes there's non-focal injuries like a concussion, and their presentation can be really weird or very different than we would expect. So sometimes you have to have that high index of suspicion and go investigating and try to figure out what this might be as we're trying to go through our differentials. So our typical age group, that's your 15 to 35, 30-year-old, usually it's the white Caucasian male. Hey, y'all, watch this, hold my beer. Famous last words that I hear a lot in Tennessee, or the, hey, there I was, or so there we were, and this happened. But definitely thinking about these patients. Head trauma can bleed a lot, just external trauma itself, and especially you put that being an older patient who's on an antiplatelet or an anticoagulant, now they really can do a lot of bleeding. So direct pressure is still our first line thing. A lot of central trauma, and have a lot of cerebral ecchymosis and edema, or if they're intubated. So that definitely has some limitations, but we know that typically if someone's post-trauma and their GCS is 13, 14, or 15, that is really reassuring. And if they're 2 hours post-trauma and their GCS is now 14 or 15, that is really a good indication of good prognosis. But if their GCS is declining, then that has some concerns. And that old adage of GCS less than 8, we need to intubate, it's still pretty true. Because definitely if that patient has a decreased mental status, they have that decline in GCS, they probably are lacking those protective reflexes that are going to be important for protecting their airway, protecting against vomiting and aspiration. So we need to think about those patients early. And definitely want to make sure that we're maximizing oxygenation and ventilation, not overdoing it, but making sure we're trying to prevent bad things like hypoxia and hypercarbia. So skull fracture we run into pretty frequently. Sometimes these are usually very minor, those linear skull fractures. We don't even need to do anything with those. Sometimes we'll observe them for a little while. Sometimes they go straight home and they'll follow up in the clinic with their neurosurgeons or trauma providers. But definitely some of these can be more higher risk. And definitely think about if you have that temporal bone fracture, that's where our middle meningeal artery is, and that is one of our big sources of those epidural bleeds. So definitely if you get that report back, they've got a temporal bone fracture, that patient I want to watch a little bit better. Maybe when I want to push, hey, we need to put them in at least for observation, especially if I'm not seeing the epidural bleeds yet, they do have that risk. Definitely our open or depressed fractures, those are higher risk for complications. Definitely our Bayesian skull fracture, we have to worry about laceration of the dura. Those are going to increase the risk for infection. They sometimes have some cranial nerve involvement as well. So you've got the injury, what are the symptoms are they having? What signs do I see? And then thinking about what's coming after this. Oh, they've got that Bayesian skull fracture. Oh, they've got that temporal fracture. Those are ones I want to watch a little closer. And luckily, most of these people do very well, but some are going to require neurosurgical intervention and definitely think about risk for increased intracranial pressure as well. So I talked about these already, but definitely think about those temporal bone fractures. And we'll talk about head bleeds in just a moment, but epidural bleeds are not as common in subdural, but they're definitely high risk. They have that high mortality. That's that classic head trauma. They get non-responsive, and they eventually come back too. Our Bayesian skull fractures, those are sometimes not too easy to pick up by CT. Sometimes they show up pretty well, sometimes they don't. So sometimes this may be a clinical diagnosis. So does this person have that periorbital ecchymosis? Do they have that battle signs? Do they have that CSF draining from their nose or their ear? If I've got the patient that's got that otorrhea or rhinorrhea, have that high index of suspicion. If they're going, I just feel like I've got all this postnasal drip and it's constantly clearing the back of their throat, that could be CSF draining. It doesn't always come out the front. It may go down the back of the throat. So watch for those things and evaluate for those. Oftentimes we're going to go ahead and prescribe antibiotics just to cover that risk, but they're not always indicated and may not necessarily help. Definitely think about high-risk situations. If you're in an area that has a profound problem with community-acquired MRSA, that may be something we need to think about more than just your typical staph or your typical strep. If they've got that blood tinge drainage, we can go ahead and check that for the halo test. It's not always going to be helpful, but as you can see here, typically if it does have that CSF there in it, it's going to give us that nice little ring appearance around the bloodstream. If it's clear, go ahead and check it for glucose. If that has glucose greater than 30 milligrams per deciliter, that is not just nasal discharge, that is CSF. You can send that off for a beta transferrin test. Probably for a lot of us, that's something we're not going to get back within a couple of hours or maybe even a couple of days. But definitely if I got that drainage, that person's constantly trying to clear the back of their throat, or if I see drainage down the back of their throat, think about CSF and let's investigate further. The raccoon eyes, the battle signs, those are pretty common that we'll see. For most of us in the ED, we tend to see the raccoon eyes more. People get mid-face trauma, they get Bayesian skull fractures. That happens pretty quickly. That area gets edematous, it becomes ecchymotic, and we can see that. The battle sign we don't see as much. That usually takes several hours to appear. It takes a couple hours for that blood to get absorbed by the mastoid process. So for a lot of us, we don't see that. That's what we see in hospital day 1, hospital day 2, upstairs in the trauma unit. But definitely be suspicious if the patient comes in, they already have both, and the story is, oh, he just fell off the bed. Unfortunately, we run into a lot of cases of non-accidental trauma, and this is one of the things I have to think about, that the story is that kid just fell off the bed, but they already have bruising behind their ears. That likely didn't just happen. That took several hours for that blood to accumulate. Hate that we have to deal with those patients, but we do, so definitely keep that index of suspicion. Look at their TMs. Do I see that hemotympanum? That may be the one indication that we see. Sometimes that's kind of difficult, especially if they have a head lac and blood's running everywhere. I want to try to clear that out, but do I see that? This is not what your typical tympanic membrane looks like with the otitis media. That's usually very red, very bulging, and this has that blood tinge, but it's not always bulging. But look for that, and that definitely is something that I want to document The absence of, hey, I don't see a hemotympanum, that makes my basilar skull fracture less likely. Look to see where the blood's coming from. Sometimes you see a lot. It's coming out of their ear, but actually it's because it came off their scalp, ran in their ear, and we had to clean those out and look for those. So we talked about earlier, airway management is important. I really want to try to prevent bad things, hypoxia, hypercarbia, but I also want to prevent hyperoxia and hypocarbia. So let's go ahead and secure their airway. Rapid sequence intubation is something we do very frequently with these patients, especially if they can't protect their airway. Usually going to start out with some nice short-acting anesthetic agent, probably for most of us, either etomidate or ketamine. Etomidate has that concern about adrenal suppression. If my patient's already hypotensive, probably not my first-line choice. In other scenarios like sepsis, not my first-line choice. For years, we were told ketamine, don't use it with head injuries. But for a lot of us, that's now our first-line agent. I go to ketamine. It really gives us really good sedation and also gives me some analgesia. It has a little bit longer duration than etomidate does. Etomidate's great because it actually may reduce ICP. It tends to have no effect on the cardiovascular or the respiratory system, but it is really short-acting, probably about 3 to 5 minutes. So definitely if I'm using paralytics or longer-acting paralytics, just keep that in mind. Your etomidate's gone within 5 minutes. Ketamine may be 15 to 30 depending on your dose. And then we may choose a short-acting paralytic. We know that using a sedation agent and a paralytic together definitely improves my first attempt success rate. And I really want to do this in the first attempt. I also want to make sure I'm maximizing oxygenation, so I'm doing my high-flow nasal cannula for the no DSAT. I'm pre-oxygenating that patient as best I can before the intubation. Succinylcholine was our choice agent for years. I like succinylcholine because it's short-acting, but I have to worry about those two things, hyperkalemia and hyperthermia. So if this patient has a known history or I'm really concerned about hyper-K, I'm not going to use succinylcholine. That's your crush injuries, your major burns that are over 24 hours. If I see a dialysis shunt, I don't have a K back yet, we're not going to use it. But the nice thing about succinylcholine is it only lasts about 10 minutes. So for most people, if I'm unsuccessful, within 10 minutes they're going to start breathing on their own. And sometimes that's something people forget about. They can't get the airway. It's either let's keep trying or let's go to a surgical airway, or maybe sometimes let's just ventilate them, let the drugs wear off, and their respiratory drive comes back. If we don't want to use succinylcholine, then my option usually is rocuronium. Rocuronium is a non-depolarizer, so I don't get those muscle fasciculations, but I don't have that worry for hyper-K or malignant hyperthermia. Rock, though, lasts a little bit longer, probably around 30 minutes for most people. Etomidate's gone in 5 minutes. Ketamine might be gone in 10 to 15 minutes or 30 minutes. So we just want to make sure we're using adequate sedation. And definitely we know that long-term sedation, long-term paralytics may help facilitate these patients. My goal, keep their end tidal somewhere around 35 to 40. We don't hyperventilate people anymore. The one time I might consider hyperventilation is impending herniation. I'm looking at this person, also they blow a pupil on me. Oh yeah, this might be the person I'm going to hyperventilate. But it's getting their end tidal CO2 down to 30, not down to 20, not down to 25, but 30. Make sure we're using good analgesia, good sedation will also help with that. But I also want to avoid hyperoxia. Hyperoxia causes vasoconstriction, not a good thing. For most of our patients, my goal would be a SAT of around 98 or 99%, not 100. End tidal somewhere around 35 or so. Think about if we've got this patient that has ICP, how all we can decompress that medically. Head of the bed's really important. If they've got a C collar on, that's fine. Get the head of the bed up, reverse to the lower board of the bed. But we can either do mannitol or hypertonic saline. Those both will pretty quickly work to reduce ICP. But think about how they're different. Mannitol and osmotic, it's going to pull that fluid out in the vascular bed. It's going to increase vascular volume, lead to hypervolemia initially, but then they diurese out. And so for trauma patients, that's not a good idea. So we might prefer hypertonic instead. Hypertonic's going to pull that fluid out, boost intravascular volume, maintain perfusion, but not cause the diuresis. So some places use one versus the other. Some places are doing a mixture of both, and that kind of balances each other out. But definitely simple things like getting the head of the bed up is really helpful, trying to keep them in a neutral inline position. But if I'm worried about ICP, let's do something about that. For some of these patients, definitely anti-seizure medicine may be helpful. Probably there's no benefit whether we use phentoin or levetiracetam. Some people like one versus the other. They both have pretty good evidence and are equally effective in these patients. And then definitely if I'm worried about anticoagulation, which unfortunately is a lot of our patients, luckily, and we'll come back to this, all of them now but one have a reversal agent. So at least can do something if we had those agents available to decrease that coagulopathy they're going to have. So our epidural bleed, as I mentioned, Arterial in nature, usually it's that middle meningeal artery. This is your classic, got hit in the head, they get knocked unconscious, they wake up, they have that lucid interval, so they're awake for a couple of minutes, sometimes an hour or two, but then they rapidly go out again. That doesn't always happen. Sometimes they get hit, they get knocked out, and they stay out. Very common with soccer players, with other contact sports. They get hit, they get that. But since it's arterial in nature, the blood rapidly accumulates and usually has that rapid change in mental status. On the CT, we're going to see this nice biconcave kind of contact lens look. Why does it give us that classic look? So this bleeding is on top of the dura, and the dura actually connects to the skull in a couple places. And so this blood accumulates between those two connections, and it can't go anywhere else. And that's why it rapidly accumulates, usually causes that rapid change in mental status because that blood builds up really fast. Where our subdural, that's venous in nature. These are usually more common. Think about your high-risk people, my older patients, my alcoholic patients. Unfortunately, as we get older, our brain atrophies. It becomes a little bit more mobile, and it moves a lot easier. Same thing in people that are diuresed very well, like with diuretics or even our alcoholics. But our older patients, our patients who fall a lot, our Parkinson's patients, those are higher risk. Venous in nature, so that blood starts to collect, but it doesn't collect as rapidly. So it may take them several hours or a day to really present. But this is the patient with that progressive decline in mental status. It may start out with a headache, a little bit of dizziness, but as the day progresses, so does their mental status. And occasionally we'll see those subacute ones or even those chronic ones, or you get that patient who falls a lot and you get a chronic and an acute subdural there on top of one another. Since this is running around the surface of the brain itself, it's crescent shaped because it doesn't have that restriction that we see with things on top of the dura. So is it that nice lens shaped or is that crescent shaped? Sometimes they have both. As a general rule of thumb, subdurals and epidurals are traumatic to prove it otherwise. If that patient has one, that is trauma. They may go, I didn't fall, they fell, they hit their head, they did something. You don't walk around and just get a spontaneous epidural bleed or spontaneous subdural. That's pretty rare. So these are trauma to prove them otherwise and treat them as such. And definitely these can cause significant tamponade effect and definitely can cause a midline shift. And we know that as this builds up that ICP, this patient definitely is higher risk for that herniation syndrome. Our intracerebral hematomas or intracerebral bleeds, those don't as classic of a presentation. So they have that head injury. This usually is some type of shear injury. It's going to be that rapid acceleration, deceleration force, but their presentation is going to vary. Maybe it's just the headache. Maybe it's just the altered mental status. Maybe it's just the vomiting or signs of ICP. There's no clear-cut, ooh, this looks like this versus some of these others. But definitely these patients can develop a significant increase in intracranial pressure as this blood accumulates. Especially these patients are on anticoagulants or antiplatelets, that tends to even compound the problem. And our biggest concern with all these concerns with ICP is herniation syndrome. Unfortunately, there's not a lot of extra space up there. I got my blood, I got my CSF, I got my brain tissue, and there's nowhere else for it to go except for down. And our most two common things that we see are usually going to be either our central herniation or our uncal herniation. That uncal herniation, as you can see there, number one, it kind of herniate on one side. Sometimes it happens on both. But this is your classic blown up pupil. You're assessing your patient, all of a sudden that pupil blows, that's the uncal herniation. They blow both pupils, bilateral uncals. Where central herniation usually goes right down the center, and that's your classic bilateral constricted pupils. We don't have a good way to look inside the brain without imaging, but I can look at their eyes. Their eyes can tell me a lot about what's going on. So can their respiratory pattern. But if I'm treating this person and I'm worried about herniation syndrome and that blown pupil starts becoming more reactive or that constricted pupil starts becoming more reactive, my interventions are working. Unfortunately, it doesn't mean this patient's going to go home in a couple of days, but definitely that's one way I can quickly assess for my interventions. But also look at those vital signs. We think about Cushing's triad. How's their BP doing? How's their respiratory rate and pattern? How's that heart rate doing? So our concussion patients, and for years we just talked about it being a concussion, and it's just a getting their bell rung. But this is not a minor injury to be just pushed to the side. Most will now refer to this as a mild traumatic brain injury, and a concussion is a non-focal injury. If I get their imaging on a CT, I'm not going to find anything usually. MRI might show us something after about 30 minutes or an hour. But for these patients, their CT is normal because this is a non-focal injury. So it's based on that clinical presentation. Usually they're amnesic to the event. They've got the headache, maybe some dizziness, some vomiting, and our favorite thing, repetitive questioning. Every 10 minutes, what happened? Where am I at? Who are you? Over and over again. That is your classic concussive syndrome. Luckily, most of these people recover just fine. Probably within 48 hours, their symptoms are all resolved. But some people may have this post-concussive syndrome, and that can last up to 2 weeks, sometimes even 3 weeks, where they have that progressive headache, that dizziness, vertigo sometimes even, but eventually the symptoms resolve. Our biggest concern with these concussions, because they are mild TBIs, is a big focus on education. This patient needs to take rest, no contact sports, no activities that are going to increase the risk of another head injury. Because what I'm really concerned about is this risk for a secondary impact syndrome. So that patient that has a head injury and has another head injury before their symptoms are resolved will likely develop some chronic long-term problems. They have some cognitive defects, their attention span changes, their IQ actually diminishes. So we really need to focus on getting these patients to understand this is not just getting their bell rung. They need to set out sports, they need to take it easy. Cognitive rest is really important. They need to limit their video games and all their electronic use. Those have been shown to worsen these conditions. And what we sometimes see in these, especially professional athletes with repetitive head injuries, is they develop that traumatic encephalomalacia. And that's something we have to worry about with these patients. So education is really important. Go home, rest. Just read a book, just enjoy whatever's going on. Try to limit both the physical and the cognitive activities, and that tends to improve recovery and limits complications from these head injuries. So as I mentioned, we do have a couple of clinical decision tools that are out there that can really help us determine who needs a CT and who doesn't. So this is the Canadian Head CT rules, and these are in MD Calc and multiple other calculators that we've talked about. So here's my exclusion criteria. Here are the people I cannot use this tool for. So those under the age of 16, they got focal problems, they've had seizures, they're bleeding, pregnancy, etc. These are the patients I can't use this tool for. But what this tool does is help me evaluate for high-risk injuries, people that have some type of intracranial problem that would benefit from neurosurgical intervention. These tools may miss minor things, but those are people that usually don't require emergent intervention. So if my GCS is less than 15, 2 hours after the injury, that's the patient likely I need to consider getting imaging on. If I suspect or know they had this skull fracture, they've got evidence of a basilar skull fracture, they vomited 2 or more times, or they're over the age of 65 or older, those people have high risk for problems. Those are the people I should image. We also have some medium risk criteria to look for. So if they've had amnesia that's lasted for 30 minutes past that impact, so I can't remember what happened 3 hours ago, much less what happened right before the accident. What was their mechanism? Was it truly significant? And they give us some details here. Those are people that are likely to have a moderate to minor medium type injury. They should also be imaged. Combining those two, these are almost 99% at picking up those clinically important problems. Again, it may miss a couple that are minor, but it's going to help us really detect that, hey, this person needs a CT. This person, no, you're great. We can just watch you for another hour or two, or we can send you home with a responsible adult. So MD Calc, as we mentioned, here's just a nice quick little blurb of it to kind of put those for you. But use these medical decision tools. Some of us may actually have them implemented in our EMR. So if I'm using head injury, it pops up and I can easily fill it in and have it put it right into my note that I use that tool to use my medical decision making. There's also the New Orleans criteria, which is very similar. Again, this was also looking for people who probably need to have advanced imaging. And so they're looking for those people that are over the age of 18, they've got that GCS of 15, as you can see, they've had that previous head trauma. We're looking for who has an abnormal CT. So based on the New Orleans criteria, if they don't have a headache, if they're not vomiting, if they're not over the age of 60, and on down the rest of that list, they don't need imaging. Again, the goal here is I'm looking for clinically significant findings. So it might miss a little something, but that's something that usually doesn't require surgical intervention. So those are 2 tools you might find useful. If you're not using them, think about using them for adults. In a moment, we'll come back to some of the pediatric ones as well. So unfortunately, anticoagulation therapy is really helpful in some patients, but in trauma, it just makes our life challenging. And it used to be simple when we had just heparin and just the vitamin K antagonist. But now we have all our DOACs, which are really good because they have a safer profile, but they really can make our life in a trauma center really challenging, and we have to work and use a lot of product to get these patients reversed. So warfarin, our primary vitamin K antagonist, it affects several factors there. And it works really well because it gets multiple parts of the clotting cascade. It has that very narrow therapeutic range, and some people are really difficult to manage, but if they're anticoagulated, they're going to increase their complication risk with trauma, especially when we talk about head trauma. Our new factor 10A and our direct thrombin inhibitors only work on one specific part, which tends to give them a safer profile and usually a shorter duration of action, which is kind of nice. But they don't have that widespread coverage that we see. As I mentioned earlier, all of our agents now, except for edoxaban, have a reversal agent. We may not always have it available because some of them aren't that cheap, but definitely they are out there for us to use. So definitely thinking about, we know that these patients that are on antiplatelets or anticoagulants, they're higher risk for bleeding, they're higher risk for complications. That might be the patient I observe a little bit longer, even if this thing says, hey, they probably don't need imaging. Or even if I've imaged them, we know that sometimes, especially people on warfarin, have an increased risk for a delayed bleed. So that might be the patient I think about observing, or if we can put them in his observation status. Those would be really helpful. There's not a really good resource for our antiplatelets. For a while, we used to give people platelets to kind of fix that, but if that drug is there, it's just going to affect those platelets as well. So most part, we've kind of gone away from giving platelets because they're on an antiplatelet agent. So we have to work about these patients, we evaluate them, think about your risk factors, use some shared decision making with these patients, and definitely it may be important to get an initial image and then repeat it in a couple hours, or do observation, or if they're going home with someone, really good education about what to look for. Luckily, we don't wake people up every 2 hours like we used to. You woke me up every 2 hours, I'd probably be mean and combative at some point too. Let them sleep. But when they do get up, how are they acting? What are they doing for those patients? Outside of warfarin, we don't have a lot of labs that can really help us. I can get my PT-INR pretty quickly. We can look at the other coagulation studies. PT tells me about my extrinsic pathway. PTT tells me about my intrinsic pathway, but they don't always help us with these other drugs. If you have access to things like TIM or TAG and can do thromboelastometry, that is where the money is, because that can really help me evaluate what's going on and determine, hey, what does this person need? Maybe they need some plasma, maybe they need some fibrinogen, but we don't always luckily have that available for us. So I kind of gave you this link here. This is a journal feed article. One of the guys I work with puts this together, but it's kind of give you a quick down and dirty synopsis of reversing all of these agents. So our head injuries in kids, as we start to wrap up this section, these can be difficult. CT has gotten a lot better nowadays. Used to, you had to sedate this kid and you're going to have to hold him still, and it might take a couple of minutes to get a CT of the head. Now, we can try to get one in less than a minute in most scenarios if we have new technology. But we have to think about the risk, because CT is not without risk. In my 65-year-old, I'm not concerned. By the time they might develop a cancer from this, probably not a problem. But in my young kids, I really need to consider the risk and benefits here. And that's when we now have some clinical decision tools that may help us. Their skull is definitely thinner than us, and one thing I really should be concerned about is anytime I see a hematoma besides up here. Frontal hematomas, they happen a lot, but the skull is at least thicker. But if that hematoma is anywhere else in the skull, those are higher risk for problems. So we need to think about investigating further. So these tools that we've got, they're not as good as we see with our adult patients, but they are kind of helpful and can really kind of help guide our care and guide the decision making. Because depending on some studies, 1 in 1,000 to 1 in 5,000 children who get a CT may develop a cancer later in life. The younger that kid is, the higher that risk is. I don't care about my older adults. They're likely not going to have a problem in 30 years. Unfortunately, they probably won't be with us. But that child will. So use your clinical decision tools, have that shared decision-making conversation with your parents or even your trauma centers if you need to. So this is PCARD. This was studied in 25 EDs across the country, had almost 40,000 children in this study. So really good data, and kind of give us some guidelines about who we should look for and who we shouldn't. Again, the goal here is looking for those clinically important problems, things that require emergent intervention. So here's your exclusion criteria again. So the people I can't use this tool for. And that's really important to know when I can use a tool and when I can't, because if it's not studying that patient population, I shouldn't be using it for that patient population. So things here, age, their trivial trauma. If we've already had a CT scan, if it was penetrating, these don't apply. So they look at the age group. Is this child 2 or less, or this child over 2? And that kind of changes some of our criteria. But for these children less than age 2, what's their mental status? Am I obviously feeling a skull fracture? How long was their LOC? And that's really hard to get. You know, it's like the seizure activity. Oh, it lasted 5 minutes. Probably like 30 seconds. So that's sometimes very subjective, but use it as part of this. How are they acting? And again, that's for the parents. If they had that non-frontal scapulohematoma, and again, what was the mechanism? If they meet one of those criteria, we should really consider getting imaging of the head. If they're 2 or older, then here's our criteria. Again, altered mental status, loss of consciousness, vomiting comes into play here. If they're under the age of 2 and they vomit, who cares? But if they're over the age of 2, now I get more concerned. If they're having a severe headache, again, what was their mechanism? These 2 things can really help guide that way, because most parents come in, they're really concerned. Hey, let's discuss it. And I actually will pull out the app and we'll put everything in it and go, here's what our evidence supports. And most of the time, that's usually successful. Combining those 2, 100% negative predictive value. Again, I'm looking for clinically important things. It might miss that little contusion. That little contusion doesn't need anything. So use these clinical decision tools to guide your care. If that parent is really adamant, we discuss the risk. Have that shared decision making with them, and I document it. If they're really concerned, consider observation for a couple hours. How's that kid acting in 2 or 3 hours? How's that kid doing after they have a nap? They're like, oh, he's sleepy. When does he usually take a nap? Oh, about right now. Take that into consideration as well. Observation sometimes is a really good thing to consider. Talk with your trauma surgeons, talk with your pediatric hospital if you don't do a lot of kids, and get their advice as well. Most time, working for one, we're happy to see them and we'll watch them there and then decide what we need to do. So again, MD Calc is a good tool. Here's just a nice little quick flow chart of looking at what PCurrent tells us about, and again, think about their age group. All right, thank y'all very much. It is time for Q&A.
That was really good. I enjoyed that.
Good.
Good refresher, too.
Gooby.
All right. Got a lot of questions. I like it. Thanks, guys.
Point you 6 feet to the left.
Y'all, if you want to head to lunch, you can. This lasts about 15 minutes. We'll be back at 1:30. So.
Somebody in the ultrasound course yesterday left this jacket. I think it's a lady's jacket. Anybody?
It had $100 in
Aha, I see somebody
Yeah.
who looks very happy.
it. Not anymore.
Were you worried about it? It's a fine jacket.
Oh, there's the owner.
Yay.
Okay.
Great. Okay, let's get started. So I noticed there were a couple questions on the first bit here about WikiM. You know, I have used WikiM. There's some people from UCLA that contribute to that, and Diane knows a few of them. So a lot of smart people contribute to that website. I think it's a useful site. There's a ton of peer-reviewed articles. There's this thing called Journal Club on there, which I found really interesting. So if you wanted to kind of check out some of the trials, some of the papers, they're peer-reviewed, could be something that might be useful for you to get involved and maybe network a little bit. So sure, WikiM might be a good choice for you if you like that layout and setup. There's also some cool EKGs on there to take a look at and an antibiotic corner. So sure, give that 2 thumbs up. And let's see, our first question here was about Toradol and avoiding the use of Toradol in a patient with red flag headaches. Is this appropriate?
Yes. Avoid. If the person has any red flags and you're sending them to the scanner, then Toradol should not be your go-to pain medication. Toradol was in my migraine cocktail for that person's like, I have a history of migraines, this is my migraine, it's a little louder, my triptans aren't working, I need something else. If I'm not scanning the person, then I think it's totally fine to give Toradol. If you're going to scan the person and you find a bleed and you gave Toradol, it's not like great practice. It doesn't look wonderful that you did that. So I would avoid any Toradol until you have a negative CT scan if you're going to scan the person. And I'm sure you're scanning people that have red flags, so I would hold on red flags and Toradol.
Okay, great. Next question, Rick. The use of elements and ROS for CMS was changed this year, and we are no longer required to document for these for CMS. Question mark, question mark, question mark.
What was it?
The changes in the documentation guidelines. this
Changes
year.
in documentation
That are new?
that are
Yes.
new.
Yeah, I don't know them.
A lot of that changed, COVID induced, and now is going to be continued. So I think part of this was part of the COVID, like, give you guys a break kind of thing. But I think a lot of the changes have happened as a result of that. And I was looking them up from that question, and there are definitely changes that we'll have to update those slides.
Okay. The chief complaint will always be required, just so you know.
And there's
Definitely.
changes as far as who needs to review what, and so it is different than it was.
When was that?
this year.
Okay. Oh, and just a reminder, the live stream is now up and running.
Yay.
So you can tune
Lie
in.
back in bed, put some pillows underneath there, get the drinks from the bar, and watch the show.
So I put up a really interesting article about orthostatic vital signs, but there were a lot of questions about why are we still doing them then? Why? So Diane?
I don't know. It's actually, and part of the problem is that I think one of the things we learn a lot on the cutting edge of things is we have to, right? We just have to. It's part of what we do. But to translate that into what is an ingrained practice in certain specialties and their own sort of feeling of their requirements is a hard thing to do. And I think all you can do is educate and just explain why certainly you'll do it. But if it's not positive, you're still worried about an ectopic, even if they're, orthostatics are fine. So just, I think, explaining sort of how you do it. And then, I don't know why we're still doing it. It just makes me crazy.
I think it's I'll be down there. I need a little bit more
I-
time.
well, no, I think
know
that's
that. I
true.
heard you
Right.
saying
Yeah.
that. It's the delay. It's like, I always like to ask,
And
if
what?
it's negative or positive, does that change anything?
Yeah.
And the answer is always no.
Exactly.
But it's
at
a
least that's
delay.
planting a seed.
Yes.
And I think that's a non-confrontational way of saying, honestly, if it were negative, would you? I would still be worried about an ectopic. Would you? Well, yeah. And then you don't have to then drive it home. You could just point made. Okay.
I think this is a good time to kind of reflect on the fact this is not worth having an argument with someone about. Like, if someone asks you to do them and they really find it important for them to do, I would say, okay, sure, I'll get those done for you. Not that big a deal.
You could say, sure, I'll get those worthless tests done for you. Maybe, and then they'll get the idea that maybe they're not a good idea.
Yeah.
And actually, a couple studies have looked at them and found that probably most people have to be at least over a liter down before they're ever positive. So they can still have an ectopic and
Well, and
bled
each
out a
person's
little
different.
bit and not have that positive test.
My favorite study that showed me how stupid they are, they did at our institution when I was a resident, where we were volunteers. Yeah, I'm not so sure, but we donated blood. So my entire residency class donated basically a quarter of our blood volume. And then they looked at what happened to us. It was a third actually of our blood volume. And about a third of us got hypotensive and tachycardic. About a third of people got hypotensive and bradycardic. One person passed out. It was just, there was no prediction.
What'd you
at
do
all.
with the blood?
Oh, we donated it. It was
Oh, you
donated.
donated it?
Yes.
Nice.
Yes.
Okay. Wasn't
It was a win-win.
auto-transfused back into you?
No.
Okay.
But we got cookies.
All right, I like this next question. If a patient is on blood thinners and they have a negative CT, normal observation period, do you typically have them hold their anticoagulant for a certain amount of time?
So I think there is a good question. We had to look at what are they on the anticoagulant for? Because we know that unfortunately, especially on the DOACs, holding that 1 or 2 doses increases the risk for getting a thrombus formation.
Yeah.
So I think we need to look at and have that shared decision making. You may even discuss it with whoever's following them with their anticoagulation. Is probably for your vitamin K antagonist, holding a day or two probably fine. Now, obviously, if their INR is elevated, we should consider that anyway. But we know that holding that anticoagulant for 1 day might increase their risk. And just need to look at that risk and benefits. And definitely that's the patient we're bringing in and they get to deal with it on the inside. But having that shared decision making, decide, hey, what's the risk here? Are they going to get a clot in the next 24 hours if we have them hold a day? Or are they going to bleed, which is higher? And that's not a really good answered thing yet.
Yeah, well, everybody knows there's the right, that's just
Yes.
logic. I mean, I think it's a very logical
Yeah.
approach.
Yeah, there are a couple interesting studies on this as well. I'll put some links in there to them. And again, the shared decision making is definitely a good way to look at it. All right, next question. Did I star this one? Oh,
6 to 12 hours.
so
6
how
to
many
12
hours
hours.
to see xanthrochromia and CSF? And you guys can answer.
Yeah, so this has
one.
actually been studied. So this is kind of one of those studies that what they did is they took blood and CSF and they put blood in the CSF and then they watched to see what happened. And it took 6 to 12 hours to get xanthochromia, and then the kicker here is xanthochromia measured how? So xanthochromia looking at is what we all do. Xanthochromia, at least the early studies, was spectrophotometric, which no one does. And so you have to be very careful how you interpret what you read about this. Like, when did it actually become something you could see? And you have to assume that's what's happening in a human when that happens in vivo in them. So with that all as caveats, it's probably 6 to 12 hours. 24 for sure, it should be there if there's enough to get visible xanthochromia. So.
Okay. Somebody really wants us to talk about central vein sinus thrombosis. The fact that it is not at all that rare and should be mentioned. Not the same as idiopathic intracranial hypertension. Well, that's true.
Yes. I might
Yes
argue,
and no.
though, it's pretty darn rare.
It's rare,
It's
yeah.
like super, super rare. And honestly, with the whole J&J, my gosh, everybody comes in with a headache and they are absolutely convinced that they have a sinus venous thrombosis. And I've ordered 2 since J&J has been out, and both have been negative. And I'm fairly confident I have not missed one. I mean, I may have, but it's also a really hard diagnosis to make, and I do think it's totally worth talking about, especially how it's become such a common thing that people are really worried about getting vaccinated. Although the risk is like maybe
Tiny.
ever so slightly higher than just like baseline normal. It's a very challenging diagnosis. It's not going to have any classic like sudden onset, thunderclap headache. I think the thing to look out for, and you're already going to get imaging in these people, is if they have a neurological deficit. Their risk factors are the same for anyone clotting. If they've had recent surgery, if they're pregnant or postpartum. Pregnancy, honestly, I think is the most common time you're going to see this, or the high risk postpartum period. So if I have a pregnant patient who's coming in with a new weird headache, that's who I'd really be concerned about. But other than that, I mean, it really isn't that common. And there's always the kind of, do I do a CT, CTV, MR, MRV? Everyone's gonna say MRI is always better, but a CT venogram is actually pretty good too. So I think if you're really concerned and they have these high risk features and they have a neurological deficit, yes, you should go down that road and think about it. But it's not fair. I've actually never caught one. Maybe in a cancer patient, I think once in residency, but that was like one time. I think the highest risk people are the postpartum pregnancy people with a new weird headache that's not a normal headache for them. That's who you should really be thinking about.
I've had one in the last 3 years, and it was a pregnant patient.
Yeah.
She
Yep.
was OB.
I think this
that's what led us
idea
down that
came
pathway.
from there's been a lot of searching and digging around to figure out what was pseudotumor, now idiopathic intracranial hypertension. Like, why does that happen? Why does that happen? And so there was a lot of sort of searching around. Are there problems with the drainage system? Could it be that they have a clot that's causing some trouble? And there was, I have to look it up because I have it somewhere I'll look it up. But there was a study that basically, it was teeny tiny. It was like, we had 3 cases of people with idiopathic intracranial hypertension who also had a clot. And could this be something we're missing? And that took off like a shot. It was like early misinformation. It took off like crazy as people thinking, oh, we need to rule it out. It's sort of like the PE study that everybody hospitalized needed to get, who had syncope needed to get ruled out for PE, which is baloney. It was all anyway, it was baloney. So I think this is something that kind of took off and had a little life of its own that has died for the most part. And I think Britt's sort of summary of it all is where we stand now with this.
Okay. Next question is, how many liters of O2 would you give for a patient with cluster headache, and for how long? Any contraindications or concerns about oxygen toxicity?
So I mean, you can just put them on a non-rebreather. I think that's probably the easiest, and that's usually set to 15 liters. There's no real magic here, and I think the toxicity really doesn't become an issue because these headaches shouldn't be lasting for hours, and so you should see resolution of their symptoms within 30 minutes, 45 minutes. It should already be helping. If it's not, then you might need to go down the road of rethinking your differential, and maybe this headache is something else. Helen? Was it Helen? Oh, Helen asked this really awesome question about cluster headaches, and how do you tell if you're working in an urgent care and you don't have a tonopen that it's not glaucoma, which I thought was a really, really interesting question, because if you don't have a tonopen and you can't measure the intraocular pressure, with somebody with such bad pain around their eye, you could really think that this might be glaucoma. And again, I think it's like, if you're going to have to transfer to the ER, it might be a treat with oxygen, watch and wait. If it's not improving, then I would be more concerned about something like glaucoma. But again, this shouldn't last more than about an hour-ish.
So acute narrow angle closure specifically, I have had it twice. I've had 3 iridotomies done. You have other symptoms, and I can tell you as a patient that has experienced it, it is just a different type of headache. I have had migraines as well. The nausea and the physical ocular changes that occur are very evident. So when you're seeing a patient like this, it's once you see one, you know one. And the pain is just such a stabbing, severe, someone is trying to murder me kind of pain. Just so you know.
And then usually with glaucoma, the eye itself is really firm, not always the best.
Yeah, it's
but if I push on it and
tense.
it's squishy like the other one, that's pretty reassuring.
You need
if
to-
your pupil's not reactive or not as reactive, and sometimes it even gets distorted. I think everyone I've ever had, I would just try, and you can just feel it. It was really firm
Super
compared
firm.
to the other eye.
What's your name again? Helen, why aren't you using the Shiat? Huh? You should be getting there and with the anybody still use the Shiat?
Shots?
That's when you just pull out your ultrasound, right?
Or, hey, yeah, you could do that as well. But,
But I mean, I also agree. If you're in an urgent care and you don't have any of those tools, the touching the eye thing, we talked about, because I asked an ophthalmologist this. I'm like, can I just push on the eye? And he's like, yeah, I could push on the eye and tell the difference. Could you? And I'm like, I mean, so I think it is much more sensitive test. And I mean, if you're just like, if you don't have anything else, I think it's a good go-to, but I wouldn't, if I think it doesn't feel hard, I don't know if I'd like totally hang my hat on like, okay, that's not glaucoma, but I think it could be a quick and dirty test just to see like, oh, it's rock hard. Okay, now I'm really worried about glaucoma.
yeah.
In the right hands though.
Yeah,
Maybe not mine.
My eye felt
That was
like
a very
golf ball.
gentle way of him approaching that with you.
It-
That was nicely communicated.
Yeah.
I do it, yes.
One other thing about the oxygen, the National Headache Foundation says that the headache really should improve with the non-rebreather within about the first 15 minutes. So you should be able to see something quite quickly. All right, next question. Shiats. TXA for isolated TBI.
So I think if the patient has a head bleed, that's a consideration. It hasn't, as far as I know, been really well studied looking at patients that are on, say, anticoagulants and looking for just the protective value for reducing the risk of a bleed. We know that in some patients, especially with multisystem trauma, it does tend to reduce the risk for need for transfusions and may improve mortality. But specifically just for the isolated TBI with no bleed, I don't think that's been well studied enough to give a good answer.
And with the bleed too, it's such a hot topic in EMS about like giving this TXA prophylactically when you are very concerned for a bleed. The literature, I feel like it keeps going back and forth. I think most of us are settling on if you do it within 3 hours.
It has to be 3 hours.
Yeah, it has to be 3 hours. After that, it's really not all that helpful and maybe more
harmful.
dangerous. But this is a huge topic in EMS.
Crash 3 is the one that kind of threw it all out in the whack. We all thought it was clear, and now it's not at all. So if you do it, though, don't do it outside a 3-hour window, because it's already controversial enough that you'll get yourself in trouble.
Okay, some of you were asking about the occipital nerve blocks. There's this great video Diane and I were looking at. We don't even know this guy, but I watched the whole video. Really informative link that I posted. I wish I had made this video. Using ultrasound guided about 2 to 3 mLs of bicarb and lidocaine or bupivacaine. He finds the occipital nerve, he makes sure that he avoids the occipital artery and vein, and then shows you how to inject. It looks so easy, I might just do it for fun, honestly, on myself. So,
But and it's that I think doing it with the ultrasound is of course like always safer. But I think some people might not feel as comfortable with the ultrasound, and I still think this
don't
is
let that deter you.
yeah.
right. This
Don't,
is
don't let it deter you.
a femoral nerve block. You can't do that blind. But an occipital nerve block, that is something where if you just feel like we were talking about, like almost like a trigger point injection, this is one that with or without ultrasound, you really can't go wrong. So I think the ultrasound is super, super helpful. And if you are savvy with ultrasound, awesome, use it. But it's not something that should keep you away from doing this nerve block.
And prone your patients to do this. Don't sit them up there like this, like hunched over, because as soon as you put that needle, they're going to move forward and mess everything up. So just get them comfortable, prone them, make sure you're not suffocating them. Good procedural pearl always, don't suffocate the patient. Okay, we really wanted to get to this other question because we're running out of time, and I think it's really important that we discuss it. If you have to, like absolutely have to, intubate a DKA patient, would a bicarb drip be warranted because of the inability to match their respiratory rate? Go.
So the word there I'm going to remove is drip. So the bicarb drip is to treat DKA. Intubating an acidotic patient is an entirely different story. So DKA is over here, and we've decided clinically that this DKA patient is so sick, we need to now move over here into our intubation brain. And our intubation brain says acidosis will worsen when I paralyze someone because they stop breathing, their CO2 starts to climb, they add a respiratory acidosis to their metabolic acidosis, and they crash and burn. The goal here is I have to do this. My intubation brain says there's too much acid here. I'm going to, quickly and temporarily, buffer that with just pushing amps of bicarb. 1 or 2, we were talking about this, which no one has a magic answer. I usually grab 2 if they're super sick, and then just push it. And what that's going to do is in that short amount of time, while I'm putting the tube down and then can bag them again and get their CO2 blown off because I'm doing it, that gives them the buffer there. It's not anything you continue later. So it's 2 separate bicarb concerns. DKA, I'm still not going to use it. But for intubation, because I need to buffer that acidosis temporarily, I will.
And sorry.
No, go ahead.
Oh, I was going to say, the AMP of bicarb doesn't last very long in their system anyways. So it's really only for those minutes of paralyzing them and tubing them. I mean, I think of all the intubations that we do, this is by far the scariest. It's not like the bloody trauma airway or maybe angioedema is pretty high up there, but this one is like these people code. The second you paralyze them, that little drop in their pH and they arrest. And so this is like the only time really where it's those amps of bicarb that actually get you through a few minutes to safely intubate them. And then I'm sure Diane probably already talked about this, but matching their respiration. You can't just set the vent for 16 and walk away because then you...
Yeah, that's a post-intubation management thing, which we didn't get into because we didn't get into intubation, but yeah. No, but you're right. So you have to then recreate the patient, basically.
Take that minute to watch their rate and figure out their minute ventilation. So as soon as you can, that rate is at 40 or 45, and use your end-tidal CO2 to really help guide that.
And that's something you have
Because
to
they will
educate the RT frequently about, just because they're like, what? How fast? It's like, no, really, it's really 40, like go. Yeah.
And if I can avoid long-term paralytics, avoid them.
Gooch is like the vent master. So if you have any vent questions, talk to this guy. He is really good at knowing that stuff from flight medic and you were an NP when you were flying too, right? Yeah. So, yeah.
This also is a really fun time to do an awake intubation and avoid the paralytics altogether, but that's maybe a deeper dive topic.
Yeah.
Don't you dare try that on me.
Sorry.
It'll come up later too, but aspirin toxicity is another one.
It is.
Any of those really bad gap acidosis.
And the toxic
we
alcohols.
Try not to.
Yeah.
'Cause it's so bad.
That's a great pearl, all of this. So good question to end on. We'll see you guys after lunch, which will be at 1:15.
1:30.
1:30. You have till 1:30. See you soon.
Okay, I have to remember to stay in my box. All right, so another super easy topic to cover in 30 minutes, TIAs and strokes. I think that the biggest thing to remember about this is it is a ginormous and very controversial topic. We are going to cover kind of basics and initial approach to diagnosing TIAs and strokes, management, treatment, and disposition. There is another advanced boot camp course that will go into a deeper dive on this topic and really get into all those controversial issues of TPA, blood pressure control. I mean, you name it, this topic has everything controversial that people really like to argue about and finesse. So I think another really important point is that every hospital, whether you're a stroke receiving center or not, is probably going to have a protocol and algorithm for your stroke patients. And by and large, they're all going to be pretty similar, but I think it's really important to know your particular hospital's policy, algorithm, and procedures for working up stroke patients. Some of which would be, if you're a stroke center, is neuro in-house? Is neuro going to call you? Is neurostroke going to appear on an iPad? Do you have MRI 24/7? Or I work at a hospital that's a stroke receiving center, but we don't have MRI overnight and on the weekends. So that definitely will affect your approach and management of these patients. So big basics on TIAs and strokes. So there's two major types. There's ischemic and hemorrhagic. Ischemic is by far the most common. And there's two types of ischemic. You can have thrombotic strokes where a clot forms in the vessel, or you can have an embolic stroke where a clot flicks off from somewhere else in the body and goes up to the brain. Typically, that's going to be somebody, say, with like atrial fibrillation. They get a clot in their left ventricle, and a piece of that flicks off and goes to the brain, and you get a stroke from that. Hemorrhagic strokes, they're less common. They're very devastating. We'll talk about them a little bit in here. And then vessel dissection. This is a very rare cause of a stroke, but I think a really important one to at least mention. I actually had this is someone you got to think of in younger patients with vertigo. And around Halloween, I had a patient who had told me she was having some neck pain and kind of had this weird feeling in her right arm, but maybe she just pulled a muscle. But when she stands up, sometimes she's kind of just dizzy, and she doesn't know why, and she just wanted to make sure everything was okay. The resident's presenting me to this patient, and they're like, oh yeah, she just like strained a muscle, slept weird, it's probably fine. But then when you talk to her, she had recently been going to like all these like Universal Studio horror nights, and essentially, with all these monsters jumping out from everywhere, gave herself whiplash multiple times. We got a CTA, and she had a vertebral artery dissection. Super easy to miss, but really keep it up there on your differential when you have a young person with vertigo that you just really can't explain. Like, okay, maybe you tweaked your neck, but why are you dizzy? Like true vertigo. So again, very rare, but important to think about. So when we talk about strokes, we really need to know, for an ischemic stroke, what blood vessel was affected. And based on what blood vessel is affected, we should see a certain constellation of symptoms. So when we look at circulation of the brain in general, there's anterior and there's posterior. Strokes in the anterior circulation are a little bit more common than posterior. Our anterior circulation is made up of the carotid arteries. They give off the middle cerebral arteries and the anterior cerebral arteries. The posterior circulation is made up of the vertebral arteries. They come together to form the basilar artery around the midbrain, and then they give two branches to form the posterior cerebral arteries. That's the posterior system. So again, based on where this clot is and what artery it is, we should see a certain set of symptoms. So when we look at middle cerebral arteries, TIAs and strokes in this distribution, these are probably the most common place that we see ischemic strokes. And what you should see is, if I have a left cerebral artery stroke, or left middle cerebral artery stroke, I should see symptoms on the contralateral side, so on the right side. And typically, this is going to be affecting your face and your arm, and less likely affecting the lower extremity. When you look at the face, it's really important to look for asymmetry, right? They can't smile, but they should actually be able to lift their eyebrows. It spares the forehead. Now, when we see the forehead and the lower part of the face next to your mouth involved, that's probably more of a peripheral problem, like a Bell's palsy. But if they really are just droopy at the side of their mouth, that's concerning for a middle cerebral artery stroke. So we're seeing symptoms on the contralateral side. So if I have it on the left, I'm going to see symptoms on the right. It's going to be more in my face and my upper extremity. And then what's really interesting, when you see people that have a massive middle cerebral artery stroke, they actually look towards the lesion. So if they have that lesion on the left, their eyes are deviated up towards the left. They're like kind of telling you, like, it's there, please get it, please give me something to help. And depending on what side of the brain it is on, right or left, they may have more involvement with their speech, usually if that's on the left. So this is a kind of a picture of the brain with that homunculus, kind of their legs dangling over, their body dangling over the brain to show you what parts of the body are affected by a certain part of the brain. So when you look at the middle cerebral artery, that you can see is affecting more of the face and the upper extremity, and that's why we see symptoms predominantly there. This is just a CT of a horrible ischemic MCA. Again, you see kind of this darker area where you have a lack of blood flow to dead brain tissue. And remember that this is the opposite of what we would see for a bleed, because bleed is white on CT. Okay, anterior cerebral arteries. So anterior cerebral arteries, again, contralateral symptoms. If I have the stroke on the left, I'm going to see symptoms on the right. I'm going to have motor weakness. I'm going to have sensory loss, just like we saw with the middle cerebral artery, but this time I'm going to see symptoms predominantly in the lower extremity. And again, when you, going the wrong way. There we go. When we look at where the blood supply is for that part of the brain that the anterior cerebral artery perfuses, you see that on that homunculus, it's mostly affecting the lower extremity. All right, posterior cerebral arteries. So this typically is going to be more visual problems. If you have a stroke on the left, you're going to see loss of vision on the contralateral side. On the right, this, I don't know if anybody's ever seen this, but have you heard of visual agnosia? There's actually this awesome 60 Minutes on it. I think I watched it way long time ago in med school. But essentially, these people, they can't recognize objects. So there's this famous book, like The Man That Mistook His Wife for a Hat. That's visual agnosia. And I think on the 60 Minutes, they show these people with this deficit, and they show them faces, and they'll show them like Obama and Jennifer Aniston. And they cannot tell the difference at all. They can tell that it is a person, but they can't define these specific features of objects. So that's probably not something you're going to diagnose in the ER, but maybe it's somebody that has had this stroke that has this symptom. All right, vertebral basilar strokes. So this is posterior circulation again, and this is, again, these are like the dissection that I was talking about. This is the vertebral arteries. This is posterior. They get a lot of vertigo. They get a lot of nausea, vomiting, and truncal ataxia. Lacunar TIAs and strokes are a little bit different. These are much smaller vessels. They're little branches off of the middle cerebral artery, and they supply deeper parts of the brain like the basal ganglia and the thalamus. Sometimes, because they're such little vessels, you might not, and the patient might not notice that they're even having symptoms. It's usually not until these accumulate multiple over time that you start to see more of like a cognitive and physical decline. Now, if you get a big one, you can get a pure motor hemiparalysis known as lacunar syndrome. Okay, TIAs. I think it's really important to take a second to actually kind of define what a TIA is, because it's changed a little bit over time. By definition, it is an ischemic event that happens to your brain that causes transient neurological symptoms. Now, we used to kind of think, well, if it resolves, within 24 hours, then it was probably just a TIA and your brain tissue's fine. But we actually can't say that anymore because time doesn't necessarily dictate whether or not there was infarct to brain tissue. So before you say this is just TIA based off the timing of symptoms, you have to get imaging. You have to get a CT and MRI. If they had transient ischemic symptoms and have no infarct on imaging, then it was a TIA. But if there's infarct on imaging, that's no longer a TIA. So the key here is you can't define it by time. You have to get imaging to look for that infarct, or the presence of the infarct or not. In general, TIAs will be very short, 10, 20, 30 minutes. And really making this diagnosis is completely based off of history. Because by the time they get to your facility, they look great. They have no symptoms. They tell you, you know, an hour before I got here, I had this really weird episode where I'm like, my face felt heavy and I was holding a cup and I couldn't really grasp it anymore, but now I'm fine. That's a good history for a TIA. Some symptoms that are not a good history for a TIA or stroke are things that are more global. If somebody gives you a focal deficit, you got to go down the road of thinking that this is a stroke. But when they start saying things like, well, my grandma's just acting confused, she's just feeling really weak, less likely a stroke and more likely maybe an infectious process, urosepsis, an electrolyte abnormality. But when things are described as more global, it's less likely a stroke. So mimics. There are so many mimics of TIAs and strokes, the big one being hypoglycemia. And I think when you're assessing anyone with a neurological deficit, whether it's a TIA, a stroke, a seizure, glucose is just one of your vital signs. You always want a full set of vital signs plus a glucose. Just get that, because I have heard many stories of people intubating patients with hypoglycemia, not realizing that it's hypoglycemia. I've certainly sent people to get a head CT and call a code stroke, and then I get a call from the lab like, oh, Dr. Guest, their blood glucose is 25. And you're like, well, damn it. Okay. Should have checked that before I sent them to the CT scanner. So that is a really, really, really common mimic of TIAs and strokes. Another one which we kind of touched on with migraine headaches is a complex migraine headache. I absolutely have almost pushed TPA in a person with a complex migraine. I learned my lesson. I didn't push TPA, but I was very close to doing so. And it's so hard. It's like the trickiest one because maybe they're telling you have a headache. Strokes could have a headache, but they have like a dense neurological deficit and they can't move their left arm. And for everything in the world, it looks like a stroke. So again, imaging and good history is so important. Other things that are really common that can mimic strokes is anything with the middle ear, so benign paroxysmal positional vertigo, Meniere's, anything that gives you vertigo, especially in an older patient, you got to think a stroke. It might be a stroke, it might just be a middle ear issue. Okay, so how do we evaluate these patients? If it's a TIA patient, obviously, we're doing a good history. We're doing a complete neuro exam. And I think this is where I bring up the bed neuro exam and like the full neuro exam. Because if you have somebody with a posterior stroke and their main symptom is dizziness, they're going to have 5 out of 5 strength in upper and lower extremities. Their sensation is going to be normal, their cranial nerves are going to be intact, and they're talking clearly to you. It's not till you get them up and walk them that they're like, whoa, truncal ataxia falling to the right, that you would have never picked up if you didn't walk them. And I think that's a common thing that we kind of forget to do, or we're in a rush and it takes too long to get them up and like get everything disconnected, but it's worth the time because they really can be hiding a very important finding that helps you diagnose whether or not this is a stroke. Okay, so just like our stroke patients, they're going to get a rapid glucose, you're going to get an EKG. EKG, again, can be very helpful. You might see signs of ischemia, you might see signs of AFib, and then you're going to get them to a CT scanner. Because again, even if they have completely resolved symptoms, if you're concerned for a TIA, you've got to look at imaging to make sure there's no infarct. Blood pressure, super controversial. I think we'll talk about it a little bit in a couple more slides when we talk about strokes. In general, I don't rush to drop anyone's blood pressure. And if I want to decrease their blood pressure, I don't do it rapidly. I think that's the big, broad take-home point. If you do it slowly and give them a time to I will say, go to the CT scanner. Their blood pressure is really high. Go to the CT scanner. By the time they come back, recheck it. You just rush them in here, call to code stroke, have a million nurses around them, stabbing them with needles. I'd probably be really hypertensive too. So I think let them settle, get the CT scan, reassess. If you get that CT scan and you see no blood, then I would go ahead and start aspirin. So what do you do with these people? They look great. They have no deficits. They're walking, talking, have no symptoms whatsoever. So that makes it feel really weird to admit somebody that literally has no complaints right now. But for me, and again, I would check with your hospital protocol and policy on this, but I admit all my TIAs. And I'll tell you why. They have a very, very high risk of having a bigger stroke very soon. So 1 in 20 will have a stroke within 48 hours, and 1 in 12 will have a stroke within a week. And I don't admit them to like wait and catch their stroke. That's not what you're doing. It's great if you do, I guess, if they're inpatient, that's a safe place for it to happen, but that's not the purpose of admitting them. The purpose for me of admitting them is to optimize all their other medical problems to decrease their risk of having a stroke in the future. So if they're diabetic, get their blood sugar under control. If they're hypertensive, get their blood pressure under control. If they get a lipid panel, start them on a statin. Optimize all these other medical problems to decrease that risk of stroke because they're already at such a high risk of having a stroke pretty soon after this TIA. Now, your hospital might use this ABCD2. My hospital doesn't. It might be something that you'll hear about, so it's probably good just to review. This criteria is, if somebody has a TIA, do I think they're super, super high risk for having a stroke or lower risk for having a stroke? And if they're super high risk, then I'll admit them. So it's based off of A is for age over 60, B is for blood pressure over 140. I would not memorize these. C is a real stretch here, but clinical features of a TIA. Was it over 60 minutes? That gets you 2 points. I'm sorry, that's the duration. Was there unilateral weakness? That gets you 2 points. Was there just some speech issues? That gets you 1 point. Duration, if it's over 60 minutes, 2, less than 60 minutes, 1, and then the D2 is diabetes. If they have diabetes or not, that gives you a point. It's not reliable. It's really not a great way to assess who needs to get admitted. If your hospital uses it, then it's worth knowing. But again, for me personally, I admit my TIA patients. So when you admit them, what kind of workup are they gonna get? They're gonna get an echo. And what's important about the echo is, well, one, we wanted to see if they had atrial fibrillation. 2, we wanna see, do they have an interventricular clot? And that's just throwing off all this little emboli that's causing these TIAs. And 3, we want to know if they have a patent foramen ovale, because that is basically a connection between the right heart and the left heart. And you constantly have little bits of blood clots going around, nothing that's causing a DVT, nothing that once it gets to your lungs causes a PE. Your lungs just filter these kind of things out of your blood all the time. That's normal. But if you have one of these little clots, and now you have a connection from the right to the left heart, it's very easy to go through that little connection, go straight up to the brain, and get a TIA. So that's really what they're looking for on echo. They'll also get carotid studies to look for carotid artery stenosis. They might do this with Doppler, CTA, MRA, and that's kind of what they're doing within the hospital. I don't know much about the stroke, but apparently this area is a higher risk. If you work in that area, maybe you see more stroke patients. Okay, stroke presentation. So this is the patient with a neurological deficit right in front of you. Now, time, just like with a STEMI, time is brain. And so many times, I work at a couple stroke centers, and the triage nurse activates a stroke before I even get to see the patient. I'm like running to the CT scanner just to see the patient, get a gross neuro exam, see what the deficit is, ask the onset of symptoms. Onset of symptoms is absolutely key, and are they on blood thinners? Those are kind of like what I do, and I look at the vital signs, and then I run out, or I'm gonna go through the scanner with them. They're already getting a CT scan that fast at most places. Now, another hospital that I work at, we actually have access to MRI available very rapidly, 24/7. So rarely, this is like special situation. Some patients will go straight to MRI, but I think most facilities that you'll work at, it's CT and then MRI. Check that blood glucose. It's a vital sign. Always get the blood glucose, because again, hypoglycemia can mimic strokes very frequently. Now, if they're not stable enough to go to the CT scanner, they're not going to be rushed there. They're going to be rushed back to your resuscitation bay because they've got a massive stroke, or they have a massive bleed. It could be ischemic or hemorrhagic, and they need airway intervention. They need to be tubed, they need control of their blood pressure, and you need to stabilize the patient before you get them to the CT scanner. Okay, so exactly what we were just talking about. Check the glucose, check the vital signs, do a neuro exam, get them to the CT scanner, put them on oxygen if they need it, and get a 12-lead EKG. All right, to blood pressure. So again, in general, check an initial one, get them to imaging, check them when they come back. Again, if it's really high, like we're talking in the 220s, then we gotta start lowering that. Never use an oral medication. You want to use an IV medication that's fast on and fast off. You want to easily titrate this because you don't really know where this patient's blood pressure is going to go. You don't know where they normally live. And you want to go slow. You don't want to drop them too quickly. So if you use something that you can add, but it's not going to last for an hour, that's ideal because they might need more, they might need less, they might drop a lot faster than you were expecting. So in general, my go-to is labetalol. That's just what the pharmacist in the ED always has. I'll just pull up 10 of labetalol. I'll give them 5, watch it for a second, give them another 5 if I need to. Now, the only caveat with labetalol is, remember, it's a beta blocker. So some of these patients are already on beta blockers, and their heart rate is already going to be pretty low. So you don't want to give them another agent that's going to make them more bradycardic, because that's going to worsen things. So if they're already a little on the bradycardic side, then I usually turn to something like nicardipine. Again, fast on, fast off, easy to titrate. So if it's an ischemic stroke, we usually tolerate a little bit of a higher blood pressure. We're still trying to perfuse that ischemic brain, so we'll let the blood pressure ride a little higher. Usually my cutoffs, like when we're starting to get to the 220 area, we really need to lower it. If the person is a candidate for TPA, then we really need to lower it because you have to have their blood pressure less than 185. And that's because if they're really, really hypertensive and if you give TPA, they're at a much higher risk of having hemorrhagic complications. I'm going to kind of go through this a little bit so we can get through some more of the material. Again, hemorrhagic stroke, sometimes you'll tolerate a slightly higher blood pressure. You can ask probably 5 neuro-stroke doctors and get 20 different answers on what the ideal blood pressure is. I would say in general, shoot for somewhere around 180. If they came in a little lower, 160. There just really isn't a magic number here. I think key is just don't drop them too quickly. Use something IV that's easily titratable. Okay. So if it's hemorrhagic, that's our fork in the road, right? We got to get that CT because we need to know bleed or no bleed. That's our big first question. If there's a bleed, this is a much different algorithm, right? You're calling your neurosurgeon or you're transferring them to higher level of care. They need to be dealt with by a neurosurgeon. Now, if you don't see any blood and this patient is within the window of getting TPA, now you've got to start considering, is this person a candidate for TPA? I wouldn't memorize all this. It also kind of changes pretty frequently. The inclusion criteria is easy. You have to have an ischemic stroke. The hard thing is you can't have too, it's like that Goldilocks. Your deficits can't be too small, but they also can't be too large, because if you have really bad deficits, you also have a risk of hemorrhagic complications. So you have to be kind of in the sweet spot. The window is now, for most places, they'll use 4.5 hours, and they have to be older than 18. Now, the exclusion criteria is extensive. They can't be too old, their stroke can't be too severe, obviously their symptoms can't be kind of waxing and waning or improving drastically, they can't have surgery recently, a history of brain bleed. There's a very long list. I would have it in your back pocket, have it on an app on your iPhone, but I wouldn't try to memorize it. The most important thing is you can have all the algorithms in the world, but when it comes to deciding if you're going to give TPA, this is a very individual, personal decision. And it's so, so important to sit down and you gotta have this conversation with the patients or the patients' families if they're not able to communicate at the moment. 6% of patients will get worse, 12% of patients will get better. It's really, you just got to sit down and run through these risks and benefits with the patient and their family. I think this is a really great script for having that conversation, basically summarizing, you know, we have this medicine, we think it's beneficial within 4.5 hours. 1 in 15 patients will have hemorrhagic complications, which can be fatal. And you really just, it's just a very personalized decision, whether or not this is right for this individual. So again, all the beginning of our stroke is tons of algorithms, right? When was the onset of symptoms? Are you on blood thinners? Get you to the CT scanner. Like, this is all algorithmic. But once you get to this point, it's a very difficult conversation sometimes. If they decide that they are a candidate and they want to get TPA, so this is how we dose it. It's alteplase, it's 0.9 mg per kg. The first 10% of that total dose is given as a bolus over 1 minute. The remaining amount of that dose is then given over 60 minutes. Hopefully within the 60 minutes, they're up to a neuro ICU or out of your department and somebody else is managing that. But really important to be watching this person super closely and assessing for any potential hemorrhagic complications. Okay, endovascular therapy. This is a super hot topic right now. At UCLA, we have the ability to do this. Some of the big stroke centers do. A lot of stroke centers, I work at some smaller community hospitals, we don't have access to this, but you need to know about it because some of these patients might be candidates and then you need to transfer them to those centers that do this procedure. This is, you're not in that 4.5 hour window. This is somebody, they can present, sometimes they'll do it up to 24 hours. So I think the caveat here is when you go send that person for the CT non-con, if there isn't a huge delay in care, get the CTA as well, because the CTA will show you if there's a large vessel occlusion. And that's really what you're looking for, is a large vessel occlusion. Now you're gonna have to talk to your neurostroke team and really go through the fine details if this person meets criteria for an endovascular therapy, but the first step there is it a large vessel occlusion or not? And that's what you're gonna get from your CTA. So yes, the right answer is coming in with stroke symptoms, go get your CT non-con, but I think that if you finesse that a little bit, it's also get your CTA non-con and your CTA head and neck and look for a large vessel occlusion. And again, just remembering that even though they weren't in that 3 or 4.5 hour window, the window for this is much larger, and some facilities do it up to 24 hours. And I think with that, I'm gonna wrap up stroke. There's some key points here. Of knowing the different stroke syndromes, so knowing the blood vessels and what part of the tissue they perfuse and what symptoms you expect to see when there's a clot there. TIAs are not just based on time, they're based on tissue damage. Things can be transient and resolve pretty quickly, but still cause infarct, so you really need to get imaging. That timer is definitely on. The second that person gets into your department and they have stroke symptoms, my 2 main questions are, when did it start and are you on blood thinners? Most of the other things, we have a little bit more time to suss out there, but I'm gonna get a call really quick from my neuro team once I activate a code stroke, and those are the 2 things they're gonna wanna know, because that timing really will dictate what treatment they're potentially a candidate for. Okay, I hope that was helpful. Strokes in 30.
Problem. You're all done? You're all experts in strokes now? Is that crazy? Back in the day, strokes would come in and we'd just like watch you and say, oh well. Now we lyse you and we ship you off to get the clot pulled out. It's crazy stuff. It does do good. Some of it is actually very beneficial, but it's a lot of resource utilization, and it's kind of an interesting discussion of where that all comes from. All right, let's talk about adult chest disorders. We're gonna split this into 2 parts. So we're going to talk first about things like pneumonia. This is not asthma and COPD, that's a whole different talk. This is basically things like pneumonia, looking at chest x-rays, that kind of thing. The second half of this one, which I'm going to do after the break, is basically a lot on pulmonary embolism and venous thromboembolic disease, which is, I'll tell you, it is the most humbling of what most of what we take care of is that. So let's talk about adult chest disorders. Lung disease is extraordinarily common. And again, we're not going to talk about the asthma COPD part, but we're going to talk mainly about how we address adult chest disorders when people come in with complaints. And often one of the things that we do with that is get a chest x-ray. Now, in the advanced boot camp course, we have a half day that's all just radiology. It's all kinds of radiology things that we go over, all kinds of plain films and CT scans, et cetera. But I want to take a little tiny snippet of that out and talk about looking at a chest x-ray. We'll talk about it tomorrow as well in the same idea and looking at an EKG. You will be looking at, in your career, you're going to look at thousands and thousands of chest x-rays and EKGs. And granted, when you get a chest x-ray, there's somewhere out there in Australia or at home in bed or somewhere a radiologist who can look at it somewhere on their digital screen. But the reality is if you order anything, I honestly don't care what it is you order. If you order anything, it is worth you putting your eyes on it. Even if it's something you don't know how to read. So say it's an MRI. I mean, MRIs to me are these big fuzzy bits of stuff. Sometimes they're bright, sometimes they're dark. MRI, I don't even know what to do. But I like looking at it and looking at the report and learning from what I see. Chest x-rays are plain films that you should be completely familiar with how to interpret, which means you kind of need to have a system to do it. You need to have some way that you actually, and each of us has learned a different way. There's the Dubin approach. There's all kinds of approaches to looking at x-rays. But I really like having an organized approach to everything because sometimes you get tripped up. You look at the x-ray and you notice the big thing that's staring at you and you completely miss the smaller thing because you just didn't have a systematic approach to it. So there's several different ways of doing this. Each of you has your own, and if you don't, please leave here with the goal of getting your own system on how your organized approach you're going to have to look at a chest x-ray. One of my favorites as far as the mnemonic here is doctors A, B, C, D, E. And the reason I like this one compared to some of the other ones I've seen as far as how to approach a chest x-ray is the DR part of this. So the D in particular, and I won't ask you to put up your hands, but I will put mine up right away, is if you've ever called someone to consult or admit or something based on an x-ray that had a really abnormal finding that you find out later was last year's x-ray, not today's x-ray, which may not have been taken yet because you didn't take the time to go look at the date, the time, and the patient. So make sure that it is what you think it is. So this D is basically patient identifiers. Is it the person you're talking about? Is it the date you think it is? Find out to make sure it's the right thing so you don't embarrass yourself, which we have plenty of opportunity to embarrass ourselves. At least you can take this one off the table. The right part of this I also like. So in the old days, we couldn't do anything when an x-ray was spit out of the machine where you pulled it out and stuck it up in a light box. But now you can, and you can make an x-ray because of our digital technology, which is awesome. You can actually make an x-ray look the way you need it to look to be able to actually interpret it. So for the most part, not always. So the right part of this mnemonic, one is rotation. So you all know you've seen the x-ray where the person is like this, and everything looks like it's on top of itself, or the heart's gigantic, it's over, and it's way too big. You want the x-ray to be square on. Okay, a PA is taken front to back, an AP is taken, the portables are APs, but you want it square on. And how do you know if it's square on? Well, what you need to do is find two parts of a human that are fixed. So one of them, and one that's midline, and then one that's kind of equal on either side. So the fixed thing in every person is your spinous processes. So get that x-ray where you find the spinous processes. So there's my spine, there's my spinous process, right down the middle. Cool, now. The fixed thing I have that is kind of equal on either side are my clavicular heads. So I'm going to go up to the top of the chest x-ray, I'm going to find the spinous processes, I'm going to look at my two clavicular heads and see are they equidistant from the spinous processes. If they are, I'm square on. If they're not, and the patient is turned, they're going to be, one's going to be farther away, one's going to be closer, and you can get an idea of which way the patient's turned depending which is which. The key, make sure that they're not rotated. That's important. It's going to make a difference how the heart looks, the lungs look. It's important. Inspiration, y'all know you want it down to at least the 9th rib, preferably more. I am amazed at those people who can take those gigantic breaths and it's like down to belly button. It's like good for you. But you need it down that far. Too low, you can't tell if the lungs have aerated appropriately. It's just you need to have a good inspiration. You need to make sure that the actual exposure is good as well. And this is where we can futz with it. What you want to be able to do to see where it's not too white or too black is to be able to see the spine through the heart. So ditzel around with your pixels on this thing to basically make it so you can see the spine through the heart. Now, if I've got my squared on, I've got a good breath, I've got the spine through the heart, now I can very comfortably know that as I'm looking at all the rest of the jazz, it's the way it's supposed to look. So you have that lined up appropriately, you have that inspired appropriately. And then have a system. I don't care if you do it out to in, I don't care if you do it however you do it, but make sure you look at everything. And the things that we forget to look at are soft tissues. So for instance, maybe somebody had a mammogram and there's a breast missing that you didn't notice. And there's also a funny, what looks like a fracture in a rib, which, ooh, missing breast, fracture in rib. Maybe that's actually a MET, and that's what we're dealing with here. So look at it all, put it all together, look at the costophrenic angles, however you do this. And the key is find a system. I like this one, pick one you want. But find a system where you have a very organized approach to looking at a chest x-ray each and every time. That way you won't get led astray by the big pneumo on one side and then the fact that the other side has a deep sulcus sign and you're missing the fact that that one actually has another pneumothorax on the other side. So here's kind of all the organs that are in there. You can actually lay them out and find all the parts of the heart. It's very cool. But have a system to do this. All right, let's talk about what your lungs and your oxygenation system actually do. So one of the things we look for, one of the things we know is not supposed to happen is people aren't supposed to be blue. right? Cyanosis, you're not supposed to look like a Smurf. Cyanosis is abnormal. But why isn't it everybody, let me think about this, why isn't everybody who's hypoxic blue? Right? They should, think about those COVID patients you saw. Why aren't they all blue? Well, the reason they're not blue is because you turn blue because of how much oxygenated hemoglobin you don't have. If you end up with more than so you're sitting here with hemoglobin of about 13 grams, just all of us sitting in this room. You need to have 5 grams of hemoglobin deoxygenated completely for you to actually look blue, 5 grams or more. So these blue bloater people actually have a lot of deoxygenated hemoglobin, but they also have often a lot of extra hemoglobin around, so they can look blue and still not be dead, right? If you, though, have a low hemoglobin level, let's say you're somebody who is anemic, you have a hemoglobin of 6 from endometrorrhagia, you'll be dead before you turn blue, getting hypoxic. You'll be absolutely dead. So know that all cyanosis tells you is that there's a lot of deoxygenated hemoglobin. We know people can be very hypoxic and never turn blue. So it's really important for you to absorb that, because if you expect people to be blue when they're really hypoxic, you're rarely going to see that, if ever. We hardly ever really see that for real. And we know that assessing people's respiratory status involves not just the respiratory rate, which we talked about, but we're going to watch it. We're going to look at the tidal volume. We're going to see actually how they're breathing, to assess how they're actually ventilating. Because remember, what your lungs are doing are 2 big things. One is getting oxygen into your system and out to your body, but the other is getting that CO2 that gets to it away, getting it out. So ventilation and oxygenation are the 2 huge things that your lungs are doing for you. And what drives your respiratory rate, what keeps you at a respiratory rate of 12 to 14 when you're normal, is your CO2 level. We all have basically a carbon dioxide drive. Most normal people have a carbon dioxide drive. And I'll tell you, you can do your own experiment and prove this to yourself. So I don't recommend necessarily doing it here, but in the privacy of your room, go upstairs and for a minute, take huge deep breaths. Gigantic tidal volume breaths, 8, 10, 12 of them, big breaths. Okay, don't get dizzy, just take huge breaths. What you're doing when you do that is blowing off CO2. So your CO2 level in your system is dropping. And then I want you to stop breathing and watch your watch. You will be amazed how long it takes for you to feel the urge to breathe. It's amazing. So it is that CO2 drive, and it's the reason, by the way, that some people who learn how to free dive, or kids that do the crazy hyperventilation thing at the pool, die underwater. They hyperventilate down to a CO2 of almost nothing. They go down underwater. They end up hypoxic before they build up enough CO2 to have a drive to breathe. And they end up drowning. So this is, that you don't tell your kids, don't let them do that. Don't let them hyperventilate at the side of a pool. Free divers learn to do this. They learn to actually manipulate all of this. It's magical stuff. But know that all of us in this room are CO2-driven breathers. We do know that COPDers can become hypoxic drive breathers. It basically fries your brain after a while from having too much CO2 around, and you become a hypoxic drive breather. Not most people. So it is our CO2 level that drives our breathing. So, and that can get messed up, right? So you cannot ventilate well to get rid of the oxygen or get rid of the CO2. You can have a diffusion problem. I have a pneumonia. I have a pulmonary embolism, something where I can't get it across from one side, from the blood vessels to my lungs to get it out. Something can obstruct that. That can be anything like a PE. True, ARDS is classic for this. So that is the drive for most of us, is this CO2. And try the experiment. It is amazing. You will find you don't have the urge to breathe. It's the weirdest thing. It's like, it's been 30 seconds. I don't really have any urge to breathe. How weird is that? Now, blood gases, I also want to mention. Back in my internal medicine days, we would admit absolutely nothing that was pulmonary, pneumonia, asthma, COPD, without a blood gas, an arterial blood gas, no less. Had to be stuck right in the artery and sent to the lab at $250 a pop, plus it hurt. It turns out most of what we need from a blood gas, we don't need to get a blood gas for. So we can get the oxygen off of pulse ox, right? I can tell your oxygenation off of pulse ox. I can get the CO2 off of capnography. And actually, it's pretty darn accurate for 90% of what I need to know to get it off of capnography. The only thing I really need a blood gas for is a pH. I have no other way of measuring that. So I can get a venous pH, and that's as accurate as I need for 99% of what I need to do. So if I'm worried about a pH, you've taken a toxic alcohol, you're an aspirin overdose, you have DKA. If I'm really worried about a pH, get a venous blood gas. But I can check your O2 and your CO2 non-invasively if necessary. So arterial blood gases are kind of really a thing of the past. And if you really need a blood gas, a venous is fine 99% of the time. Now, when people have respiratory failure, where their lungs just aren't doing what they need to do, there are two versions of this. There's hypoxic failure. I can't get the oxygen in and into my body, hypoxic respiratory failure, and hypercarbic respiratory failure. That's the COPD we think of, the person retaining CO2 and gets hypercarbic respiratory failure. Most people have a little bit of a combination of both, but depending on what your entity is, you may be predominantly one or the other. Like hypoxia is really common in things like COVID we saw. Hypoxia was a really profound thing. If I need to give extra oxygen or help the ventilation of somebody who is in hypoxic respiratory failure, other than just regular oxygen stuff, when I advance into the sort of advanced oxygen things, I have three options. I have non-invasive ventilation, I have high flow oxygen therapy, and I have intubation. Now, you all are very familiar with those, especially since COVID, especially high flow oxygen therapy. That was not something routinely done until COVID hit, and now it is like the thing. But that's for hypoxic respiratory failure. Hypercarbic respiratory failure, where my oxygen may be fine, I just have a whole bunch of CO2, that I usually fix with non-invasive ventilation. I help them blow it off, non-invasive ventilation. If I may need to intubate, I can do that, but turns out high flow oxygen therapy doesn't help that. It only gives more oxygen. It only fixes the hypoxic part. So if you get into the two categories here, sort of the non-invasive deal, non-invasive has great, I'll tell you, non-invasive wasn't around when I first started training, or it was, but it wasn't as sophisticated as we have now. And I'll tell you who discovered this. So in the 1980s, it happened in Europe. There was a patient who came in with basically CHF, a humongous, horrible CHF exacerbation, flooded, but did not want intubation. Flat out, did not want intubation. And this is where the MacGyver brilliance of people like you in this room came to be. The person who was at the bedside said, well, I have a ventilator there, but you don't want it. I have an ambu bag here with a mask on it. I know this mask fits on that ventilator. What if I put those together and I put the mask on this person's face and just like duct tape it to that person's face and let's see what happens. I'm gonna turn PEEP on, oxygen like crazy, and let me turn on some PEEP. I can't do it down there because you won't let me put a tube down, but let me do it out here instead. And voila, it was like magic. It was like magic. It was like, whoa, this is working great. And they had a few tweaks. It took the mask had been on for a couple of days actually when they finally took it off, and there was pressure necrosis. And it was like, okay, we got to tweak this a little bit. But it was brilliant. So we know non-invasive ventilation is great for CHF. It is the initial treatment of choice for moderate to severe COPD. Absolutely great for that. It is wonderful. And you have ways of using this. You can use this just constantly. It's like, use it like they did at that bedside in Europe, where they just turned PEEP on. I don't know, let's turn on a PEEP at 10. That looks good. That's CPAP, constant. But now we're more sophisticated. We have ones that will have a different level when you're inspiring and a lesser level when you're inspiring and a higher level when you're exhaling, or the bi-level version where you actually can help somebody actually clear things out a little better, like CO2. It is an amazing, amazing technology. And you guys, if you're not good at it, please get comfortable. And I will tell you another thing you should do when you go home. This you're gonna have to get your RT person to be in cahoots with you. But hide behind a curtain with that machine and try it on. Put it on. See how you feel with that thing on. See what it feels like to breathe with CPAP on. See what it feels like to breathe with bi-level positive airway pressure. It's worth knowing that because it'll help you coach people when you help put it on people. It'll help you, because it feels really weird, I have to say, especially when you're breathing normally. It feels really strange. It will help you help them understand. So you have these different ways you can set this up. It aids ventilation and oxygenation to do this without putting a tube down. And then we know ultimately intubation is the be-all, end-all. But I will tell you, it is not safe in every case. At the Q&A, if you were still here, if you weren't, the things we talked about was, what if you have to intubate a DKA patient who's super, super, super acidotic? What do you do with that person? Could bicarb be helpful? Because we know there are risks with intubation. I stop somebody from breathing, they start to retain CO2, but they're already acidotic, they get worse. There are lots of risks that come along with intubating, so we'd like to stop short of it if we can, and we have lots of options for this. Now, non-invasive ventilation, I'm just going to spend one more moment on, because I think it's a technique that we've jumped into high-flow oxygen so much in the last 18 months. And non-invasive is certainly still part of our armamentarium, but you need to be really good at this, especially for CHF and COPD. It's also very useful, by the way, at end-of-life care. So let's say you have somebody who comes in who is a DNR, DNI. It's like, I have end stage whatever. I do not want you to intubate me. I do not want you pushing on my chest. I am really short of breath. My loved ones are 3 hours away. I would like them to be here. It's something you can do in the interim. It's non-invasive. If they're willing to, it just can buy them some time. Sometimes it buys them enough time to get them past whatever today's episode is, and they have some more time, weeks or whatever, if it's a cancer patient. So keep it in mind for that patient group as well. Sometimes it keeps them more comfortable as whatever's happening is happening. And the basics of this, we talked about CPAP and bi-level, so you have two different kinds of settings. If you have somebody who's on bi-level, people have a lot of things. It's like, okay, wait, if I have it on bi-level and I picked my initial settings of, let's say, 8/3, which is a really good initial start, except for CHF, whole different thing. But let's say 8/3. But the patient is still hypoxic. So their SAT is still low. It's not really helping them. How do I fiddle with those numbers to make their hypoxia better? What you're gonna do, if that's the case, is increase both numbers. So 8/3 is gonna go to 10/5 or 12/8. If it's like COPD or who's retaining, and they're still retaining more than you want them to at 8/3, you're gonna increase the first one, not the second one. You're gonna give them more of a sort of a gap between the two to be able to get that CO2 out. Let them collect it and breathe it out. So those are the ways that you adjust the settings when it comes to non-invasive ventilation. And we talked about high flow nasal cannula, and I just wanna re-emphasize that is not for COPDers. That is for hypoxia alone. It's just an oxygen delivery system. It is not anything that changes pressures specifically like we do with non-invasive. All right, let's talk about pneumonia. The old man's friend. Osler called pneumonia the old man's friend. Pneumonia is extraordinarily common, and right now everything on an x-ray that looks like an infiltrate is COVID. But it isn't, right? We know that a lot of things go on in those x-rays. One of the things is to decide who needs an x-ray. So let's say you're working in fast track or you're working in an urgent care and somebody comes in and they're coughing and they may have a low-grade fever, temperature of 100 degrees, something little. They're just coughing away. Does that person need an x-ray? Well, we know most people don't. In fact, a lot of people don't. Some do, some don't. You have to decide who gets it. The knee-jerk thing to do is to order one in everybody. That's kind of overutilizing resources. We don't need to do that. It's expensive for patients too. So there's some guidelines here. So if somebody has a temperature, it doesn't have to be super high, consider it. That's okay. If somebody's tachycardic, consider it. That actually means that they're having some either end organ-y issue, SIRSy kind of issue you got to worry about here. If they're tachypnic, definitely think about it. So tachypnea, so think about it. Bronchitis, if somebody has bronchitis, they don't get tachypnic. They don't get tachypnic. They cough. They may have a little fever. They don't get tachypnic. People with pneumonia can get tachypnic. So tachypnea to me is a definite tip into, yeah, I'm going to image that person. If I hear something, the breath sounds are unequal, or the breath sounds are crackles someplace. If I hear something when I listen to that person, I'm going to go ahead and get an x-ray. And especially if somebody's wheezing with no history of asthma, I'm going to definitely get an x-ray and see what's what. And what I'm going to do when I look at that x-ray is go back to my Dr. ABCDE approach, and I'm going to look specifically around for things. But in those lungs, I'm going to focus on are there infiltrates? Where are those infiltrates? What do they look like? Are they cavitary? Is there an effusion that goes with those infiltrates? You're going to actually look very closely at that x-ray for things that will help guide you to determine how sick that person is with pneumonia. So you're going to see things like this. These are two x-rays of people that have viral pneumonias. Now, COVID is a viral pneumonia, right? We see viral pneumonias in people, and that tends to be patchy and diffuse. Mycoplasma does this as well. These kind of interstitial patchy infiltrates. These two x-rays are quite consistent, especially the left one, quite consistent with this sort of mycoplasma, chlamydia kind of viral pneumonia picture. The one on the right in this picture is a lobar infiltrate. This is actually, by the way, does anybody, I'm gonna just like a super bonus question. Where on my person, where am I gonna put my stethoscope on that human being to hear that infiltrate? Is it gonna be in the front or the back? So that is a posterior infiltrate. And the reason I know that's a posterior infiltrate, not a right middle lobe infiltrate, is that right heart border is really sharp. I see the entire right heart border and I see it crystal clear. If that right heart border were blurred out, that tells me the infiltrate is sitting right against it. That's the right middle lobe. That infiltrate is actually not. That's in the back. You're going to hear that one in the back. You'll hear it right there in this person. You're going to hear it right in their back. So that is a lobar infiltrate. That's the kind of infiltrate where we do hear things like E to A changes. Remember that? Egophony, 99, 99. The things you were taught to, I to E changes, the things you were taught to listen for. You may hear those and that kind of thing. We don't do it very much anymore, but when it's there, it's awesome. It is amazing. It really does that. The one on the right, on the left of this picture, if you see that X-ray, you are going to be so happy that you always wear masks now in the hospital, because that person most likely has tuberculosis. I see TB a lot in where I work. It is a common thing in our patient population. So, and we get kind of sloppy sometimes. If you work in an area where TB is not that common and somebody happens to be there, you'll miss it. You can miss this. So that cavitary lesion, that person goes into isolation. We're so good at isolation now, but that used to be a big thing. Goes into isolation. Respiratory precautions, you do too. That person can be spreading tuberculosis. When people get pneumonias, they present the way you would think, right? They have a cough, they may or may not have sputum. Remember, some of them don't, but they might have sputum. And sometimes the sputum is very helpful to you. It's like, wow, I hacked it up and it looked like a chunk of rust. It's like, oh, well, that's helpful. So ask about the sputum, see if they've actually looked at it. See if they have a fever and chills, whether the tachycardia, all the things you would normally do, of course you would do. But do know that in particular the elderly don't read the textbooks and may just present with a little bit of altered mental status or a little bit of fatigue. So they may not come in with the fever and the cough and the sputum, all the things you'd expect, and they may still have a exam that sounds like pneumonia and an X-ray looks like pneumonia. And to diagnose it truly as pneumonia, you need an imaging study. You need some sort of imaging study. So you need a chest X-ray that's positive, an ultrasound that's positive. So ultrasound for pneumonia turns out to be pretty darn good if you know what you're doing. But X-rays are just fine for this. I hear people talk about false negative X-rays. They're uncommon, to be honest. And if they occur, it tends to be in somebody either who's super dry or somebody who just, it's not there right now and it's obvious later today that they were in their early phase of pneumonia and now it's clearly pneumonia later in the day. Any other testing other than an X-ray in a pneumonia case is individualized. There is no checkbox pneumonia click order set that you should be clicking unless somebody's really sick. Most patients go home with pneumonia. Okay, not all of it. It depends on your patient population, but a lot of patients go home with pneumonia, and you don't need anything other than an X-ray and what they look like to determine what to do. The more comorbid the person, and the sicker the person, the more tests you'll order then. And if you think you're going to admit the patient, that's where ordering something like a blood culture comes in, and that's a whole different sort of entity. But the reality is, especially if they might end up in the ICU, you're going to head and order a blood culture in that person as well. Now, the key here is to determine, what do you do now? So how do I treat this person? Well, back in the day, we used to wait until we had something like a gram stain to determine of sputum, which was a riot. We gram stained a whole lot of spit for decades. People can't hack up sputum. They just don't. They into a cup, and that's what we would gram stain. It doesn't help you. The reality is you're much better determining what antibiotics to use based on a constellation of things about the patient rather than trying to guess the organism. Because if you figure out this constellation of things, you'll have a pool of a pod of different organisms that you can treat with, appropriately. So empiric treatment is where we go now. We don't try to figure out the specific organism. We treat empirically based on patient characteristics. But you have to ask a few things, like, have they been in the hospital recently? Have they been on antibiotics recently? Have they traveled? So make sure they haven't gone overseas somewhere or traveled somewhere where COVID rates are really high. You really need to know your hospital's antibiogram. And what is interesting to me is even in LA, which is gigantic, but it's a relatively, anyway, we have antibiograms that are distinctly different in hospitals that are 5 miles apart. So you need to know the antibiogram in your hospital, which basically says for these kinds of organisms, these are the antibiotics that we use here because this works in our patient population. And then you need to know the guidelines. The first decision that you make when it comes to pneumonia, yes, you have it. The X-ray's there, your symptoms are good. Okay, we're good to go. It's pneumonia. My first decision is, do I keep you in the hospital or do I send you home? Because if I'm going to send you home, I'm going to be able to treat you with certain kinds of antibiotics. And if I'm going to keep it in, I'm going to use different ones. How you determine that, you can use a scoring system if you want to. There's the Pneumonia Severity Index, there's the CURB 65, there's lots of these. You can use clinical judgment, that's absolutely fine as well. None of these is easy to remember, so get your little app and your thing if you want to calculate it. I usually put it, when I diagnose patients with pneumonia, put it in the chart, PSI of whatever, Pneumonia Severity Index of this. If you decide that the patient goes home, I've got one set of antibiotics to use. If I decide the patient is staying, I'm going to use another set of antibiotics. This is the Pneumonia Severity Index. You can see why you would never want to try to memorize that. Just plug it in. Get MD-Calc out and plug it in. It'll cough up a number for you. And the reason this is important is if I think you're healthy enough, like most of you in this room, if you had pneumonia and your SATs were good and you weren't super febrile and your respiratory was fine, I would be sending you home. So so as an outpatient, I'm going to play the odds. We're in Vegas. Odds are it's a virus, or it's mycoplasma, or it might be pneumococcus, it might be Legionnaires, but probably not. Often we don't really know what it is, and you do fine as an outpatient with that kind of group of things I'm worried about. If I'm going to admit you, though, and you're not an ICU person, now I have a few more things to worry about. And this is where multiple organisms can be causing infection in one person, and I need to broaden things a little bit. H-flu becomes a problem here. And if you're super sick, you're in the ICU, now we have the bad things. Now we have things like H-flu. We have things like the gram-negatives where people get that. We have Legionella that can occur. We have people that have Pseudomonas sometimes. We have the necrotizing Staph aureus. This is the sicky people, and that's a whole different set of antibiotics. And this set of guidelines came out in 2019 from the IDSA, the Infectious Disease Society of America. And this is basically what they recommend you use. I am not going to talk through it. You can read as well as I can. Just the general gists here are outpatient single drug. Okay, outpatient healthy single drug. Outpatient comorbidities, it's either 2 drugs or a respiratory fluoroquinolone. Inpatient depends on a lot of other factors, like where have they been hospitalized recently? How sick actually are they? And that you can go, I'm going to let you read. There's no point in my reading you through that. And just know that your antibiogram at your hospital may change that a little bit. So you kind of have to know what you have at your place. But that's what most people have. We have a couple of tables of charts here that are kind of fun facts about specific kinds of pneumonias. But remember, we're not diagnosing the specific pneumonias in these cases. We're putting a patient clinical picture together, and if we end up finding out the organism later, that's good to go. But you're not ever going to say, oh, I am sure it's X, because you'll end up being wrong, and you need to pick the right sort of empiric antibiotics. 2 last topics. One is spontaneous pneumo. So when you're having a really bad day at work, like you've had your 55th weak and dizzy older person that you just don't know what's wrong and your brain is ready to explode, that there are 3 things that can happen in your job that will make you ecstatic. A shoulder dislocation, an SVT patient, and a spontaneous pneumothorax. It's like, yes, I needed this. Right? These are awesome. Tend to be tall, skinny people. They just drop along. They often have, pleuritic chest pain. They may have trouble breathing with this. Your X-ray, if you get an X-ray, looks like this. Better yet, grab an ultrasound. The ultrasound shows you that one side slides, the other one doesn't. It's awesome. And ultrasound is fantastic for this. And you can fix it. And you can fix it great. And there's like a jillion ways to do this, by the way, for spontaneous pneumo. If it's tiny, you can just stick them on oxygen. If it's bigger, you can put in a valve. You can put in a pigtail. You can send them home with those valves and pigtails. Rarely do you ever need to put in a gigantic chest tube. We have lots of cool ways of doing this, which is why it's so fun. It's like a shoulder dislocation where, I have 15 different ways of doing it. How do I feel today? This is a wonderful thing. It's a nice thing to treat, easy to do, spontaneous. The last thing is not so easy and can be pretty scary, and that's hemoptysis. So someone out there gauged hemoptysis by how much? And people don't come in and say to you, oh, I coughed up 55 cc's of blood. I mean, they don't do that, right? They never do that. But nowadays, they are coming in with like their cell phones saying, I coughed this up, or better yet, the Ziploc bag with, I've been coughing this up for the last hour and a half. It's like, okay, fine. Hemoptysis usually is from bronchitis, and it's usually mild, no big deal. But when you get into things like TB that erodes through an artery, it's called Rasmussen's artery, or mycetomas that erode through, or cancers that erode through big vessels, people can bleed to death in their lungs. And they don't bleed to death, they drown. And our job, if they have a massive bleed in front of us, is to first keep your cool, and then remember to do a couple of things. Get them on oxygen for sure. If you know which side the bleeding is coming from, put that side down. Put them on their side. Put that side down. Let that lung go ahead and fill. Okay, put that side down. If you need to intubate, try to intubate the other side. Easier to do on the right, kind of much harder to do on the left. Try to intubate the other side. If they're coagulopathic, correct that. Get all hands on deck. You're going to talk to pulmonary, you're going to talk to cardiothoracic surgery, you're going to get all hands on deck, ICU, intensivist, everybody. Often, sometimes IR gets involved, and try to get them to the IR suite or to surgery, because these people, unless you can tamponade it off, they drown. They end up drowning. Scary, scary, scary. Okay, that's the first part of chest. We're going to come back and talk about PE after the break. And I think we have Rick next. Thank you.
Did you see the papers? No, it's not muted. Hmm? Did you see the, no, it's still not. 1, 2, okay. One, two, 1, 2, 1, 2, 1, 2, 1, 2. Chris, help us out, Chris. Better. So my time is up. Does anybody have any questions? You know, Diane mentioned about pneumothorax. There's some recent papers that basically say even large spontaneous pneumothoraces, you can do nothing, and the vast majority of them will just expand on their own, and they can go home if you've observed them for 4 or 5 hours and taken another chest x-ray, it's not getting worse kind of thing. And the other thing I wanted to mention about pneumonia is that this is the weirdest thing. The pediatricians, the American Academy of Pediatrics, said you don't need to take an x-ray to diagnose pneumonia in a kid. I thought that was like the gold standard, you know? But if you want to check me, I can assure you that's correct. So they'll allow you to make a clinical diagnosis of pneumonia without taking an x-ray. You also know that even if the x-ray is normal, the CT is really the better study, and that will probably be abnormal. So now we're going to move on with more pediatrics. So EMTALA basically says you're mandated to do a medical screening exam to determine if there's a HCFA-defined medical emergency, and it doesn't require permission to do that. Anybody who presents themselves to the emergency department, so you don't need the parent's position. And frankly, if the aunt brings a kid in and he bonked his head, he's got a big Goomba there, and you feel that it needs a CAT scan, you don't need to wait for anybody. You can get the CAT scan, or if you think they have a surgical abdomen, then you can do whatever you think you need to do, because if there's a delay, maybe that's going to result in some negative outcome. These are the folks who have state-protected rights to be seen by a clinician without the parent's business. Well, child abuse, that sounds reasonable. Pregnancies, STDs, outpatient mental health, and substance abuse. So they don't need their parents' permission. One of the problems is recognizing child abuse in a subtle stage. I know of 2 $45 million cases of child abuse that was missed, and it's always the same. The kids missed on the first visit. The next visit, they came in with all kinds of fractures, broken skull, intracranial hematomas, that kind of thing. So, that's always a bad outcome. And so the idea here is you have to be very, very suspicious I saw a case where the complaint was blood in his mouth. And they looked and they really couldn't find anything that was the source of it, and it was just a one-time kind of thing. So they kind of shined it on, and it turned out that the kid really did have some kind of process that was going on. Maybe they should have looked more carefully. Maybe the nurse's notes would have tipped them off. I think that was the case in that one. And it did turn out to be $45 million, because these kids don't die. They basically live in a paralyzed or brain altered state for the rest of their lives, and it takes a lot of money to pay for that to occur. Emancipated minors, which means you can have a 15-year-old girl married. She's an emancipated minor. It happens a lot in Kentucky. Members of the armed forces, and self-supporting and living on their own. Macaulay Culkin was a emancipated minor. Drew Barrymore was an emancipated minor. There was a list of the Hollywood people, because once they're emancipated minors, the work rules related to child labor does not apply to them anymore. And they basically wanted to work more, and they could limited their hours to work, and everybody still has to have a teacher. You can't get out of that, even if you're an emancipated minor. Obviously, the best thing to do in these cases is to keep the patient in the room with the parents, kind of thing, because it's the parents who need to be treated here, and they need to see that you're going to do a good job and that they trust your judgment on this. And so doing it without the parents in the room is just like is a rehearsal. Bring the parents in, and then you verbalize this exam that you're doing on their child about hydration, and moves all his limbs and doesn't have any rash. I look in his mouth, the mouth looks okay. Don't see any pus in there. Ears look okay. The neck is supple. All of that gets verbalized. And then you basically, they're clear that you did a thorough exam, good doctor. And that's kind of like a cardinal rule. You have to do the exam with the parents in the room. If you have a sign outside that says emergency department, it implies that you're going to be able to take care of anybody who walks in the door. Certainly kids. I mean, they're at least 25, 30% of what's seen in most emergency departments. So you will be expected to have all the equipment that is necessary, particularly with regards to airway equipment and the like, life-saving type equipment. So in Los Angeles, we have a thing called EDAP, Emergency Department Approved for Pediatrics. And they have to have they make the nurses go through all these pediatric ALS courses and all that, and the doctors who are, if they're board certified, they say, oh, that's part of our core training, we don't need that. So the poor nurses have to go, the doctors don't, and they also have a checklist of all this equipment they're supposed to have, including pediatric rib spreaders, which wouldn't know how to use those things. And other related kinds of things. So, and the other thing that comes up is all about this dosing for little kids, and the opportunities to make an error is when you dose kids because you're not really familiar with it, you don't do it a lot. The Braslow tape will give you the weight, and there's a kind of thing on it that will help you give it dosing. But now they have a new version of this thing where if you get this e-Braslow version, it will scan the medicine bottle, because there's various dilutions of these medicines, so it'll scan the medicine bottle, which will tell it the dilution of this drug and tell you how many cc's of that drug in that bottle you need to give. Inconsolable crying. This is a common complaint. Generally, when they come in, the kid is happy as a clam, not crying anymore. Everybody's said, oh, he's really crying at home. They feel a little embarrassed to have you there. Well, this is a diagnosis of exclusion in terms of you look at all the bad things, and if it's not the bad things, you just say you have a miserable kid. But the fact of the matter is you can say, is it colic? 3 hours a day, 3 days a week, 3 weeks in a row is the definition. There is a definition of colic, that's it. 13% of the kids have this horrible thing. It appears that it normally lasts a short period of time. I know a woman who said her kid had colic for 6 months. Now, she'll be getting out soon from the sanitarium because it was a miserable experience, I can assure you. Trauma, you have to look all over. You have to take the clothes off. You have to take the diaper off because some of the interesting things are below the diaper, like, so we're looking for soft tissue. We're going to grab all the extremities, see if they move okay. Yes, they're fine. Strangulation of the digits. Has anybody seen this? Please raise your hands. Those of you who haven't, look around. This is not an uncommon kind of thing. It is like a miracle this thing happens somehow. It strangles the toes, strangles the penis, and the treatment is Nair. If you have the time to put Nair on and have somebody run to the, so you should really have it in your emergency department. Infections could be painful, and that could make a kid cry, whether it be the ear. We know earaches hurt, and maybe it's a nasty sore throat or some other kind of thing. Meningitis, that's still around. Gastroenteritis, cramps, abdominal cramps. Surgical conditions are under the diaphragm, so we're looking for inguinal hernias. We're looking for anal tears, the anal fissures at 6 and 12 kind of thing. Testicular torsion, appendix, testis torsion. Those things are all down there, and basically you have to take the diaper off. Some of these kids have horrible diaper rashes, and you're wondering why they're crying kind of thing. And the parents just don't have an appreciation that this is not really good. And then you found the likely problem, at least. The most common reason for bringing a newborn back to the hospital is that they are turning yellow. The most common cause for jaundice is physiologic jaundice, which means that the liver is being overrun by the products of fetal red cells. Fetal red cells are these red cells that have nuclei in them, and they get rid of those things and replace them with adult type red cells that are non-nucleated, and you're familiar with what they look like. So in the process, all these fetal red cells are broken down. White cells, spleen, break these things down, and they release their hemoglobin, and the heme gets changed to this or that, and ultimately you wind up with bilirubin. Bilirubin is headed down to the liver, where it's going to be conjugated. When the liver is conjugated to the bilirubin, then it can go out the biliary tree. So the vast majority of bilirubin that people have when their liver is kind of a little overwhelmed in terms of its ability to handle all this is unconjugated bilirubin. Unconjugated bilirubin is what needs to be conjugated to become bilirubin. And the way that it becomes conjugated is by the release of some enzymes, which we'll talk about in a minute. So this is most common for sure, and there are some certain ranges. And so this is all about the Billy chart, and who goes under light and who doesn't go under light. It says there, in the 2nd to the 4th day, days 2, days 3, day 4, your bilirubin is 5 and 6. Is that helpful? Day 2, day 3, day 4, your bilirubin's up to 5 or 6. So that's one peak. Should decrease pretty quickly. Sepsis is another cause of jaundice, but septic kids usually look septic. So we don't really worry about the kids who look sick. We worry about the kids who don't look sick. The well-appearing neonate, the well-appearing 3-month-old, those are the ones that are the bugaboo about how much do we do in terms of a workup. The kid doesn't have a fever now, but the mother said it had a fever at home. How do you handle that? We'll talk about that as well. Breastfeeding-related jaundice. This is strange. So mother has glucuronidase transferase inhibitors. Now you need glucuronidase to conjugate the bilirubin. There's inhibitors of that enzyme in mother's breast milk. So later in the child's life, we're talking 10 to 21 days here, look at how high this bilirubin can go as a result of this process. Now, normally we're worried about kernicterus. This is a blood-brain barrier thing. It exceeds the amount that would take to go into the brain starts turning yellow, and it's a neurotoxin. So that's not a good thing to have. So that's what we're concerned about. Look how high these kids can tolerate it. when they're older, just a couple weeks older. This is all something I think that every neonate has a doctor, and so you just basically there's somebody to call here and hold their hand in terms of what are we going to do for this little child. Screening tests, they all need these screening tests. You need a bilirubin, and you need a conjugated, unconjugated, direct, non-direct, the same thing. Why? Because in physiologic jaundice, your unconjugated bilirubin is going to be very high because the liver can't handle it. If the conjugated bilirubin is high, that means it's been conjugated by the liver but can't go out the biliary tree. What does that talk about? That talks about biliary atresia maybe going on. So what the number is in terms of the ratio of conjugated to unconjugated is what we're talking about here. So that's one screening test. The other screening test is the Coombs test, which is a test that looks for preformed antibodies that surround red cells and lyse them. So this is a hemolysis condition. Like if you're given the wrong type of blood, all of a sudden you'll have a transfusion reaction. We're going to have to wait for the making of these antibodies. These are preformed there and waiting for the wrong blood to come along. And this is the same kind of thing. I don't know why I put that in there. Vomiting in kids. Vomiting is a common problem, and sometimes there could be nothing serious, and then it could. So here's the list. Infections. The responses of children are rather stereotypical. They vomit, they have diarrhea. They vomit, have diarrhea. Infections, UTIs in particular. UTIs are the most common bacterial infection in young children, 3, 4, 5, 6 months old, that kind of thing. So infections are one. UTI is at the top, and we'll talk about the assessment of fever in the young children. Hepatobiliary causes of vomiting are related to you should look yellow, because normally these kids are manifesting liver dysfunction, and they're turning yellow when they're having this vomiting. Malrotation of the gut. So in embryology kind of thing, and the embryonic fluid is out here. The child does not have a closed gut. All the bowels floating in the embryonic fluid. And when it goes out there, it's supposed to make 3 turns. 3 turns, bump, 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 and it goes back in and puts itself where it's supposed to be, except sometime when it happens, you get a band. You get a fibrous band that happens across the duodenum. And so in those cases, there is an obstruction, and the kids are vomiting. And depending on where that is, they can be vomiting bile. Kids are not supposed to vomit bile. So bilious vomiting is a touch-off to, this is due to a malrotation of the gut. Malrotation of the gut are usually identified in the first 2, 3, 4, 5, 6 weeks of life, but some adults have had malrotation of the gut, but it doesn't cause them any problem until they're older. So it wasn't even known that it was there. Pyloric stenosis, we'll talk about that. We'll talk about intussusception. Increased intracranial pressure, shaken baby, you don't call it that anymore, although I kind of like that term. Abusive head trauma. All right, that's what the committee came up with. Incarcerated hernias, we'll talk about those. And there's a magic drug at the bottom, which is was a lifesaver to us because it's an oral antiemetic that was used in cancer patients, and now it's used in everybody. Diarrhea, winter diarrhea or summer diarrhea. Winter diarrhea is usually virus. Rotavirus, they still get in their shots for rotavirus, but all those shots basically tell us we're not going to get a severe life-threatening diarrhea. It'll be less severe. So the numbers here are like 90% effective for severe rotavirus, about 2/3 effective for mild rotavirus diarrhea. Summer tends to be bacterial, so we're talking about staph, Shigella, Salmonella, Lactobacillus. In any case, staph. Staph is when you go to the picnic and you eat the mayonnaise in the potato salad, but it's been sitting out all day, and within several hours you have wicked diarrhea. Because this has a preformed toxin that's been it's been stewing in the salad bowl where the potato salad is. So it doesn't have to do anything inside your bowel except get there. And once it gets there, your bowel realizes that this is a toxin, an exotoxin produced by staph, and you got the diarrhea very quickly. So if you have diarrhea very quickly in the summer, it's assumed that it's staph. Bloody diarrhea basically is when the these bacteria go through the cell wall and start nibbling on the underlying capillary bed. This is Salmonella and Shigella. You know, Salmonella is chicken, turtles, and Shigella is kind of like the roach coach kind of thing. Shigella is interesting because Shigella creates a neurotoxin, and it generally causes really high fevers in kids, usually 104, 105 fever kids. And they come in with a febrile seizure because this is a neurotoxin as well. It causes a febrile seizure when this kid's 104, got this febrile seizure, and you're about to do a lumbar puncture because it's a little tiny kid and had a seizure, and there's been no history of that, and look at how sky high the temperature is. A lot of them, we just don't do much of anything in a febrile seizure, but in this case, we probably would. And I had a case, I remember to this day, where we're going to do a lumbar puncture, and you know, you get the EMT to hold the kid in a little like horseshoe kind of shape kind of thing. And when he put the kid in the horseshoe kind of shape, he didn't, and out came the specimen we were looking for. He squeezed it out of this kid. So this bloody diarrhea came out, and we decided not to do the lumbar puncture. Leading cause of blood in the stool. Moms come in, you know, they're all been out of shape because there's a streak of blood in the stool. So basically, you're supposed to kind of say, well, what would be causing that? Well, in the vast majority of blood, we don't know. We don't know the cause. And in those cases, if the child is well appearing and active and playful and eating, just say, okay, we're going to keep an eye on it. Let's see how it progresses. Let's, you know, if it's getting worse, let me know. Otherwise, we're going to check it again tomorrow by your doctor, your pediatrician kind of thing. So that's the most common. We don't know, and it goes away. And there's really nothing really to do specifically for it. Some say milk intolerance is a cause. That may be. That may be. I guess there's some enzyme issues, and you know, some people are lactose intolerant. Well, maybe these babies, for some reason, also get to have a little bit of bleeding. Anal fissure, 6 and 12. Some say swallowing maternal blood. Have you ever heard this? That swallowing maternal blood would cause to have red stools, blood in the stools. Has anybody ever heard this? If they've not, we'll skip it then. Because it was always something that I thought was totally ridiculous. I mean, you're going to put somebody sucking on that nipple there, like with a 40 psi of pressure, and sucking out all of this thing. The nipples are cracked. The kid is exsanguinating the mother. But blood in the stomach turns black. So this is not going to be red blood. So I reject that. Pyloric stenosis, so, you know, this is white males from Northern European ancestry, generally 4-to-1 predominance in males. I don't know why they get this thing. But this is a great case because it's so, you know, it's so classic. The kid is starving, so he's drinking the formula, whatever, throwing it up, throwing it up, throwing it up. The kid's vomiting so much that maybe he has some, or she has some metabolic alkalosis because they're vomiting all their acid. And when you have metabolic alkalosis, you can also have a low K. Low K is low mag, and so that may be going on there too. But generally, you don't need to do any kind of electrolytes or anything like this. You fix the problem, and it'll all go away. There's the palpable olive. You've all, you know, most of us have felt an olive, but now they have ultrasound. So the ultrasound is like the definitive test here for that problem, ultrasound. And all of these people Ultrasound is the stethoscope of the future. It's time, you're going to buy yourself a butterfly or something like that. A stethoscope is doctor jewelry. This is a hard audience, I tell you. So you feel this olive, and basically you call the surgeons, and they open it up. In Japan, they give atropine for prolonged periods of time rather than do surgery. So that's intussusception. That's a good one too. This is the most common cause of a bowel obstruction in this age group. 3 months to 6 years. That's a huge span. Where does this occur? Usually, where the colon meets the small bowel, which is down in the cecal area here, right lower quadrant. That's where it usually happens. And there's the invagination of one part into the other, usually by some kind of lead, but it doesn't have to be that way at all. Rotavirus was thought to be one of the reasons for intussusceptions because it caused a proliferation of the lymphoid tissue of the abdominal wall, and that when this lymphoid tissue pooched up like that, the bowel said, "Pooched up? Fine, come, we're moving you down." And so it would invaginate into the small bowel into the large bowel. So this becomes a vertically oriented tube in the right side of the abdomen. Ultrasound makes the diagnosis. This is the picture there is classic picture. It's a tube within a tube. That's a head-on picture of a tube within a tube. These children presented in kind of a unique way because, and I saw one like this where this kid was just screaming his lungs out. Red, legs bicycling, in distress. And then all of a sudden they become quiet and they become listless. And then all of a sudden the legs are going again, turning red again. This very unusual pattern. Oh, geez. I think that, especially those of you who work alone, out in the rural areas where there may be transfers or no transfer, the weather's bad, the next closest hospital is 75 miles away kind of thing. You need to get this publication, Pediatrics May 2016, where they talk about this, because I can't give you all of in 2 slides. But this is an extraordinary guideline from the American Academy of Pediatrics. So if this spell, whatever this thing was, lasted less than a minute in a kid who was less than 1, and one of those things occurred, I think all of them were kind of scary, like turns blue or stops breathing or becomes floppy or rigid or alteration of consciousness. I think all would scare the Jesus out of the parents. You can start applying these criteria, which means that if this is a low-risk brew, that you don't need to do anything much in the way further. And the American Academy of Pediatrics is adamant about it. If the baby starts off and is well-appearing, taking fluid otherwise, is back to baseline, they have to be perfectly normal when you see them, and they can't have any evidence of any other illness, even a cold. If they have a cold, they are no longer a low-risk brew. So here's what they say. First episode, under more than 60 days. They talk about gestational age and post-conceptual age there. And no CPR was done on this little kitty. And there's no worrisome history like no evidence of abuse, no family history of sudden death. I would not think to ask that to a family of, do you have any family history of sudden death? No toxin exposure. They didn't get into grandma's purse. Gastroesophageal reflux is considered to be the most common cause of these, at least. And how do you know that they have gastroesophageal reflux? That's all this spitting up stuff. The spitting up stuff is bringing up acid that goes into the esophagus, which causes this irritation. So what they're bringing up, the spitting up, is acid containing small amount of stomach contents, which could become onto the cords. And as soon as acid goes on the cords clamp shut, and this kid is now is having difficulty breathing. So these are the criteria. You can share decision making with mom and dad about what we're going to do here. Are they amenable to this? And they say you can get a pertussis test. Pertussis has basically been associated with apnea. But you know, no prior history of coughing, you know, I wouldn't bother with that. A brief period of some observation and monitoring. But look at this, they say don't do this. Have you ever heard anybody say don't do something? Don't order any tests, all of those tests there. Don't bother, you know, considering testing. There's a long list of need not order this, need not order that, and that's why you need to get that article. Because obviously you would like to be able to do this in association with some other people, but there are going to be times, because I know that many of you work in very isolated areas where you're going to have to make the call on your own, that this is a low-risk brew case, and we're just going to observe for a while and see how he does or she does. Simple febrile seizures, 6 months to 6 years, 6 months to 6 years. Bilateral. Short, they say short is under like 5 minutes. 5 minutes seems like an eternity to have a seizure, 5 minutes. 5 minutes or less, normal exam when they're done. No Todd's paralysis where they're not moving one arm or not moving one leg. They can't have that. Usually these febrile kids are running around the department terrorizing Mr. Jones in the next room because they're perfectly well again. You know, you gave them something for their fever. People say, well, I'll prevent this seizure here when my kid is a little sick because I'll keep on giving him Tylenol, even if, because you never know kind of thing. These seizures are associated with the rate of rise of the temperature. It's not necessarily how high the temperature goes, it's how fast it gets there. So it's very difficult to catch these rapid rises in temperature. No other causes found. Certainly with a family history of seizures as well. Good idea not to marry your sister. And when people say, is my son going to have epilepsy, doctor? You say, you know the number 2%. So you'll say, very, very, very low chance of that happening, ma'am. Complex febrile seizures, you do the entire workup. These are seizures that are long, unilateral, focal, only an arms moving kind of thing there. Multiple, one after the other, residual paralysis, all of those kinds of things. Nobody would not do a workup on these kids. This is the lab work, the LP, the whole kit and caboodle. New onset seizure, no fever. Oh, you sure don't have a fever? I'd rather do that one. No fever. So maybe the child is hypoglycemic. Some children are born hypoglycemic, and now they check for sugars in the kids who are born because their mother hasn't eaten in 2 days and the little kid hasn't eaten in 2 days. And the little kids don't have a lot of glycogen storage capacity in their liver, so when they have not enough to eat, they become hypoglycemic pretty easily. So there was a study that showed about 6 to 8% of kids who have gastroenteritis will have a sugar like in the 50s kind of thing. And some of them had even worse. Hyponatremia, that's from water intoxication. That mother, you said give plenty of fluids? Well, she gave a lot of fluids. Low MAG, low K, INH. This is in the Vietnamese population. Population have a lot of TB, American Indian population where I worked for 2 years. Everybody knew there that if a kid has a seizure and there's no fever, that's an INH overdose, and they're proven otherwise. And so the idea was gram for gram INH, pyridoxine for INH, gram per gram. But if you know how much the ballpark is. Causes of pediatric dehydration. You know what the causes are. They got these sores in their mouth. They can't swallow. Can't drink very well. They have a high fever. You've seen this chart. forget it, forget it. Just kind of realize what the things are that are manifestations of the hydration is not normal. 90-some% of the kids who come into your ER that are dehydrated will be mild to moderate, mild to moderate. American Academy of Pediatrics says mild to moderate, they get the sippy diet. Here's the Pedialyte. We're going to give a teaspoon every 5 minutes, teaspoon every 5 minutes. If it vomits once, give them some ondansetron, or give it in advance of the sippy diet. But you don't have to be so exacting at this. You're going to look at the skin tone, and you're going to look in the mouth and see what the kid has, tears and the usual things that you would look for in a dehydrated kid. And you make a decision. This is mild or moderate severe. The treatment, mild, 50 mLs per kilo. If the kid's over 10 kilos, he gets 30. 50 mLs per kilo. Moderate, 50, 100, 150. That's what the numbers are, 50, 100, and 150. Mild, moderate, severe. As soon as you get into severe, you're going to be giving the fluids in these 20 ml per kilo boluses. Now that you filled the tank, you fill the tank in 4 hours. They don't drag this thing out of all the day. You determine that the kid's mildly dehydrated. We're going to give this 50 mLs per kilo, and we're going to get it done in 4 hours, and out they go. What diet doctor are we going to give? Full age-appropriate diet. Full age-appropriate diet. So says American Academy of Pediatrics. Now, these kids cannot afford to be hypoglycemic or not eating frequently enough, because they're going to get their sugar is going to go low because no liver glycogen storage. Maintenance. This is cool. I'm almost done here. This thing is blinking at me. A 1-year-old kid weighs 22 pounds. A 22-pound kid is 10 kilograms. This says 100 mLs for each of the first 10 kilograms of weight. That means that 1-year-old kid needs a liter of water a day. This little kid needs a liter of water a day. So you can understand why, if they get sick, if they get some sores in the mouth, they could easily get dehydrated because they're supposed to drink a liter a day. And I think that puts in perspective how much fluid these kids need, and how, if they don't get it, how quickly they can get a deficit for this stuff. APGAR, you'll be lucky to deliver the baby alive kind of thing, and that, we don't really care about canning the score, because we're not used to delivering babies in the ER. And the neonatal resuscitation is all about airway, breathing, avoiding oxygen if you can, keep them warm and dry, those kinds of things. And then this is all the standard pediatric ACLS material. So, enough of pediatrics part 1.
All right, so something a little less intense before our break. It seems I always have to come up here when y'all get ready for a break, so this one's a short one, luckily, to get you through that. But just kind of review some of those big things we see with some of our ENT problems. We'll cover some more of this tomorrow with the ears, and some of this is spread throughout other contents. But luckily, most of this is usually our low acuity, which sometimes it's kind of nice to see those low acuity patients. And like, in and out, it's this, it's this. But let's kind of review some of those guidelines that are out there to kind of help us through these patients. So our first topic to talk about is sinusitis. Probably all of us have experienced this at least once. For most people, this usually just is a typical upper respiratory infection. And even your standard URI is going to have some sinus involvement. But those of us have had, especially a lot of allergies. I live in a nice allergy bowl, so we deal with it every spring, every fall. But you can get a lot of facial pressure that builds up with this. And sometimes does get worse when people bend over, so we might feel like this. But we need to look at how severe are their symptoms and how long have they had this symptomology for. Your typical URI lasts a week, maybe 10 days. And they're going to have some of that pressure. They may have some of that drainage, some of that discharge. Pacemakers drip is sometimes common. Sometimes they'll get a little cough with that as well. But most of this is truly viral in nature, so it's going to be supportive therapy. We may see some of these that actually translate over into a bacterial infection, but that's a very small portion of these patients. And most of these patients should be a watch and wait scenario unless they're immunocompromised or have other high risk factors. So that pressure, that drainage, sometimes a lot of thick mucopurulent drainage, and sometimes it's just kind of clear. They get the congestion. As miserable as it is, the congestion is our body's way of trying to keep out whatever's there. We get that inflammation trying to keep out that virus, but it makes us feel kind of miserable. There's your typical bugs. We talk about bacterial things. These are your common things also for otitis. See those a lot more in younger populations. We'll come back to that tomorrow. But typically these are simple things that we could easily treat. For most of these patients, imaging is not needed nor warranted. Unless you're really worried about something with a chronic sinusitis, then that may be indications for a CT scan. Most of these patients are simply going to be symptomatic supportive care. So the IDSA guidelines give us an idea about what drugs we should use for bacterial infections. But for most people, think about supportive therapy. Sinus washes really do help. Now, some people just hate that idea of trying to shoot stuff up one nose and out the other. I do it. It's actually not miserable. It's pretty pleasant unless you get the water too hot or too cold. But it actually does really help. For some people, that may be all they need. Also, a short course of a intranasal decongestant may be helpful. Big thing to remember there is you are using those like oxymetazoline, phenylephrine, should be limited to probably no more than 3 days. After about 5 days of therapy, people can sometimes get a rebound effect and actually can make their congestion worse. So I usually just tell them, hey, 3 days and that'll be enough. And sometimes with the combination of that plus the wash and maybe an intranasal steroid, that's really all they need. Intranasal steroids, safe, proven, over the counter now, indicated for most things, that easily can be used, and typically that combination is what most people need. If for some reason you're thinking about using oral decongestants, just keep in mind some of those patients that already have uncontrolled hypertension may be at risk for worsening of that. They're also kind of limited to get. You got to go in and show your ID and sign a waiver and get everything to get Sudafed now. But most part, intranasal works. If we do need to use antimicrobials, we do think this is a bacterial sinusitis. Unfortunately, due to overuse, resistance is pretty high. The IDSA guidelines recommend going straight to amoxicillin with clavulanate, that they think this is probably a resistant form of bacteria. Skip the amoxil, skip the macrolides definitely. Our resistance for macrolides is over 25% in all regions, shouldn't be used as monotherapy. Doxy is an alternative, maybe a higher generation, like a third generation cephalosporin, if for some reason. If you've never taken amoxicillin with clavulanate, it's really bad on the GI tract. Diarrhea is almost common. So Doxy may do tolerated better and be just as effective. For most adults, probably a 5 or 7 day course is all they need. Peds might need a little bit longer, but typically 5 or 7 days, and then let's make sure they follow up so that they have resolution. Some of this is based on the Choosing Wisely campaign. You're going to hear this throughout several of these lectures of things that we unfortunately have done way too much of and definitely have cost a lot of healthcare dollars and have sometimes even led to harm. Most of these patients are viral in nature. Let's not treat them as bacterial unless we have other concerns. Now, they've had these symptoms for 2 weeks. Yeah, that may be more of a bacterial infection. But let's try to educate them. They're going to want that prescription for that Z-Pack. They're going to want this. They're going to want this. But let's spend a couple of minutes trying to educate them and even talking about the risk of antimicrobial therapy and what we know it can lead to. And if we actually need to prescribe them, then let's just educate them as well. So a couple studies listed here. As you see, one from that Cochrane review, the number needed to treat was 20. That's a lot. The next one that was in emergency, the Annals of Emergency Medicine, number needed to treat was 18, but number needed to harm was 9. So all it took was half of those patients to get an antimicrobial, and it gave them some GI distress. It gave them some diarrhea. And we unfortunately know we are seeing a lot more problems of C. diff infections. So if you are having to prescribe an antimicrobial, think about the role of a prebiotic or even a probiotic, and those may help in some patients. But definitely if they're not immune compromised, those may be a good option. In someone who is immune competent, has good follow-up care for most of these scenarios, simply watch and wait. And they can always come back to us and follow up if they need to. They do have risk for complications. We definitely know if they have a bacterial, this could lead to erosion. This could cause some damage. Get that orbital cellulitis or sometimes even that venous thrombosis. But those are pretty rare. That's when we encourage people to follow back up. As Rick said earlier, if things worsen, new things happen, come back and see us. Ideally, we'd love to have a primary care provider they can follow up with, but sometimes that's not an option. And definitely when, hey, we'll see you in 3 weeks, that's not really good for most of these patients either. So our foreign bodies in the nose. This is something we deal with mostly with pediatric patients, especially young kids. They love to put things in different places, but definitely can be in some of our patients with mental delays or even acute psychosis. Acute presentation, parents probably report they've got some congestion, maybe a lot of runny nose, that when it's been there for a couple of days, it tends to really smell really bad. And parents bring them and go, their breath just is horrible. What's going on with them? And sure enough, there's something up in there brewing. Hopefully this is something we can easily get out. The big red flag was definitely going to be your button batteries. In about 4 to 6 hours, those can definitely cause some damage to the septum. Those are things we definitely want to get out today. We'll talk about those later with GI stuff as well. Those are the ones that have to come out. I want to try to get most things out sooner just so because they don't become irritating. They cause more trauma. They can increase the risk for infection. But definitely those button batteries. So some things that may kind of help us. What is it? Sometimes it's a nice little piece of plastic, and those are pretty easy to grab. Pieces of crayon are horrible. Nerds are bad. Rabbit food, I don't know why, but rabbit food I run into. It's horrible. It's really hard to get out. So sometimes some topical vasoconstrictors may help. Get a little oxymetazoline and phenylephrine up in there, kind of vasoconstrict those tissues, may give me a little bit more room to work with. Some stuff we can easily instrumentate out, some stuff we can't. But definitely we don't want to cause more problems. I don't want to push this down and actually have them aspirate it. So sometimes procedural sedation is something we have to go to, especially if I can't get a good visualization. It's nice when I have the headlamp and a nice little speculum and I can really go into there. Most of us don't always have those great tools available. They've disappeared 3 years ago. But definitely think about using procedural sedation, using your ENT resources if you have those. Working in my academic ED, not a problem. In my community ED, sometimes that is more of a challenge. But definitely don't want to cause further injury or harm, so let's try those. Sometimes the air trick may work. So having mom or dad occlude the good nostril, give them a kiss, and they blow in their mouth, and sometimes that'll work. If they don't want to do that, maybe a BVM will work if you can just kind of get a good seal in the good nostril and then use that BVM to give them that kiss, and that may work. Stand clear. The rabbit food I mentioned earlier came flying out into mom's hair. I forgot to tell her to stand back. She wasn't very happy, but the kids laughed and laughed and laughed. But definitely it may come out pretty forceful. Some stuff we might be able to irrigate, but definitely if it's organic, anything that's going to absorb that water, probably not a good idea. But definitely if it's something they can wash out, have them lean forward, squirt some water or saline up in there, and it may come out real easily. We've got lots of little tools out there if you have them available. The little ENT scissors, those can work if we got to kind of get into something, but definitely those little alligator forceps are phenomenal. If you have one of those nice little bayonet suction devices, those are great as well. But it depends on what we're trying to grab. One of my favorites is definitely one of these balloon catheters, if you have those available. They're not cheap, but they definitely come in handy when it's something you really can't grab with your forceps, like a bead. Beads are kind of hard sometimes, but with these little devices, if you can get the catheter past them, and when you inflate, as you see there, you can use that to sometimes pull things out. And that works pretty well for things that are kind of hard to grab. Pieces of paper, those are kind of difficult. Little pieces of plastic, sometimes those are difficult. Sometimes you have to get a little inventive. If you don't have like those little hooks or scoops, maybe you can make one out of a paper clip. One of the important things also to think about is anytime you look in one orifice, be sure to check all of them, because they might put it in one nose and the other ear, so definitely think about those things. Our epistaxis. See these frequently. These are more common in winter months because of the dry hair, especially where we deal with less humidity. The most common trials, though, digital trauma. But also think about other trauma, also think about infection, also think about foreign bodies. Those are some of our other big things. You know, for years, may have been told, hey, it's elevated blood pressure, it causes the nose to bleed. Probably it's the reverse. Nosebleed starts, they get anxious, fight or flight kicks in, that's what shoots the blood pressure up. Most people, it's usually going to be an anterior bleed, and usually those can be well controlled with direct pressure. Unfortunately, most people think this is all they're going to do. No, it's 10 minutes, it's 15 minutes sometimes, especially if they're on something that's going to alter their coagulation. But having them hold direct pressure usually works. Most of the time this is anterior, and that's going to help. But definitely look for things that may think about something else. Get that good medication reconciliation. The G herbals, people take them a lot. Those are all going to have either some little antiplatelet or anticoagulant effect. Many patients don't consider those to be medications. They're over the counter, they don't count. But ask about them. Do I see any petechiae, any ecchymosis anywhere else? Are they prescribing if they brush their teeth, their gums bleed, or if they blow their nose, there's blood there? Just kind of thinking. Most of these patients don't require anything other than intervention. They don't require any diagnostics. But occasionally you'll get that patient who is anticoagulated and they bleed a lot. And they come in, they're a little dizzy, you stand them up and they get kind of orthostatic. That patient might be the one I did check. If they're on warfarin, I probably will go ahead and check their INR just to make sure they're not super therapeutic, and maybe to tell them, hey, it's okay to hold your dose the next day. Or no, you're good, or actually maybe we need to reverse them. So look and see what you can see, and this is when suction and a good light source really comes into handy. If I can go in there with my little bayonet suction and I can find the bleeder, perfect. This is a great time to either do some topical vasoconstrictors or sometimes even some cautery. Biggest thing is, especially when I'm talking about the septum, I don't want to cauterize both sides because that definitely can sometimes lead to perforation. But most time, direct pressure, and some people just go ahead and have them squirt some Afrin up in there and do direct pressure. 15 minutes later, take a look, and usually it's stopped. If I can't find the site, now I'm more concerned about a posterior bleed. And definitely those are usually more of our older patients. But definitely sometimes none of this may work, and they may have to go to a tamponade device. If I have the option of using some of these preformed devices for either anterior or posterior, those tend to have lower complication rates than using gauze. But definitely if I've got that posterior bleed, I'm going to have to use something that's got a tamponade device so I can inflate those. Got a couple of them listed for you here. Typically, if it's a material that's going to be absorbent, it's going to maybe be impregnated with thrombin or maybe sometimes even TXA. Most of the manufacturers will recommend lubrication is going to help as long as it's not a balloon and you don't use petroleum lubrication. Those I want to make sure I'm using water-based lubrication. There may be some benefit of coating these devices in a topical antimicrobial like bacitracin for the concern of toxic shock. Typically, these are supposed to stay in place for no more than 2 or 3 days. So that's pretty limited, but definitely if it's not balloon-based, you may want to coat that with some bacitracin, some Neosporin. Gives you some lubrication, but also may help control in that local flora. Definitely want to make sure these people have follow-up. Ideally, if they've got that posterior bleed, those are people I really want to bring in for observation or at least for admission. Especially in the older patients, they're higher risk for brain dysrhythmias due to that increased pressure there in the back of the pharynx. Most of your anterior bleeds are Kesselbach's plexus. We can control those pretty easily. Think about your complications. Definitely if that stays in place too long, so ideally 2 to 3 days, I want them to follow up in 2 days and get a recheck and hopefully get those removed. But definitely if they have some dislodgement, they may have aspiration with that. If it stays in too long, the risk of infection. And I mentioned that brain dysrhythmia. But that's definitely a time to talk to ENT, talk to hospitalists. Hey, we need to put this guy in for observation. If I'm sending this patient home, I probably want to recommend they avoid, obviously anything that's going to increase bleeding. Probably I don't want them going home and drinking a lot of hot liquids, a lot of hot soups, because that warmth is just going to cause vasodilation and may increase the risk of bleeding. Most of these patients require nothing more than just topical stuff. Rarely do they ever need systemic in the way of antimicrobial therapy unless you're worried about another type of infection. So nasal fractures. How many people get x-rays? You don't have to raise your hand, but probably for most people, we don't need them. If it looks like it's broken, it's broken. It really won't change the treatment plan. Some people like to reduce these early, some people like to wait. Most ENTs will say, hey, if it's been less than 6 hours, we can go ahead and reduce it right now. Not a pleasant experience for the patient. But if it's been more than 6 hours, they have a lot of edema, well, let's just wait, let the swelling come down, and then they can reduce it. Now, if I'm worried about multiple injuries because of assault, then definitely imaging may be appropriate. But if it's just isolated just the nose, probably not a big concern. I do want to get a good inspection inside the nares. I want to document the presence or absence of that septal hematoma, and we'll look at one of those in just a moment. But if they have a septal hematoma, that has to be drained. Otherwise, that will cause significant destruction of the cartilage and a significant deformity. If I've got a lot of bleeding, then think about also, is this a risk for a basilar skull fracture? And I don't think I mentioned this earlier, but if you have the patient lean forward and the flow increases, that makes me a little bit more concerned they may have something there with the cribriform plate than just a nosebleed itself. We can always do the halo test, or if it's clear, we talked about earlier, checking it for glucose. So as you can see here, this guy and this kid both have a nasal septal hematoma. That has to be drained. If not, it will destroy that cartilage. This is a time that actually doing some topical anesthetic really helps. Medical cocaine works really well here because it gives you both the anesthetic and the vasoconstrictive property. Some places have that available, some places don't. Some patients freak out when you tell them you're going to put some cocaine up there. But medical cocaine, not the patient's supply, works really well because what I need to do is go in here and either open that up with a scalpel or a needle and drain out all this blood. And I need to take like a Q-tip and kind of express out all the blood and clots, and then I need to pack it. And I'm going to pack it on both sides to keep that compressed against the septum. Because if this blood does reaccumulate, it's just going to cause more damage and end up causing that deformity. Most will recommend that if I have to pack this, then I probably should go ahead and put them on systemic antibiotics to reduce the risk of infection. Probably amoxicillin with clavulanate is going to be our choice. But these patients definitely need close follow-up, probably within 12 to 24 hours with ENT, just to make sure this has stayed compacted and not reaccumulated. We'll talk about this tomorrow more when we get to ears, but definitely this is the same thing that happens here with the cauliflower ear. This guy, probably a boxer, wrestler, lots of fights. That blood didn't get drained from his ear, and it destroyed the cartilage. Same thing will happen here with the nose and gets that classic saddlebag deformity. So probably most of us don't want that patient to come back going, look what you did to me. So make sure you get it drained, you get it packed. If that's something you can't do, then get them in a CENT that day to make sure this is managed. Our famous dental patients, our toothaches. Most of us don't have dental providers rapidly available, and we know that dental health care, unfortunately, is a big area for improvement in many of our areas. But if that patient comes in, they truly have a toothache, if they have an abscess, we can usually make that feel a lot better. You know, sometimes it's like, it just hurts all in here. If I want to get a good exam, do I see a pus pocket? If they typically have that typical periapical abscess, you can usually see that little area of fluctuation. That can be really drained pretty easily, and they will get some relief with that. If you can't identify anything, take your tongue blade and just kind of percuss on their teeth and see which one hurts. And that usually kind of helps you identify it. We'll look at some x-rays in just a moment. Usually they're not needed, but definitely you can kind of see what happens up in there, because if this is left, it can cause some erosion and destruction of not only the maxilla or the mandible, but also the root of the tooth itself. But most of these have good suction available, because it's going to kind of pour out and taste horrible for them. But drain that, and then usually put them on something that's going to cover all those oral floras. And big thing we need to think about here is most of the time this is also involving anaerobes, so that's where your Clinda or your metronidazole is going to come in handy. Unfortunately, Clinda is one of our big culprits now with C. diff, so some of us may aim towards the metronidazole, but then we have to worry about alcohol, and that's not a good place here in Vegas or a lot of other places to do. But as you just see here, that's that classic periodontal abscess. Got that nice little fluctuant pus pocket. Drain that, they're going to feel a lot better. Go ahead and cover them with the typical stuff and have them follow back up. But as you can see here with these x-rays, this is what's going to happen if this is truly left untreated, because it can cause significant damage and erosion. Most people, localized, we can treat that. We'll talk about pain relief in just a moment, but as we'll talk about later with ENT stuff, definitely if someone has a true dental infection and it's not treated, that could lead to some bad things like Ludwig's syndrome or Ludwig's angina and some other problems. So truly we do want to treat this if they actually have an infection. So those dental trauma patients we see, if it's an avulsed tooth, it's partially removed, try to put it back in the socket. What I do is just have them bite down on some gauze, some 4x4s, and reseat it. If it's fully avulsed and it's an adult tooth, we want to get it back in that socket as soon as possible, if possible. Now, if I'm really concerned about a maxilla or a mandible fracture, we're not going to do that. But that tooth roughly has 1 hour. As the arrow points out here, it's called the periodontal ligament. That ligament is really important for survivability and reimplantation of that tooth. We've got about an hour to get it back in place. Well, unfortunately, we don't usually see them within an hour, or they're still in our waiting room waiting with everyone else. But that is going to improve the chances of successful reimplantation. I want to gently rinse this off. I don't want to scrub it because I don't damage that ligament, and put it back in place. Now, obviously, if they're altered, I'm worried about aspiration, probably not a good choice here. Then definitely could put it in some type of preservative. Your pharmacy may have a preservative solution called like Haint solution. If not, I can use milk. Water's not my best, but at least it keeps it kind of wet. But if you're worried about fractures, not going to be a good option. And definitely if that tooth is fractured, that's something we're going to have to see a dental provider for as well. So sometimes we see a lot of dental trauma, sometimes we don't. But if you're by yourself, you don't have a lot of good close dental resources, this is the dental box information. Has some pretty good stuff there for splitting and immobilizing these teeth. Most of us don't have regular immobilization stuff there. We can use suture, can use other things to get those in place, but this is a pretty good investment if you see a lot of dental trauma and don't have a quick resource to get them over to be seen. Our diagram, what tooth is what? I had to look this up. You know, it's like, do they have their wisdom teeth? Do they not? But 8, 9, 24, 25, those are your middle teeth. So if you got 8 and 9 and you got 24 and 25, just count in the other direction. When you're talking to Max Face or Dental and go, hey, it's tooth number 10, they are kind of impressed. They may go, are you sure it's 10? But yeah, get an idea. I'll look these up real quickly. If your patient does have true dental trauma and it involves just the enamel, that's an Ellis-1 fracture. That can be followed up anytime with a dental provider. It's purely cosmetic. But if they have a fracture that goes through the dentin, that's now what we call an Ellis-2 fracture. That person now needs to be seen within the next 24 hours. They're going to have a lot of pain with that because the dentin's going to be kind of sensitive. And if it actually goes through the dentin and into the pulp, and now part of the root's exposed, part of the nerve's exposed, that's an Ellis-3, and those need to be seen as soon as possible. Unfortunately, most of those patients are going to end up requiring a root canal to stabilize and fix that problem, but definitely we know it's important for cosmetic, but also for health as well. So our last little tidbit here, patient comes in with isolated toothache. One of the best things we can do is this supraperiosteal nerve block. All you need is just a little bit of lidocaine, a little bit of marcaine, a syringe, go right above that tooth, bevel side in, and just inject 1 or 2 mLs of anesthetic, and they're really going to get some decent pain relief. If you want to, you can also go behind it and do it on that side, or we can actually do a facial block if you're able to do those and get the whole area. But it's amazing you'll actually have patients that come in and go, hey, can you do that block thing again? Because it really does help their pain and gives them good relief for several hours without having to go to something like an opioid or even an NSAID. So this definitely may make patients more comfortable. You can do it on both sides, just plain lidocaine, plain marcaine, and works pretty well to give them some relief. Maybe also helpful to use some other things like acetaminophen, ibuprofen. If they have an infection, let's treat it, but most of these toothaches don't have a visible infection. There's not much to do for that. Just have to try to get them into a dental provider if available. All right, thank y'all so much. Looks like it is 3:30, so it is time for y'all's break, and we'll start back about 3:45.
part of adult chest. And we're going to actually go into the land where everyone in this room, everyone who practices emergency medicine will get burned at some point in your life, and that is the land of pulmonary emboli. It just is what it is. It is a very wily diagnosis. If you think about pulmonary embolism, is if you went down to hell and you said to the devil, create some disorder where it is a lose-lose just all the way across the board. Like make it hard to diagnose, make it so that the treatment that we have is super high risk, make it so that all the tests we have could expose people to radiation, make it as hard as bloody possible for us to make this, this diagnosis accurately and catch it in everybody who might have it. And that is what pulmonary embolism is. It will humble every single one of you if it hasn't already. It's just one of those things where, and I see stories all the time. I have a Facebook group of emergency docs that we kind of all keep in touch with each other, and somebody's always saying, happened again, got myself burned on a PE case, never would have suspected it, So it just is one of those things you have to kind of get your head around, that you will miss a case, at least one, of pulmonary embolism in your career. But that doesn't mean you're a terrible person, and it doesn't mean that you shouldn't be practicing emergency medicine. It means it's a hard diagnosis to make. It's very wily. What the whole reason it happens, if people get any sort of venous thromboembolic disorder, is 3 things have to happen. You need to have stasis in a vessel of some sort. So there has to be a reason that the vessels aren't moving as well as usual when you're kind of living your daily life. That's anything from being immobilized, and that can even be as short as 3 days, starts to increase your risk of getting stasis enough to get sort of that triad, that Virchow's triad. But we also have things like people have poor circulation. COPD or CHFers have this. So people who are immobilized or have sort of just stasis problems where they just don't circulate terribly well. So that's one thing. The blood kind of has to sit stagnant for a little bit, or relatively stagnant. You have to then, this is point number 2, you have to damage the endothelium. Something has to damage that endothelium. Usually it's something like trauma, right? So we worry about this in people who have like immobilizations and things, or have had trauma. So we see that in trauma. We see it right now most commonly, honestly, in what we do to people. Think about it, we send people home all the time with IV lines in, right? All the time. Well, that's been poked through that vessel wall, it's hanging out in that vessel, and it's a lovely nidus for a clot to start. And smokers are more likely to have endothelial damage. So along their endothelium, they're just more likely to have damage there. And then the third of the 3 things is the thing we all think about the most, which is hypercoagulable stuff. People who are pregnant or immediately post-pregnant. Cancer is the big one, right? That's the one we worry the most about. People on certain hormonal therapies will have this. People who have lupus definitely have an increased risk of clotting. There's no question about that. HIV, nephrotic syndrome, and now, of course, COVID. COVID has become the sort of the king infectious disorder that causes people to clot. So stasis, things not circulating as well as they should, something that's got damaged the endothelium at a spot, often something we do, and then finally a hypercoagulable state. Those 3 things consort together to make somebody form a clot somewhere, and then the worry is that it ends up in the lung itself. Now the thing about this is when somebody was down there chatting with the devil, is they said, let's make the symptoms tough. So there's not one person in this room who would miss the case of the person who gets off an airplane, has sudden severe pleuritic chest pain, a heart rate of 140, a saturation of 82%, and tachypnea. No, and oh, by the way, let's add a little coughing up of blood just to add a little to that. Oh, and by the way, a big old leg that they noticed when they stood up. None of us would miss that. Not one of us would miss that. The problem is that is not the case for a lot of these at all. They'll come in with a little shortness of breath. I mean, how many gajillion things cause shortness of breath? They'll come in with pleuritic chest pain. Well, we know, yes, PE we worry about, but pneumonia can do that, pneumothorax can do that, lots of things can do that. So could it be costochondritis? So it's not specific to pulmonary embolism. They can have syncopal episode, but it's not, I'll tell you, syncope in PE is never just, wow, I fainted and gosh, I have a PE. It's like, I had some chest pain. I was really short of breath. I have been short of breath for a couple of days. Now I finally fainted. It's never in isolation that somebody is syncope with nothing else when it's a pulmonary embolism. So that's not that common. But these really vague complaints are extraordinarily common. And then if you think about the findings we have when we examine somebody for a pulmonary embolism, let's just go for those lungs. They are tachypnic. Well, my goodness, tachypnea is so nonspecific. A million things cause tachypnea. They're tachycardic. Well, yeah, so so bajillion things cause that as well. DVT, if they have one, great. Okay, whoa, that's helpful. That's handy. Big fat leg, feeling a little short of breath. Okay, now I'm really worried. That's helpful. Wheezing, rowels, again, non-specific. A lot of this jazz, fever, this is the other thing. Like if I ever make it to heaven, God and I are gonna have a chat. Because besides the fact that the female urethra is way too close to everything else down there, and that should probably be moved, just saying, the reality is God needs to do a few other things. He also needs to fix this idea that a PE can cause a fever. So PE in and of itself can cause a temperature as high as 101. Well, now what? I have rowels, I'm short of breath, I have a little bit of pleuritic chest pain and a temperature of 100.5. Well, I would love that to be pneumonia, but that could just as well be a pulmonary embolism. It just makes it really hard for us to diagnose this disorder. And if they come in shock, if they're truly shocky, rarely is that something that's subtle. To be shocky from a pulmonary embolism, it has to be massive, absolutely massive. So that is usually something that's not subtle. It's these more subtle ones. We're good at the bad ones. We're just these subtle ones that we miss that are a problem. So what are our options? What are our tools in our bag of tricks that we can do to diagnose pulmonary embolism? Well, chest X-ray. Chest X-ray turns out to be just ghastly. Despite the fact they taught you the findings with pulmonary embolism on chest X-ray, it is not very helpful at all. I will tell you what is helpful. Somebody's hypoxic, tachypnic, short of breath, and tachycardic with a totally normal chest X-ray? Something's not right here. In fact, that tells me I'm more worried about pulmonary embolism, because if they're tachypnic and hypoxic, why isn't there something in those lungs? Well, something's preventing them from oxygenating. It's probably something in the blood, the vascular system. So a totally normal chest X-ray is quite common in people who have pulmonary emboli. The findings that you're expected to see, all these, they can see atelectasis, you can see people who are splinting, you can see all these things are not very specific. And we were taught to look for this kind of jazz. Look for Hampton's hump, look for Westermarck sign, look for oligemia distal to whatever. It's like, are you kidding me? By the way, this poor baby here needs to come to Las Vegas. This poor person has both Westermarck sign and Hampton's hump on the same chest X-ray. That person needs to come here and put like $1 billion down on the roulette wheel, because that never happens, absolutely never happens. So just know that the chest X-ray findings, and think about it, I'm gonna go back to these. If you had somebody coming in coughing and dyspneic and a little bit of a fever, well, that would be an infiltrate, right? I mean, it's like, well, that looks like a pneumonia. So this is where we can get in trouble. This is where it's really frustrating. And I'll talk about how we actually go about fixing this in a second. As far as EKGs, so you were all taught S1Q3T3. S1Q3T3 in pulmonary embolism, big fat lie. Just saying, big fat lie. Can happen, extraordinarily uncommon, and not specific to pulmonary embolism. The most common thing you see, honestly, in a not massive pulmonary embolism is a normal EKG, or maybe some sinus tachycardia. That's it. All this stuff, P pulmonale, S1Q3T3, right bundle branch block pattern. This EKG is only going to confirm what you already know when you walk away from the bedside. This person is sick. This is a person who's hypoxic, tachycardic, they got a big leg. This is not subtle. This is not subtle. This is the sick person. So usually in that person where I'm just not sure if it's a PE or not, this isn't there. The chest X-ray is usually fine, this isn't there. What about the ABG? Let me get an ABG because maybe they're hypoxic. Well, we don't need that anymore. First of all, not only do we need it, a normal ABG in somebody that maybe it's a PE is gonna hurt you. Because what it's gonna do is convince you it's not there when it very well could be, and it's a terrible tool to differentiate. Turns out more than half of people with non-massive PEs have totally normal ABGs. Totally normal. It doesn't help you. It does not help you. And in fact, it has been flat out said, do not get them. If you're worried about pulmonary embolism, skip over this entirely. Do not get them. You have a pulse ox that's good enough to show you what their pulse oximetry is. You don't need any kind of AA gradient calculations. Pulse ox is fine. So skip this. Just don't do it. Now, D-dimer would be nice, right? This D-dimer thing where you break down a clot and you get these D-dimer things floating around in your body. It'd be lovely if we had a number that said, well, above a certain D-dimer, it is obviously a pulmonary embolism. It turns out that doesn't work exactly like that. So right now, for instance, if I were to walk around this room and put an IV in every one of you, I'm gonna walk around and just start an IV in you guys. I need some practice. I'm just gonna start an IV in everybody. Almost all of you would bump your D-dimer. just from having that damage done inside your vein, just from having an IV put. Now, it wouldn't bump a lot, but if your D-dimer is already kind of in the high normal range and it bumps you a little higher, it's going to bump you into a range that might be looking higher than what's true. So it turns out D-dimer is not a stratification tool. It is what you employ after you've decided how likely it is somebody might have a PE. And I'm going to come back to that. D-dimer is fabulous used correctly. It is terrible used wrong. Absolutely terrible. And it is not something to be done in this D-dimer, BNP, troponin triumvirate. The road to hell is paved with D-dimers, BNPs, and troponins. Ordering these sort of for any pain from sort of sternum to symphysis turns out not to be a very good practice, and I think we know that. It's tempting in triage to order a bunch of this jazz. You have to stratify first before any of this stuff is particularly helpful. Now, D-dimers turn out to be more subtle when you're actually trying to learn how to interpret them or use them in cases that might be pulmonary emboli. So we do know that how old you are depends what is a normal range of D-dimer, and whether you're pregnant or not depends what's a normal range of D-dimer. And we have learned that not only are there cutoffs for what's considered a positive or not D-dimer in just everybody, that if you are over the age of 50, we can use what's called an age-adjusted D-dimer. So I'm 63. So my D-dimer normal, lower end of normal, is 630. It's my age times 10. So for anybody over the age of 50, it's their age times 10. So for a 75-year-old, a D-dimer of 730 is normal because their lower limit of cutoff for positive D-dimer is going to be 750. That has actually proven to be helpful in applying the use of D-dimer and deciding what we do in the algorithm I'm going to show you. Pregnancy is a little bit dicier. We absolutely know that your D-dimer goes up in pregnancy, absolutely does. But as far as are there cutoffs where we can say this is a normal D-dimer and this one isn't, we are still chasing that sort of golden cow. We haven't really found it yet. We haven't found the cutoff that we can say for all pregnant women in their third trimester, X number is acceptable. We're getting closer, I will tell you, we are getting closer. There's a study that just came out earlier this week on using the modified Geneva rule with some modifications to it for pregnancy. There's the years trial I'll show you in a second. We're getting there, but right now, don't let anybody tell you that a D-dimer of X number is the cutoff for everybody who's pregnant. It just isn't. So be careful, we're getting there, but we're not quite there yet. So your concepts now, so we know all the trouble, we know the playing field that's problematic. So now what you're gonna do is if you have a person who might be a pulmonary embolism, it's something you're considering, you are going to risk stratify that person first. Before you order anything, you're going to risk stratify that person. And how do you do that? Well, you can do it one of two ways. Most of us will basically do something like the Wells score. And what that does is gives you a likely, unlikely kind of deal. The key to this, though, is to determine when you walk out of the room whether you're even going to consider it at all in your differential. Back in my internal medicine days, I was taught that basically for anybody with a pulmonary complaint, that a pulmonary embolism should cross my mind and I should always think about it. That's actually not true. Most people who have pulmonary complaints aren't having a pulmonary embolism. So sometimes you're going to walk out of that room and you're going to say, this is a patient with asthma. What they're having is an asthma exacerbation. It's just an asthma exacerbation. That's why they're having a little bit of chest pain when they breathe. That's why they're wheezing. That's why they're short of breath. That's why their SAT has dropped just a tiny bit, because it always is for them. I'm not going to think about PE. And you're not going to start anything at all. Because remember when the devil made this whole deal up? The tests that we do are problematic, and the drug that we might give them is problematic. You don't want to even go down that pathway if you don't have to. So you're going to be dividing people into no risk at all, and you're going to stop, nothing more. Then you're going to have people divided into low risk, intermediate risk, and high risk, or low risk and high risk. Either of those two dividers is fine. The low is key, though. The low is absolutely key. If there's no likelihood, you stick with whatever you were treating before. You don't go down the PE pathway. Low risk and beyond, you are going to do some stuff, and we'll talk about that. How you decide what the risk stratification is, I will tell you, the data says that they've studied physicians. I don't think they've studied PAs and NPs yet on this, but when they've studied physicians in their gestalt compared to what the Wells score says, a physician's gestalt is pretty good as far as comparing to what a Wells will stratify somebody out to be. And I think that makes some sense. Wells is not perfect. We know that Wells has its problems. But if it's something you're not comfortable with, or you want a backup, something to go to, it's worth doing a Wells. And what I recommend doing is for anybody where PE is like, okay, I really need to think about this. It's not a PE for sure. I need to think about this. And I need to stratify them. What you're gonna do, what I recommend doing is do a Wells on purpose, but then let your clinical gestalt trump that. So if the Wells comes out a little bit low and you're like, I just am more worried about that, go ahead and let it, because here's why. This is what the Wells is, and we all know there are problems with the Wells. There are definitely problems with the Wells. The biggest problems, so two of them I want to mention. What if, let's look at the third one down. You get 1.5 points on the Wells score if you have a heart rate of 100 or higher. But what if the patient's heart rate is 99? They technically get no points. But that doesn't mean you're not worried about them. If you're clinically worried about them, it's like, okay, well, I'm gonna, yeah, it may calculate out low, but I'm more worried than that. Go ahead and let yourself trump this thing. The thing that really has been the problem here is this other diagnosis. What a weird way to word this, right? Other diagnosis less likely than PE. Wow, that's kind of a weird thing. What that's basically saying is, sure, it sounds like asthma, but boy, when I really think about it, I think PE is more likely in this one, even though the person has a history of asthma. And that is something people have a lot of trouble with, and that's one of the things that's been really sort of criticized about the Wells. The reality is that's why I go ahead and calculate this out. If it puts somebody sort of in the low or the high group, the likely, unlikely group, go for it. But if you're still worried beyond that, go ahead and use your clinical judgment. That's absolutely fine to do. But the key is you have risk stratified to start. The reason it's important to do that, so first I have my no likelihood group, I'm doing nothing. Okay, I'm doing nothing. But now I've got this pot of people that's low likelihood. Okay, I don't really think it's a PE, but I'm concerned enough, I'm not gonna just let it go. Well, what's nice about that low likelihood group is you can apply what's called the PERC rule to that group of people. So you now go out, get your MD Calc out, and it pulls up 8 things. And all 8 things have to basically not be there. So basically all 8 things, all 8 criteria have to be met. And if one is missing, you're done. So look at this. I mean, if somebody's 51 years old, you can't even apply the PERC rule. So all 8 of these have to apply. But the reason it's nice is if all 8 apply to a low-risk person, you can stop. Their risk of a PE that's symptomatic and causing any trouble down the line is less than 1%. It's 1.6%. It is really, really low. So as far, you are totally justified, medically justified in stopping at that point. Not even a D-dimer. So I've already peeled off my no-risk people. Now I have my low-risk PERC negative people, no tests in them either. So I've now peeled off 2 groups of people where I'm not gonna do anything for them at all. If they don't PERC out, that's the group you're gonna do a D-dimer in. And that's the only group you're gonna do a D-dimer in. So what you're gonna do basically, I'm gonna back up a second. So now I have that low risk group, it's like, the PERC doesn't work, it's a 52-year-old. Or the PERC doesn't work because they came in with a heart rate of 102. Okay, so oh well, I can't use the PERC rule. I'm gonna take that low risk group only, not the high risk group, the low risk group, and that's the group I'm gonna order the D-dimer in. I'm gonna use an age-adjusted cutoff if that's appropriate for their age. I'm gonna use my hospital's cutoff for what's positive or negative D-dimer in that group. The reason you're not gonna use it in the high-risk group is if it's normal, it's gonna make you feel better, but it doesn't mean the patient doesn't have a PE. So all it does is, again, lead you astray in that higher risk group. You're gonna go on to image that high-risk group. So here's your algorithm. In our little green box is our suspected person, okay, non-high-risk PE. So this is where the high-risk group goes off and gets their studies to start. Now what I'm gonna do is I'm gonna assess my risk. Right? If somebody is no risk, they're not even on this anymore. If somebody is low risk, I'm gonna take them over and I'm gonna do the PERC. If the PERC rule is, they're all good to go, they go home. If it's not, now I get to my D-dimer. I use an age-adjusted D-dimer there, and if it's positive, I move them on. If it's negative, I don't do anything. I send them home. This will allow you to do if you follow this rule, which a lot of people don't, by the way. They've looked at studies of our practices, and we don't do this. I don't know why we don't do this, because the value of doing this is, when you miss the PE, you will undoubtedly miss. You will miss, because you will. This disorder is just wily. You will have had a standard practice that is completely medically justifiable that you have done every single time you've ever seen a patient. so that when the one does slip through the cracks, you are completely justified in having, because that's just what happens in life. This is a reproducible, medical legally and medically sort of wonderful foundation to practice from, because it'll protect you all the way around. It protects, no one wants to miss anything, but you will, because this is just a tough diagnosis. This algorithm will catch as many as you can without over-testing people. Over-testing can be problematic as well. So this is perfect, because it's the sweet spot in how we work up pulmonary emboli. Now, the imaging study to get kind of depends where you are. And I will tell you, 99.999% of the time, what we're getting on people is a CTPA, which is fine. There are instances where it's recommended to do a VQ scan. The reality is, I don't know about you, but getting a VQ scan, I don't know. It's impossible at our place to get a VQ scan. And for a while, there was no isotope in the United States to even get it. So usually most people are getting CTPAs. They're absolutely fine to get. If you do get a VQ scan, what you really only need usually is just the perfusion study. So the CTPA is what most people are getting. Here's what the images look like. And by the way, once you get used to looking at these, which is why I recommend you look at everything, even if you don't read them yourself, look at the read from the radiologist that says on slice 51 on the right first branch of the pulmonary artery, you'll notice an embolism. Go look at it. It is amazing. And once you get looking at these things, it's like, oh, there it is, oh, there it is, oh, there it is. Oh my gosh, there's a saddle. You get really good at seeing these things. So, and then VQ scans are just mushy, so forget that. Now, what if they're pregnant? So we know pregnancy and D-dimer is a problem. We know pregnancy increases your risk of clotting. We know peripartum increases your risk of clotting. And we don't want to radiate some pregnant woman. Okay, I don't want to radiate her and her belly, her baby. I don't want to do that. So there are issues that come up in pregnancy that when we're trying to work them up. The Wells score turns out not to work very well in pregnancy. The symptoms are so vague that women will have who are pregnant. Think about it. So my daughter is literally term pregnant. She is delivering Thursday morning. She is out to here. She can't breathe. She can't sleep. She can't swallow. She has GERD. All the things, all of it. You can't, because there's like your baby from here to here. So the symptoms that a woman has when she's term are often symptoms that are a lot like a pulmonary embolism. I'm short of breath. I'm short of breath when I walk. It's miserable. It's hard to diagnose this. It is extremely hard. Your clinical gestalt isn't as good. The Wells is not as good in this. So you have to be a little bit more careful, and we don't want to radiate. So you need to kind of adjust your clinical suspicion and how you approach a woman who's pregnant. The American College of OBGYN knows this is a problem. Now, they've done a couple of things that I don't always agree with, but this is sort of their current go-to. They say do not use a D-dimer in pregnancy. They just say don't. There's been quite a bit of pushback against that statement, because it turns out that a low D-dimer in a low risk, boy, I don't think it's a PE, but I'm just a little bit worried, even pregnant person, turns out that a low D-dimer is pretty good. That being said, American College of OBGYN says don't do it. What they do say, and this does make sense if I don't want to radiate somebody, is if I have a woman who's pregnant and she is sounding like it might be a PE and she has leg symptoms, and that's even a pregnant woman who has bilateral edema, which a lot of women do, go there first. So go there first. If there's a clot down there in either leg, or any evidence that there might be a clot, and those of you who did the ultrasound course know how to do these things now, looking for compression and all that jazz. If there's anything that's suggestive of a clot here, well, you already know you're going to have to treat her anyway. So she's going to get treated anyway. You don't need to go radiating like crazy up here. So you're going to start down here in a pregnant woman. That's what you're going to do. If it's negative down there, and do both. If you have one to go for, it's like, oh, that one's symptomatic, go there. But if not, then do both. If that's not the thing, then what you're going to basically do is go ahead and go up to the chest. And what they're recommending really to do is a CTPA. Now, I'll tell you, the other thing that has come up is whether an MRPA, using basically MR technology instead of ionizing radiation from CT, is that an alternative? Again, not quite ready for prime time. It's being looked at. There are some studies that have looked at this. It's tiny. I don't think you're wrong to do it, but I don't know anyone that's going to back you that that's like the be-all, end-all, we know how to interpret them kind of thing. So stick with what you know, the CTPA. So here's kind of the look in pregnancy. Go to the legs first. Compression ultrasound, which is what that CUS stands for, go there first. If not, you can get a chest x-ray in a woman, and the only reason for the chest x-ray is to basically say, oh, look, there's a pneumonia, or oh, look, she has a pneumo, yay. It really doesn't help you. We end up having going on to that CTPA. This is the algorithm I mentioned to you that they're looking at to try to figure out how to integrate clinical findings and a D-dimer cutoff, I think they used 1,000, in women who are pregnant. Now, this is a study that came out, I think, 2 years ago. This has been followed up with a smaller study. We're looking into whether something like this would be its own algorithm for women, or something like the modified Geneva that just came out this week, whether those will be something we can use in women. I think right now we're still stuck with having to do our best clinical judgment, go for the legs first if there's any hint there's anything down there, and then if not, do a CTPA or observe. You can observe that woman if you're not super worried. You can observe or talk to her OB. But the imaging is basically CTPA or legs. Now, treatment. We know for treating PE, heparin was the be-all, end-all. And if it is a pregnant woman with a PE, it is low molecular weight heparin. That's what they get treated with during their pregnancy for anything embolic, thromboembolic. So DVT, PE, it's low molecular weight heparin. But for most people now, we're not doing heparin. What we're doing for most people now is the novel anticoagulants, which does bring up the idea of, can you send somebody with a pulmonary embolism home? Now that used to be like so easy. It's like, oh, you have a PE, we're admitting you, done. It's like so easy. It was like, check, boom, next. Can't do that anymore. So you can send some of these people home, but I will tell you there's the Hestia criteria, there's the PESI criteria. There are things, you better have a protocol at your hospital and ask at home sort of what the protocols are, how to make sure somebody is safe, how to assess them medically for that, make sure they have follow-up, they have doctors that can see that they can get the meds themselves, because starting and stopping these meds is a disaster. So novel anticoagulants are the way most people start. Most people honestly are still getting admitted, and they're getting sort of tuned up and sent home with all the ducks in a row when they're sent home from home. Can you lyse a PE? So yes, you can, but the only time right now that's really considered okay, that it's kind of an accepted practice, is in somebody who has dropped dead from what you think is a pulmonary embolism. And better yet, someone you can confirm that their whole right heart is enlarged on echo or ultrasound, that they have a big PE that's causing the problem. It's really not meant to be used for things like subsegmental PEs or bigger ones where people are still a little unstable. I will tell you what a lot of hospitals are doing is forming basically PE teams, basically thromboembolism teams, where people will come down and do all of that assessment to determine whether lytics have any role whatsoever in patients that aren't arrested. So that's the deal with thrombolytics right now. Again, I mentioned most people are admitted, but they can go home. Here's some of the criteria you can use, and you're going to have to find out your own institution and how it's handled there, because Kaiser's done it forever, Canada's done it forever. But for down here, it's still a relatively new thing, and just make sure it's a safe practice where you are. Now, the other thromboembolic thing is DVT, right? Basically, that's where a lot of the PEs come from. It came from there, and they go up to their lungs. It's a really, really, really common problem. They're very much related as such. And the approach is very similar. You're going to see somebody with leg symptoms. And I'll tell you, you're going to see a million legs like this. Your job is going to be determined, is it cellulitis? Is it pulmonary, or is it a DVT? That's where ultrasounds come in handy. Remember, things like necrotizing fasciitis should be in your differential as well, just in case that red leg that's big is something worse. But DVT is something you're going to see a ton of these things. And the diagnostic approach is very similar. Risk assessment, you do a Wells kind of scoring on this, you D-dimer test in the algorithm I'm going to show you, and then you ultrasound. And the biggest controversy here is if the ultrasound is negative today and the dimer's up, do you bring them back and re-ultrasound them in a week? And a lot of people do that practice. So that's one thing you can do. Positive, you're done. Negative, they can be treated as outpatients for sure. Here's the Wells criteria for the legs for DVT. This is something that's, again, in your MD Calc. Just go to that, add your score up. It's usually likely or unlikely that you're going to come up with a score. And here's your algorithm. This is much more straightforward. It's basically somebody where I think it's unlikely my D-dimer is negative. I'm done with you. Bye-bye. I think it's unlikely, but your D-dimer is positive. Okay, I'm going to image you. I think it's likely, I really don't care what your dimer is, honestly. I'm going to go ahead and image you anyway. If I image you and your dimer is negative, I'm going to rethink myself. I thought it was a DVT, but boy, that looks really good. And I will tell you, that is a time where you really do want to go back and check yourself. It's like, well, I went into this thinking it was a DVT. The dimer's negative. The ultrasound is negative. I need to go back and rethink this. Maybe it's a Baker cyst that ruptured. Maybe it is neck fascia I didn't pick up on. Maybe it is cellulitis, and I'm totally wrong here. So that little side of this algorithm is a place to go back to the patient and make sure you're not wrong. Here's what the images look like. Those of you who did the ultrasound course, I was watching you guys do your DVT ultrasounds. It was pretty gorgeous. You guys were really good. Doing DVT ultrasounds is not rocket science. It's actually really cool, really fun. But this is what they look like. You can see vessels that are compressible. You can actually see the clot sometimes in the vessels themselves. To treat this VTE, to treat anything, for legs for sure, novel anticoagulants are the thing, absolutely for sure. You can start them now, they kick in right away. A lot of you kind of learned about these over in the pharm course. You don't have to follow labs, they're great. You can send a lot of these patients home. Really easy. So that's it. We've done thromboembolic disease from lungs to legs. Just have a really set algorithmic approach, especially for PE, so that you are really comfortable in how you approach them and you know you can do it the same way every single time. All right, thank you. I think Rick's going to come up and chat with you. Thanks a lot.
I think you were just showing off the show you can get. Okay, a little bit about malpractice. We'll show you a study later that said over a 4.5-year period in emergency medicine, 1 out of 11 physicians got sued. And that's only out of a 4.5-year period. They have a career of 35, 40 years. So the inevitability of a lawsuit seems to be out there. But the idea is to try to make that inevitability. You know, there are lots of doctors get through their career, never have a lawsuit. That's called lucky. The keys to not being sued. This is, oh no. What's happening here? We're doing this like one at a time here, things? All right, know the medicine. The keys to not being sued. Know the medicine. Know the traps. Act like you care. Insurance issues. First of all, it's a good idea when you're buying car insurance to get a copy of car insurance. It's a good idea when you're buying malpractice insurance to get a copy of your malpractice insurance. And one of the things it's going to likely tell you there is that if you get involved in any kind of a medical care outside of the emergency department, you're not covered. If you decide to take a little job in the urgent care center down the road, you are not covered. And you have to be careful about that because it can kind of be a little sneaky in that regard. What about if you failed to report a disorder characterized by a lapse of consciousness? That's what you have to do in California. You have to report them. And you didn't do that. This person has they're a chronic alcoholic, they drive drunk, they killed somebody, and then look at the pack, and you were in the emergency department and saw that person, and they had a disorder, they were drunk then, and they were driving a car, and you didn't report them. So then you are now partially to blame for that person's accident, and you're the only one who has any money behind this. And if you're an employee of the hospital, well, the hospital will get sued because you're an employee of theirs. But if you're an independent contractor, then you're going to get sued, and hopefully your insurance will be adequate. You know, there's this push to have people insured for, instead of 1 million, 3 million, they want 3 million, 5 million. And there's like 2 points of view of that. Well, if I insure myself for more money, there's less likely that they'll come and take my house, or that I'll have a claim that is over the limits. But the reality is that most malpractice cases, they don't want your house. They just want the height, your limits, because they're also going to be suing the hospitals and other people too, but they'll be content with your limits. But obviously, you don't have $45 million to do the case that I talked about in terms of a failure to report child abuse. Also, obviously, your insurance is not going to cover you for anything criminal. I mean, failure to report is not necessarily criminal, but it's not going to cover you for any of the problems that you get into related to that, or any of the legal fees that you generate. Here's the thing, it's kind of a lie. Never take anything from anybody in association with Good Samaritan suit. Here, Doc, thanks for helping out on the flight. Here's an extra bottle of X. Don't do it. Thanks very much, appreciate it, I can't take it. You take anything that resembles payment, it's almost irrelevant how much it is. Pharmacological sources of suits. So this is actually probably the second or third highest reason that we get into trouble. Black boxes. One of the problems with black boxes is that you are not systematically advised when black boxes come along. Because a drug may be released with a black box already there. 5 years later, the drug's been out in circulation, and through post-marketing surveillance, they determined that this drug causes tendon ruptures when you take fluoroquinolones. Nobody knew that in the beginning. That box got put there. In May of 2016, in May, no, it was about 2 years ago at most. There was a black box on fluoroquinolones for causing neuropsychiatric problems. Some of them quite significant. And it was ascertained that these neuropsychiatric complaints occurred in 1 to 2% of cases. Maybe insomnia, headache, something mild, but it's also has been psychosis, things that lasted long periods of time, depression, all kinds of neuropsychiatric things, all kinds of neurologic manifestations, headaches. And so that black box, most of you were not sent a letter on, because they only send a letter to you if it's a really bad kind of thing. But now that there's this neuropsychiatric problem with the fluoroquinolones added to the tendons and soft tissue and those kinds of infection problems, those drugs are probably, there's always an alternative to the use in most, I got to think in most cases. There was a case I know where a lady basically had some kind of lower extremity injury. She was an older lady, lived alone. She came in and she was certainly perky enough to go home kind of thing and live on her own. So they gave her some shots of pain medication while she was in the emergency department. And you know what happened. She went home, and going up the steps to her front steps, she fell and re-injured and actually broke her hip. And they went back and said, didn't you give her some Dilaudid? And when did you give it to her before she went? And she won that case. And it was actually several $100,000. So apprising people that they have drowsiness means that basically they really can't go home unless there's somebody who's going to help them in the house and the like. It's the same thing as if you send an alcoholic home. You're going to send him home with his, alcohol intoxication patient. You're going to send a person home with their brother or their son or something like that. They're going to take him into the house and make sure they're safe and comfortable. You're not going to leave him alone that night. And all of you are going to say, that's what you need to do, or if we're going to let him go. If you don't agree to do that, we're not letting him go. Because he may harm himself or something like that, or may start drinking again. Drug interactions, those are generally, in emergency medicine, we generally give a small amount of drugs. Here's a place that somebody got in trouble. So a psychiatric patient came in who was taking a huge amount of psychotropic drugs, but they were really kind of settled out. It was a good amount of drugs. It was helping them, but it was substantially over what would be viewed as therapeutic. So the ER doc didn't feel comfortable giving that high a dose, so he gave the normal dose. The patient went home, and within a day was manic and did all kinds of dangers to themselves and harmed themselves. And the physician was sued. And the physician was sued because he didn't attempt to call the psychiatrist. Well, good luck reaching a psychiatrist. He didn't attempt to talk to a hospital pharmacist or the psychiatrist on call or anything like that to help him say, I tried to find out about this higher dose. I'm not familiar with that dose at all. I don't feel comfortable. And they're going to say to him, this person has been stabilized on that dose. You dose them much slower. They will become unstable. And the consequences were that doctor lost that suit. Testing-related issues. Some Sometimes they ask you, Doc, while I'm here, can you check my PSA? You can't do that. How about my cholesterol? No, you can't do that either. First of all, you're going to submit this bill to the insurance company for the fact that they had a right upper quadrant pain or something like that, and they're going to say, how does the PSA and cholesterol come into that? So it's not really appropriate that you order those tests for that patient. So you shouldn't be ordering those tests. And this fellow is just trying to end run his family doctor. But while I'm here, check it out. Will you mind? Okay. Don't do that. Don't do that. And obviously, you need to know what the correct test to order. As a great example of that is spinal epidural abscesses. The test to order for that is a MRI. And if you don't have access to an MRI, then they've got to be sent to a place where they have access to an MRI. It's not good enough to do a CT, and let's see, well, the CT is normal. If it's abnormal, great, but if it's normal, you still haven't done the right test in this situation. So they may need to be transferred for that, because that diagnosis has got to be made on the first visit. You know, I think this issue about knee-jerk testing is kind of like a little problematic, because I bet you all of you have protocols for what to order for somebody who has abdominal pain. And those things are ordered out there by, well, whoever's, whatever provider is doing triage. But it's a sheet of paper. It's already been decided. And so it's made up by committee about what we're going to order consistently for abdominal pain. And so what happens in that case is you order a ton of stuff on this patient. There was no consideration of do they really need this or that kind of thing in the process? No, they just got this shotgun thing. Why did they get the shotgun thing? Because it'll be quicker. You'll be able to go see the patient and there will be the tests. Like you didn't have enough time to decide what are the appropriate things to order in this patient. Did this patient really need an amylase when the pain is in the left lower quadrant? Probably not. So I think that this idea of knee-jerk testing, I think, is a little problem. What about the test that you did a test, it's a culture, it's going to come back in a couple days. You have some kind of system in your department where somebody's going to look at it and make a decision about what to do with that culture. So in this case, it's a lumbar puncture that has a staph epidermidis. Well, that's a skin contaminant kind of thing, and that's probably not the problem at all. People did that, sent them home. We don't need to really call them on that test. Of course, they had meningitis. Same thing with urine infections and the like. So the idea here is you have to have a foolproof system for following up on these. I can't tell you how many cases I've seen where people committed malpractice because they didn't have a system which consistently identified follow-up x-rays. Generally it needs to be some kind of health professional that's looking at those reports to understand what are the subtleties that may occur here. So you better be careful about saying which is a contaminant, which is not. And I think most people don't want to even get into that position. Telephone advice. Somebody calls up your hospital and says, I have a problem, and they stop them. Don't say another word. We don't give out telephone advice. Well, what is a nice, warm reception is that kind of thing? I'm just trying to help out my baby. Here's a little favor. You can't even give me a little advice here. We'd be happy to see you at any time. So this is the robot response there. There's a company that does telephone advice, or virtual telephone advice. It's called telemedicine. And when you have telemedicine, you can talk, you can see the person. Can you examine the person? Look in the camera and open your throat. Ah. So, that kind of is bordering on similar kind of thing. So I think you have to be careful about giving advice when you don't have an adequate database upon which to act. So you could probably be really nice and said, ma'am, we really can't, we don't know what's wrong with your baby. We don't want to, give you any bad advice. We'll be happy to see you. And the charge will only be $1,600. It's kind of like, you almost feel bad for people bringing kids to the ER when that's the charges that are being generated. So, but you don't have to say go to urgent care unless it was your urgent care. If it's your urgent care, that your folks have been checked out, they're approved by the hospital, their credentials have been checked, they haven't had 3 felonies who work over there. Obviously, HIPAA-related information. In California, where we have hospitals where the movie stars go, and all the the Kardashians are regularly there for having a baby or something else, but everybody's looking at their records in Cedars-Sinai Hospital. Let's go through the computer. They have a zero tolerance policy. You get caught looking at anybody's record who you have no reason to look at, you're out. Zero tolerance. And I think probably most places should have, but that is particularly problematic place where these stars go, or personalities go. Critical values. Somebody sent out a test and it came back and it's really off the chart. And you call them up, they're not there. Critical value. I'm going to send the cops. I wouldn't hesitate to send the cops. Just call the local donut shop. See, is there a policeman there? Would you please send him to Mr. Jones' house? Tell him I got to talk to him right away. EMTALA. You all know about EMTALA and transfers, and many of you transfer lots and lots of your cases, so you're quite familiar with filling out all that paperwork, and you don't want to commit EMTALA error. And EMTALA errors are so focused on the process and the paperwork and the signatures and all of those kinds of things. And if you commit an EMTALA error, the CMS detectives come to your hospital, and it's not just about the case that you involved in the EMTALA patient. The entire activity of that medical facility is fair game. They can look at anything that they want once they're there. It will cost your hospital usually hundreds of thousands of dollars in legal fees to deal with this, and it will be a nightmare. So those of you that do transfers, you know them because you do them regularly. It's more concerning about the ones who don't do transfers very often, where there's the opportunity to screw this up. If somebody is stabilized, once they're stabilized, well, we got the cut finger bandage up. That person is now stabilized, and they can go to another hospital if they want. They don't need permission. EMTALA is done. They are stabilized. If they're still not stabilized, and then basically you can send them to a higher level of care because your hospital can't provide it, and that's fine. That's fine. Higher level of care. But did you call the on-call surgeon, and basically the on-call surgeon says, I know it's probably appendicitis, but I had a few drinks at dinner tonight, and I really don't think I should come in. And so you can't transfer that patient because you do appendectomies in your hospital all the time. So this doctor can't do it. So you're going to call chief of surgery. Chief of surgery is going to say, I'll take care of it. Chief of surgery can't be reached. Is there a surgeon that you know who's friendly to the emergency department? You call them. I need a hand. I need a favor, please. You can't do that. Doesn't work. You call the chief medical officer for the hospital. You got to go through that pathway because that's not a transferable patient because you do appendectomies. If the on-call physicians won't come in, you just say, I'm going to have to pursue this, Dr. So-and-so. And if they've offered, as he said, I've had a couple of drinks, that doctor is done. So then you have to scramble around to find something so that that patient doesn't get transferred, because that would be an inappropriate transfer. Patients can request a transfer. And even if they're not stabilized, they can request a transfer. You know, it's like as long as they're have the capacity to make that kind of decision, they can go. Sometimes people confuse the words capacity and competence. Judges determine competence. Doctors and you, nurses and nurse practitioners and PAs determine capacity. Does this person have the capacity to understand what I'm saying and make a reasonable decision? And that's a professional decision that you make. And so you put it down that the person is, you know, awake, alert, is able to speak without a slurred voice, is not ataxic, and understands what I'm saying and the options I'm providing to him. So you've drawn a picture now of somebody who seems to be, you know, with it. HIPAA's the ones where they look at the Kardashian records. Zero tolerance. Don't post any pictures that from your telephones. Some people even say don't send any kind of pictures to the cardiologist. Look at this EKG, because that's theoretically not a protected line. And the hospital has ways for sending pictures that are taken or using a separate phone and the hospital's camera, so that it's not on your phone by accident, it doesn't get deleted, kind of thing. Picture taking and recordings. There's two versions of that. One of them is that have you had any people who come in and said, I want to record this while you take up sew up my laceration, I'm kind of interested, you know, I wanted to be a doctor, kind of thing. How about a recording? Can I do that? There needs to be a nice, big, friendly sign that says, for the privacy of our patients, no recording of any kind is allowed in the department. So it's not a mean sign. It's for the privacy of the patients, kind of thing. And the fact that you will be very annoyed if you take my picture while I'm doing this. Some states only require one person's permission to take a picture. And if that person is the person taking the picture, then they can take your picture without asking your permission. And the states, California will allow you to take a picture of anybody you want, and they can't stop you because it doesn't matter. They're allowed to do that because California is a state which is a one person in authority. Many states are two. It's the picture taker and the picture takee. Ordering issues. Admission orders, you ever get in trouble writing admission orders? Because, you know, it's come to the time, except for perhaps in rural areas, where admission orders really aren't written by emergency physicians anymore. I mean, we struggled through that thing 20 years ago. And basically, the doctors are used to generally calling in some orders. Can you write some holding orders to keep them until I come in and see them in the morning? Man, you are responsible for that patient. You are responsible for that patient. And I had a really bad situation where the doctors never came in to see that patient because they fell back to sleep and never remembered that I called them. And the next thing I was doing, I was writing discharge orders on that patient. That is sad. That is sad. This patient was on autopilot up there for 2 days. Scary business. Phone orders, basically, do have a reflex. It goes right to the nurse. Phone orders, get that arm right out there. If the doctor wants you to transcribe some orders on the phone, just say, I'm transcribing these on behalf of Dr. So-and-so. I'm just the writer. He's the one, he's ordering it. And if the patient goes to the floor and the nurse is taking care of that patient, make sure that they know who to contact in the event that the blood pressure is going down, the potassium's 3, those kinds of things. That it's not the emergency department. What not to put on the ED chart? Any derogatory comments regarding your colleagues, anything about unprofessional conduct, anything like that. No, that's not a part of the medical record. Basically, just keep it short and sweet. Anything that's going on in terms of an argument, you're having an argument with a consultant, Dr. So-and-so declined to come in to see the patient. That's fine. The fact that you're having screaming on both ends of the phone, that doesn't happen. How about negative statements about prior care? How many times have you seen that happen? It's just, and how many times does it happen in reverse? When you send a patient for follow-up and they make some crack about your care, you never know that. But it's just not gentlemanly to do that. Yes, they may have made a mistake. They may have rendered bad care in that case. We're going to take care of it now. We're going to do as good a job as we can for you. Quotation marks around whatever the patient says. Well, the doctor said I had that's a quote unquote kind of thing. So it's not your words, but it's the patient's words that are down there. Incident reports don't go into the chart. Incident reports are excluded from the chart and make no reference to the fact that you wrote an incident report regarding this case, because that may allow them to access that incident report. You just want to have them follow the chart wherever it's supposed to be, but no extraneous documents. Addendums, basically, they're always self-serving. It's by, so you have to be careful about writing that. It doesn't say you shouldn't write them, but it just means to understand that everybody's going to be looking at this a little suspiciously because it is going to be self-serving. Don't alter the record. I guess it's getting harder and harder to do these days, but I've heard of some cases where the record's been altered. And soon as they have all of this metadata underneath, they can look at really what transpired on this record in terms of who accessed, when it got accessed, and they can find out from this metadata that you accessed that record and made this change. So you have to be really careful about that, because it's another one of those cases where they find that you lied, and the jury gets to hear that you lied. What other things has this physician lied about? Leaving AMA, patients can leave AMA if they have the capacity, if they can do all the things that they can understand what you're saying. They basically are not. They can have a blood alcohol, of 0.05, but that never. I don't think it's a good idea to measure blood alcohols in anybody, except if this person is out and you're wondering, is it because they're drunk or because they have a subdural hematoma? So you're going to get a blood alcohol and a CT of their head to see what's going on and that kind of thing. Otherwise, don't get a blood alcohol, because there is straight line metabolism of alcohol. So if you got a blood alcohol and you sent the patient home, and 8 hours later they know what the person's blood alcohol is through this straight line kinetics, and so it's probably not a good idea. What you're interested in is, how does this patient clinically behave? Some people can drink a lot more alcohol than others and still be brilliant. Others can't. So this is a clinical decision. Is the patient speech slurred? Are they walking, ataxically? Those are the kinds of things where you paint the picture of what you actually are trying to achieve. So a patient still wants to go out. This patient has capacity to go. Mr. So-and-so, I really don't think you could go, because we believe that you're having at least an episode of coronary ischemia, which could potentially lead to a heart attack, and we really think that you should stay. No, doc, I really want to go. I don't want to go. Well, the thing is, bring in a relative. Hopefully it's a spouse. It's the wife of Mr. Jones. Mrs. Jones, your husband doesn't want to leave. We think that he's maybe having an impending heart attack. Please make him stay with us. I should tell you that if he has a cardiac arrest in the process and lives, you'll be wiping his butt for the rest of his life. Immediately, Mrs. Jones says, "Albert, you're in the hospital." So basically, it's about establishing capacity. They want to leave. You want to leave on good terms. Listen, you have an infection. It should be IND'd. You refuse the IND, I'm going to give you the options. We're going to give you some antibiotics if you want to, if you must leave. And I hope these may help. This is not the preferred treatment, but it's the best you're going to allow us to do. And please feel free to come back. It's one of those things where you can't have them leaving my way or the highway. They need to feel that they can come back and still not lose face by doing that. So you do whatever you can. You give beta blocker to the chest pain patient kind of thing, aspirin. You don't want to give anything that will really mask this. If this is an infection kind of thing, you don't want to give them pain pills. They're going to say, you gave pain pills. Look at that, it got worse. I didn't even know it. You don't want to do that. You would just want to give treatment that is focused on the resolution of that problem. So that's not an unreasonable thing to do. The AMA form, they basically have to be told the potential consequences of if they leave. It potentially could be death. If that's the potential, you put it down. And basically, you provide this conversation to everybody in attendance. You write a note that this person is leaving against medical advice. The nurse writes a note that I have witnessed Dr. Spicata talking to this person regarding leaving against medical advice, and they leave against medical advice. Elopement, if they have something potentially serious, call the cops. If they don't have something, and call the hospital security. If they don't have something serious, wait till they get home and say, Mr. So-and-so, I know you had a problem. We're we're somewhat less busy now, and we'll be happy to see you. That's a reasonable thing to do. But if it's potentially serious, call the cops. And consent, we already talked about this capacity related matters. If you want to do that IND and they refuse, you could say, well, okay, here's another treatment we can give. If you decline that treatment, we can give you this treatment. If you decline that treatment, and there's no treatment, then this is the likely outcome of that no treatment. And we just went through ascertaining capacity. Apology. There's too many slides here to finish. Maybe I can do it. I have another one of these risk management things, and maybe there's a little space there, and we'll pick up the rest of this at that time. But I don't want to screw up the schedule here.
Neuropsych?
You're welcome here. I didn't finish.
Okay, I am well aware that I am the last person standing between you and like casinos and cocktails. So why not end it with neuropsych? Because that's going to be a super fun topic. It's always, like we were just saying with Diane, it's full of fun stories. So I think I can make up some time here and hopefully get you guys out and free soon. So neuropsych. We're actually going to skip the first few slides here. I think they're more review. We talked about some of the brain anatomy in the stroke and blood vessels and what tissue that perfuses in the brain. I think this is the first few slides here are just good review slides for reflexes, dermatomes. I would say this probably is a slide worth starring and circling just as like the important clinical dermatomes that you usually want to remember and are frequently tested on. And I know you guys already talked about GCS. As a review, just for getting them to the ER, they automatically get a 3. Remember, that's a 111. A completely oriented person, following commands, making full sentences, opening their eyes spontaneously is a 15, and then there's everything else in between. So let's really start with the mental status exam, because we're talking about patients coming in with altered mental status. So This is more than just the GCS, like are they alert and oriented or are they in like a full-on coma? This is, what are they acting like? What do they look like? Are they disheveled? Their thought process, are they hallucinating and just like completely disoriented, or can they actually, form complete sentences and kind of sound normal? What's their mood like? Are they depressed and they're not making any eye contact with you? Are they manic and talking a million miles an hour? Do they have insight? Like, did they know why they're here, or are they just completely confused and altered? This is just a reminder that, of course, on all of these people, you're going to do a complete physical exam. I'm like the neuro person today. Do your full neuro exam. So this is a reminder to do those. And then this is the reminder to, again, there's the bed neuro exam and then the up and walking neuro exam. And that cerebellar exam is incredibly important. Finger to nose, pronator drift, rapid hand movement, walking in a straight line, assessing ataxia. So the differential for altered mental status is probably like the biggest differential we run into, right? There's everything on this list. I'm not a huge fan of mnemonics, but I actually really like this one, AEIOU tips. And it's just a reminder of all the other things to think about, because I think like alcohol is easy. We see intoxicated patients all the time. That one we always remember. E for epilepsy, it's not necessarily the person that has a seizure in front of you, right? That's obvious. But if you don't know they had a seizure and they're coming in and they're really altered, but they're really just postictal, and you don't know the history of the seizure, that's just something important to remember. Like, look through their chart, try to get some family, some extra information if this patient can't talk to you, and see if they have a history of seizures. Also importantly, do they have a history of diabetes? I is for insulin. One, did they take too much and they're hypoglycemic and just totally wonky? Or have they not taken their insulin for weeks and now they're in a hyperglycemic coma? O for opioids, vital signs are going to give us a clue about that too, right? Their respiration rate's going to be low, their pupils are going to be pinpoint. Uremia, very important cause of altered mental status in people with kidney dysfunction. T for trauma, got to think about brain bleeds. Again, when they're completely undifferentiated, really need to look head to toe for any signs of trauma, because you just might not be getting a full story. Infection, meningitis, urosepsis, pneumonia, all of these different infections can cause altered mental status. P for poisonings, again, try and get a really good history. Did EMS find this person covered in a bunch of empty bottles on their bed and this was a suicide attempt? Did they overdose on something? And then the second P is for psych. I think this is also a really common one that we're used to, but one that we really have to remember is a diagnosis of exclusion. And what's super important here is there might be a patient you see every week that's schizophrenic. They come every Friday night, right? And you're just used to seeing them. But always remember, even in those common presentations, thinking about your differential, because they can still get meningitis. They could have still had trauma. So instead of just early closure onto the schizophrenia, remember to think about the other things that cause the altered mental status. And then stroke. So a good history and a good physical exam usually can help you get down a certain path of why you think this person's altered. Now, when we talk about the general approach, like say, and this happens, EMS says, we found this guy at the bus station down. We have no history, we don't have a name, we have no idea what medical problems he has, we don't know anything, here you go. So in that case, your workup is going to be really broad, right? You've got to kind of cast a wide net because you don't have a good collateral history to go off of, and this person might not be able to give you any history. So in that sense, you're going to do your labs, right? CBC, BMP, get a liver panel. I actually like to get Tylenol and aspirin levels in these patients, because if they can't give you a history for ingestions, Tylenol and aspirin early on might not have a toxidrome yet, so you have no idea, and that would be important information. I could probably talk a whole lot about urine tox screens and how I think they're absolutely 100% useless and a waste of money and time. With that said, you might have hospital protocols that require you to order them frequently to transfer psych patients. You need to order them. My quick take on urine tox screens is there's a lot of false negatives, there's a lot of false positives, and even say this person is on Norcos and they light up for opioids on their drug screen. that can lead to a lot of dangerous early closure on why that, like, you know, you just assume, oh, they're polysubstance abuse, it's just drugs. And you forget to think about all the other things on the differential. And they might be on opioids, but that might not be why they're altered today. So that's my take on drug screen tests. I think they're useless. Urine, blood cultures, do a full septic workup. I have a really low threshold to get a CT scan in these patients. Especially if they're found down, if they're elderly, if they're an alcoholic, I mean, they just have such a high risk of getting brain bleeds that if I don't know what's going on, it's completely undifferentiated, I'm usually getting a head CT. And you want to get a head CT in a patient that you think you might have to do an LP on, because if they're altered and you can't get a good neuro exam, then you actually have no idea if they might have something in their brain. So you got to do the CT before the LP. In terms of treatments, again, just from the beginning, because all of these individual causes are going to have specific treatments, but from the beginning, it's your airway, your breathing, your circulation, oxygen if they're hypoxic, check a blood glucose, consider giving some naloxone. There's no harm if it's not opioids. It doesn't matter if you gave it to them, but it might reverse the cause. And if you suspect infection, just go ahead and start antibiotics early. You can always start them and stop them, but there is harm in not starting them from the beginning. Okay, so of all the many causes that cause altered mental status, we're going to focus on just a couple. So meningitis. Meningitis we don't see quite as often, but it carries a really high morbidity and mortality. So it's something that we got to keep high up on the differential and really think about and make sure that that's not what is causing the altered mental status today. So if you can obtain some history, or if you have some family that can tell you anything about this patient, you want to ask, are they immunized? Did they get their pediatric immunizations? Think about it in the little kids and the older patients, they're at a higher risk for meningitis. Is it an immunocompromised patient? Is it a transplant patient? Where I work, we see transplant patients all the time. Are they on chemotherapy? Super high risk for meningitis. And you know, we always read about like in close quarters, the dorms, military, things like that. This is just a chart on age distribution. It only shows for adults, so there'd be another peak over here on the little kids. You know, we always have to do a big septic workup on our under 30-day-olds, and then we see another spike around 65 to 70. In terms of how these patients present, so there's the completely altered and comatose patient, which you're not going to get much history from, but maybe this patient's a little off and altered, but they're telling you they have a headache. On vital signs, you see that they have a fever, or family tells you they've been having a fever. Maybe there's vomiting. Maybe you got to undress all of your altered mental status patients. You might find track marks from heroin. You might find rashes where you didn't expect them, foreign bodies that have been stuck somewhere for way too long. All of these things are really important, and so always make sure that you undress the patient. And particularly in bacterial meningitis, you're looking for that petechial rash. And just like we were saying earlier, just go ahead and get that CT, start those antibiotics. If you think this person might have meningitis, start the antibiotics. You're still going to need to get a CT scan, especially if they're altered. But if you have antibiotics going for even like an hour, it's not going to affect your CSF. You are still going to have gram positives, the bacterial cultures will come out positive. Just an hour isn't enough to really affect the CSF results. So antibiotics are totally fine. And if for some reason there's a huge delay to getting an LP and the antibiotics maybe altered the CSF, you got this patient what they needed, and it's more dangerous to delay. Just start them empirically. This is another kind of one of those review slides. I think there's a couple important things to point out. Like most of the bacteria and bugs that cause meningitis are pretty similar across age groups. There's a couple things that are important to remember. In our little babies, we worry about listeria. Listeria falls off kind of our list of most common bugs from 3 months to 50 years of age. And then once you start getting into 50, 60 years, listeria comes back on. And that affects how we treat these patients. So 0 to 4 weeks are newborns. They're going to get ampicillin because that covers listeria. Then, what it always says in the textbook is cefotaxime. But I don't know if you, like hardly any hospital carries cefotaxime these days. So I remember as a resident, I'm like, wait, I'm supposed to give cefotaxime, but we don't carry it at the hospital, then what? So they always say cefotaxime, a lot of places don't carry it, so you're gonna use an aminoglycoside instead. Then from 1 to 3 months, It's ampicillin and cefotaxime, same, so add your aminoglycoside. And then 3 months to 50 years, it's pretty much just higher dose ceftriaxone. So it's not our 1 gram of IV ceftriaxone for like Pylo, this is 2 grams. You need higher concentration to get into the CSF. Once you get over 50, that's where we remember we've got to add ampicillin back in because of that increased risk of listeria again. Now, if it's someone that's older, that has, that gets dialysis and is in and out of the hospital all the time, and they are at a higher risk of having MRSA. So I also go ahead and add vancomycin onto my older patients or my immunocompromised patients. There's a little caveat down here about steroids. This is one of those things that like 1 year, yes, steroids, 1 year, no steroids. It's super controversial. I would just ask your hospitalist or your admitting physician what they prefer, and then they can go ahead and start them if that's something that they do. Right now, I feel like we're in the swing of where steroids are kind of out of favor, but who knows what will happen next year. Okay, seizures. Seizures are another common cause of altered mental status, and we're talking about like the thing that's not so obvious is when they just come in postictal and we have no idea if they had a seizure or not. So if you get the history that they had a seizure, why did they have a seizure? Do they just have a history of epilepsy and ran out of their Keppra for the last 2 weeks? Okay, cool, that's not as concerning. But we also need to go digging if we don't know why they have seizures or why they're having a new seizure. So metabolic disorders, glucose being low, sodium being either too high or too low can cause a seizure. Structural changes like masses. Now toxins, the most common one, honestly, of all the toxins and drugs is an alcohol withdrawal seizure. That's a really dangerous seizure. Febrile seizures, typically we see in kids. I think you're going to talk about that if you haven't already with peds. And then also like look at the patient. Is she pregnant? Because then your management of the seizure is very, very different, and they need high dose magnesium, not a bunch of benzos. Now, you've all worked in the ER or different urgent cares, so there's some patients that have true seizures, and there's some patients that have pseudo seizures. And so it's important to also get that history because we're in neuropsych, so we're going to talk about psych too, and that's where we go down the road of pseudo seizures. But true seizures, they're abrupt in onset. They're not talking to you. There's complete loss of consciousness. They bit their tongue. They urinated themselves. Those are more consistent with a true seizure. And their lactate might also be elevated because of all the tonic-clonic contractions of their muscles. Okay, so if you get that this person had a seizure, is it a new onset seizure, or is it the chronic seizures and they've ran out of their meds? If they just ran out of their meds and they can give you that history, they're back to baseline, honestly, I'm not doing much more than maybe getting a blood glucose to make sure their sugar isn't out of whack, but they probably don't need imaging if they have no neurodeficit, they're acting normal and just need a refill on their meds, then that's a safe discharge. The people that you need to be concerned about are new onset seizures, especially in older patients that have never had a seizure. This is not them just developing epilepsy suddenly at the age of 50, right? So you got to think about infection. You got to think about electrolyte abnormalities. Really pretty common in the pediatric population is where we run into those sodium abnormalities. Now this might just be parents that don't know how to mix the formula correctly, or maybe they're tight on money and they're trying to make that formula last for as long as possible, and they end up diluting the formula, and that causes hyponatremia. So important to check that in kids. And then again, if it's a new onset seizure, you're gonna do much more of a broader workup and try and figure out why they're having this first time seizure. Treatments, benzos, 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 and more benzos. The dose I usually start with in adults is 2. They're still seizing another 2. They're still seizing another 2 after a few minutes. Keppra is a great go-to too as well. Keppra is super safe, well tolerated, but it doesn't really do such a great job of breaking the seizure right in the moment. It's better at preventing the future seizure. Phenobarbital is something that I use very often now with my alcohol withdrawal seizures. Phenobarb is really great. I start with a loading dose of 260, and then if they're still having withdrawal symptoms and I'm concerned they're going to seize, then I do another dose of about 120. This is so much smoother than the Ativan for them in terms of withdrawal symptoms, because Ativan works great, but it puts them on a little bit more of a roller coaster. They feel like their symptoms are controlled, and then all of a sudden they're shaking and feel like they're going to seize again. Phenobarb actually gives them this nice, easy, kind of smooth transition out of the really uncomfortable withdrawal symptoms, and I found that patients and physicians really like this medication. We talked about pseudoseizures and things to look out for that. Whoops, I went backwards. Sorry. All right, now the fun stuff. Mental disorders. So probably the biggest thing to remember from this is that, again, there's the medical causes of altered mental status, and then there's the psych causes of altered mental status. And especially if you have a patient with a history of known psychiatric disorder, just really run through that whole differential of why they could be altered before you just pin it on the schizophrenia or the psychotic episode that they're having, which they definitely might just be having, but really run through that differential and make sure you're not missing a medical cause or a traumatic cause. So in terms of the functional causes, this is the patient with bipolar or schizophrenia, where symptoms are more gradual in onset. They've been acting off for a little while, it's kind of been waxing and waning, and now they're having a psychotic break. Versus the organic cause is grandma's been acting, she's normally fine, alert and oriented ×3, and all of a sudden she's wandering the halls naked and not remembering anybody's name. That's more concerning for like maybe a urosepsis picture, and that is something that would be, I wouldn't just all of a sudden be like, oh, grandma at 75 is having a psychotic break. That's pretty unusual. Okay, so some of the psychiatric things that we see in the ER, most common, antisocial personality. These patients are just tough. Like, they don't give a darn about much. They break the law, they don't care if they just don't have any remorse for anything. So they're just not the nicest patients, I guess I would say. They can just be very challenging. They're very impulsive, and again, they just don't have remorse for any of their behaviors and how they impact others. So they can be challenging patients in the ER. Anxiety disorders, I think this is something we're probably all very comfortable with. We've seen a lot of, there's many different variations of anxiety disorders. PTSD is usually around an episode. Maybe this is a rape victim or somebody that was in combat that has a lot of their anxiety about recurrent thoughts of those episodes, those traumatic events in their life. Obsessive compulsive disorder, those are just more intrusive, repetitive thoughts that they need to basically wash their hands, and that'll release their anxiety, when actually feeding into those compulsions makes their anxiety worse. And then phobias, again, a fear that isn't realistic. Fear of flying, fear of snakes, where people like literally can't function, they're so terrified. Bipolar disorder is really interesting. These patients, they just go through these massive mood swings. They go from completely manic to maybe completely the next month very depressed. And then manic being they're not sleeping, they're hypersexual, they're in Vegas gambling like crazy. They have all these ideas for making billions of dollars on these business plans that will work, and they're just ramped up, they're hyperverbal, and they are all over the place. And then they swing into that depressive state. I think this depressive state where they're sleeping all the time, they don't get out of bed, they can't go to work, they're feeling suicidal. And so it's these really huge swings of emotions. Schizophrenia, another really common one that we see in the emergency room, and unfortunately a really common issue that we see in our homeless population. Schizophrenia is difficult. I mean, they have such horrible hallucinations and paranoid delusions that just living in society is so difficult, to pay bills, to manage keeping a job. It's very, very challenging. And so unfortunately, we do see this a lot in our homeless patient population. You've seen them all in the ER. They're disheveled. They're all over the place. Very common paranoid delusions being, the government's put a microchip in their brain and bugged all their phones and, following them, and it makes it very difficult for them to function in society. Now, depression, it is important to pick up on the patients that are depressed. We want to give them resources for being depressed, but what we really care about is picking up the patient that is potentially suicidal and we're worried might be a danger to themselves. So in terms of the warning flags and things that I always ask my depressed patients, have you tried to commit suicide in the past? If they have had a previous attempt, they're at a higher risk for attempting again. Do they have access to weapons at homes, guns, knives? What's their support system at home? If this patient goes home and we don't think they're actively suicidal in this moment, are they going to have people at home with them? Are they going to be able to turn to someone and say, I'm not feeling right? Or are they going to be home alone with no friends to call, no social support system? We always mention, and this comes up in tests as well, remember, females will attempt suicide more frequently but not be successful, and men will attempt and be more successful. Usually men use more aggressive weapons like guns and things like that. Somatoform disorders. So this is another really interesting one. Hypochondriacs, I think we all feel comfortable with, right? They're all on WebMD, they're convinced they have every symptom, they have every disease known to man. Conversion reaction is not something we see all that often. I've seen it once or twice, and it's really, really fascinating. These people, I guess best described with an example, right? So say you have somebody, and they're crossing the street with their mom, and God forbid, their mom gets hit by a car right in front of them, and mom's killed. This person just had an insanely traumatic episode, and they are absolutely just unbelievably traumatized from what just happened. And they're brought in because they say they can't see. They just have complete loss of vision. You run every CT, MRI, blood test, LP, everything under the sun, and there is no medical reason why they can't see. That is conversion reaction. When somebody has such a strong emotional reaction to a traumatic, horrific event that they have a neurological deficit that can't be explained in any other medical way. The patient I had, I remember, I think I was an intern back in residency, and I can't remember what the traumatic episode was, but they couldn't feel their legs. They just couldn't feel their legs. Their motor exam was normal, they just could not feel their legs. And again, it ended up being more of a conversion reaction. Delirium, so we're gonna talk about quickly delirium and dementia. In a nutshell, delirium is acute onset and reversible. Dementia is slow, gradual onset, and you can't reverse it. So delirium is your urosepsis. Grandma's been acting weird for the last 2 days. Again, she's running around naked in the streets. You treat her UTI, she's back to normal. That's delirium. Dementia is the gradual onset. Now grandma's actually having Alzheimer's. She's been more forgetful recently. She left the stove on last week. It's progressively getting worse. This is more of an Alzheimer's dementia and not, unfortunately, something that you can reverse. All right, I think I have just a couple more. So malingering. Malingering patients are also very challenging. This is the patient that, maybe they do have back pain, they have chronic back pain issues, but they're coming in and they might be shopping around at different ERs, a different ER each week, a different urgent care each week, and they're saying, oh, my back pain's so bad, I definitely need Norco, I really need a work note to excuse me from work for a week. And in the end, maybe they do have back pain, but they're over-exaggerating their symptoms for a secondary gain. They want those opioids, they want the time off work, and that's why they're coming repetitively, shopping around at different facilities. Now, Munchausen, I believe the name actually changed to factitious disorder now, but Munchausen syndrome and Munchausen by proxy, so factitious disorder to self or factitious disorder to others. Has anyone ever seen this? How weird is it? Yeah. I've definitely seen this. I saw the Munchausen or factitious disorder to others actually on my PICU rotation during residency. It's very, very interesting. So this is somebody that wants to be the patient. It's not the hypochondriac that just thinks they truly have everything. This is the patient, they want to be sick. They will say they have this terrible, awful abdominal pain and constipation, and nobody can figure it out. They'll go through all these CTs. They'll go through colonoscopies. They'll get admitted so they can get X-laps. When nothing's really wrong, they just really want to be the patient. Now, the flip side of this is when it's factitious disorder or Munchausen syndrome to another person. So this is when it's usually a parent, it's oftentimes a mother, and they want their child to be the patient. The child is the victim here. And this is, they make up all sorts of symptoms. I think an easy example is that they'll come and tell the doctor, oh my gosh, my kid's peeing blood. Like it's hematuria, they must have some terrible infection. And so they get the doctor asks for a urine sample, and mom pokes her finger and puts blood in the urine to make it look like hematuria. I mean, these are the things the links that they go to because they want their family member, their child to be the victim. Really scary stuff. And with that, I will end, and I think we're doing a short Q&A session. Yes.
All right, we're going to do some Q&A.
Do you need a clicker?
Nope. Nope.
Okay.
Tomorrow when we talk about
Oh, cheers.
rashes, you're all going to think that you have every rash under the sun because you were just in Las Vegas. Mm-hmm. Mm-hmm. Why couldn't COVID have originated in Las Vegas, Mike? Because what happens in Vegas stays in Vegas.
I wish.
Thank you, Michael.
That would have been nice. COVID just stayed here in one spot.
Where is Diane?
I got you. See.
Where's
Waiting
Diane?
for
I
Diane.
don't know.
How does the colorectal surgeon enter the ballroom? From the rear. Man,
I thought it was funny.
jeez. Couldn't get you with the vagina joke, can't get you with the butt jokes. What's left in this world if that doesn't make you laugh? The squeezing of the ketchup bottle should always make you laugh too. At least that's what Diane says. Oh, there she is. Okay, so quick announcement. The essential pediatric talk that was a little bit riddled with some feedback, we're sorry about that. We posted the full lecture that was done just a couple months ago with this same person right here. Rick Bucata's talk is available feedback free. And I posted the link within Slido. If you have a problem accessing it, you could also just go to the CCME YouTube site and you'll see it. Okay? All right, so this first question. Sorry, this should not be like that. How can you tell the difference between vertigo and posterior stroke?
Oh man. I would be so
easy.
happy if that was easy. This is why everybody hates dizziness, right? Like we're all like, oh, maybe my colleague will pick up that person. Maybe I need to go to the bathroom right now and they'll pick it up. It's so hard. It's so hard. I think there are signs of peripheral that can lead you more down that. You know, if it's positional and then you thinking it's more of a BPPV, that's great. If there's another neurological deficit associated with that I'm thinking more central. Nystagmus can be helpful here in terms of, you know, if you ever see vertical nystagmus, that's a central lesion. The Dix-Hallpike, I think that came up in another question too. I mean, I remember there was a Roche review that was like, what's more sensitive for a stroke? Dix-Hallpike or MRI? And I'm like, MRI, it has to be MRI. And in the right hands, apparently not mine. Again, when a neurologist does it, it's really, really sensitive. But we don't have that capability all the time. So I think there are, maybe you guys have a better answer, but I think there are certain signs that lead you more down central and more down peripheral. But if you're on the fence, you just got to go down the stroke road and make sure that you rule that out.
And we'll actually talk about this more tomorrow morning in my ear lecture and have a good little table that kind of helps differentiate central versus peripheral and those things we can look for as well.
Yeah, and you kind of put them on a scale. You know, sometimes it's like I don't know. It could be either. So err on the side, especially the older they are, if they're diabetic, the more you're going to rule out the scary. Or if somebody like your person who had the vertebrobasilar dissection.
Oh, I know.
right,
When I saw that question, I did not do a Dix-Hallpike on them. I have to be completely honest. But she also had pain and some symptoms in her arm, which I was like, no, we're just going to get the CTA because that was going to be more sensitive than my Dix-Hallpike, to be completely honest.
And if anybody tells you they're great at the hints, they are lying. It is the hints is. You talk about where that in yours.
Yeah.
I
Talks
hate the
about
hints
it tomorrow.
exam. And actually, if the guy who did the hints exam had to put another paper out that said, well, if you record it on your iPhone and play it really, really slow, and then look only this way, you'll actually see it. And I was like, okay, I'm not so bad. Yeah.
Although there have been studies that basically showed, despite the complexity of all this, we do surprisingly well.
do.
I also posted about a 85-page paper if you want to spend tonight reading that on the difference between central and peripheral vertigo. Enjoy.
Any trouble sleeping? All right.
Well, there's
where
Nate's
are we?
All right.
question. Let's get that one.
Yeah.
So someone asked, I mean, I think this is actually a good question. How does the Nair actually help, the Nair ointment, the lotion, get the hair off?
It dissolves it.
Exactly.
Although I'm just gonna like throw it out there. Has anyone ever done this?
No.
Has anyone ever put Nair on your legs?
Oh, yes.
Oh, on your legs.
Just
though.
like last week, Diane.
Yeah, but it takes like 10 years to melt the hair on your legs. So how is this like, do you leave it on this poor little kid's penis for like
Well,
a
the-
century?
the
Like, how
I'm
do you
not
do it?
putting Nair on a little boy's
I-
penis. Like, I'm just not doing it. It's
I've
not
done it.
happening.
It's not a big deal.
Although one of the problems is that hair goes way down there.
Right, it's all folded in
Yeah.
there.
And how are you going to go down
How does
and
the
get
Nair
it?
get in
You'd
there?
rather go in there with tweezers and try and like you're in there with the.
Yeah,
just
no,
look-
it-
I mean, the
Hey,
image
listen,
itself is
Do you
really
think it'll work in a
disturbing.
half an hour?
I have no idea. Have you
You
done
need a
it too?
Yes.
randomized
Oh,
double
yeah.
blind.
Seriously.
I've used it on a finger too.
Anybody else? We have one.
There's got to
Going
be
once,
somebody
going
else
twice.
out here,
Anybody
and I
else?
work mostly exclusively in peds, but
Okay.
I
Well,
bet
at least
you
I know
Maureen
somebody,
McCullough-
because you're the only person. Although I'm not sure. I'll
Stat
ask Mel.
urology
we have to ask
consult.
her. What?
Nicola?
Stat
Yeah.
urology
She prob- I'm
consult.
She probably, yeah, she's
Probably.
done everything.
She's done everything.
All right,
Moving on.
next. I always worry about orbital cellulitis versus lower lid sty. In some of the severe cases, the sty really mimics the look of orbital cellulitis. Any advice?
I mean, typically your sty, your hordeolum, more common on the upper, but sometimes on the lower, but usually it's very localized just to there. And one of the other big things we look for, especially when we think about true orbital cellulitis, is proptosis.
Yeah.
Usually you're gonna get that bulging out appearance of the eye, and you don't see that with a hordeolum.
And they won't, true orbital cellulitis, they won't move that eyeball.
Very
They
painful.
Yeah.
will not move that eye. So it's not that it hurts when it moves, when it bumps against my sty. It's like, no, I'm not moving my eye. It hurts too much to move it at all. That's been helpful for me.
Well, they got stuff going on in the back of their eye, and these muscles that are basically controlling the eye. I guess it hurts worse when you do that, so they don't move their eye.
And I think with kids too, like, it's hard to get the full exam. They just say, my eye hurts because around it hurts. But if you have them, and if they're trying to open this painful swollen eye, it hurts. But if you have them close their bad eye and just have them follow your finger, and they're like, oh yeah, no pain, I'm less worried about an
Yeah,
orbital.
with the good eye.
With the good eye.
Yes.
Yep.
Because if they move the good eye, they have to move the bad eye.
Right.
So they're moving both. And if it doesn't bother them
That works
then,
for almost for a
then-
lot of things
yeah.
where you like just, here, let's do this one since they go together.
But I mean, a sty, you know, like Mike said, it's pretty localized. It's that one little spot. If you start to have a lot of redness and swelling and the pain with the eye, then you know it's probably posterior and it's not just that localized sty. So,
Or preseptal.
yeah. Okay. What is the process for draining septal hematoma?
And I actually posted, I think it took 2 lines to do all this, and actually a really good New England Journal of Medicine article with a video
With a
that goes
video,
through it.
yeah.
And as I mentioned, usually you can use the cocaine, or if you need to, do a facial block. If it's really large, you're probably going to use a scalpel, so I need a really good light source in the nasal speculum. If it's kind of small, sometimes you just use an 18 gauge needle and a syringe and just aspirate it out. But then I want to take a Q-tip and kind of milk out, make sure I get all the blood and the clots out, and then pack it. And we're going to pack both sides. I can really compress that against the septum and have them follow back up.
Which is key. I think that gets forgotten sometimes.
Yeah.
Yeah. Okay.
Wait, there's a question right over there.
Oh, hello.
Oh,
Michael, can you bring a microphone over to the
We
folks
got it.
in the
I got it. I
audience?
got it. Go
she
ahead.
said
No, no,
there's
no.
a
I can hear you.
picture.
Both sides.
Yeah, if they had it was usually you see it on both sides. And sometimes it's just on one. Just depends on how severe the trauma. You would definitely want to drain both sides if it's there. And usually you'll pack both sides no matter what, just so you keep the septum compressed so it doesn't reaccumulate. That's usually the big problem. And we'll talk about a similar thing tomorrow with the ear as well. You've got to compress it from the front and the back so it doesn't reaccumulate.
And speaking of noses, a question was delivered to Diane and myself when we were sitting over at the table, and it specifically asked, should you obtain an X-ray of the nose if there is severe trauma in
But
an assault case.
No, it just said assault. It didn't say severe trauma, which I think will make a difference.
Oh, I'm
right?
so sorry.
Yeah.
I just made that up.
You did.
The question was actually in assault, which it could be severe trauma,
Could
but
be.
the question didn't say severe trauma. It just said assault. So someone gets punched in the face, and they want to know if their nose is broken. And so why do they want this x-ray for their nose? Well,
I mean, as we talk about, usually it's not going to change anything. It's truly if it's localized just to the nose. But if I see periorbital ecchymosis or anything with the maxilla, I'm probably going to scan their face just to make sure we
Exactly.
don't miss
Yeah.
something.
'Cause-
But if it truly is, the young, no risk factors, just truly blunt trauma of the nose, it's not going to change anything. Get them into see ENT to have it reduced. They usually have obvious deformity. Biggest thing is want to make sure they don't have any bleeding or anything else going on.
Right.
Look for those concurrent injuries.
some people want them for legal purposes, but like Mike said, you're going to get a CT anyway. Probably look for facial fractures or something else if it was really severe trauma.
I feel like it takes more of like a conversation. That's like
Yeah.
the thing that takes the most time because maybe it's broken. Does it matter? No. If it's severely deformed and there's other problems, then yeah, the CT. But they just want the answer. Like, but is it broken? And you're like, maybe. But we're not going to do anything different about it. And I think that's not
Yeah.
as satisfying for them.
Well, society hasn't really caught up with us. If you're in a court of law and you're just someone sitting on the jury and you're listening to an assault case for whatever reason, and you have an x-ray that says, you broke my nose. Sounds worse than like, I had a bloody nose, right? I mean,
But that's not a medical question.
well, that would be a question
a
for you
legal
then, medical
question.
legal. What would you do, Rick?
If they want an x-ray of their nose, I'll get an x-ray of their nose. I mean, I can assure you that many ENT doctors will get an x-ray of their nose somewhere in this process. So I don't think it's a sin to do that.
A sin.
I don't get them.
And I think most
I don't
things to
get 'em
think
either.
about, and when I teach students, is what's the utility? Is it going to change anything about your plan of care? And I can't remember if we've gotten to RSV yet, but just the other day I started seeing lots of kids, and mom and dad are like, we want an RSV test. I'm like, it's not going to change a thing. Your kids look great. They're congested. It'll keep you here another couple hours. What do you want? So if it's not going to change the plan of care, is it really important?
Yeah.
Medical, legal things, sometimes patient satisfaction, but always think about, is it going to change what you're doing or not? If not, then really have the discussion, that shared decision making, and maybe they will agree with us. If not, let's see what we need to do to take care of the patient.
The other thing is nasal bones are complicated. Some are truly cancellous bones that are truly bone, like you think about it, and some are membranous bones. And you crack a membranous bone and it always looks broken for the rest of forever. The cancellous bone will heal, but so if they've had, sometimes people who are assaulted have been assaulted before, just kind of as a, I don't know, it's chronic illness of some sort. But
Is
they,
it in the
yeah.
neuropsych
Yeah.
part?
There you go.
Maybe they're antisocial
Yeah.
personality disorder.
Actually, that's a really good point, Diane. I mean, you'd have to get a real good specialist to determine when that nose
It
was
was
broken,
today.
right? And ENT's expert consult witness charge about $2,800 an hour, by the way. $1,500 to
What?
$2,800 an hour.
Oh man, we all blew it.
I know. Get out of here and go back and be an expert consult
No, ick, no.
witness. Okay. Challenging question. What about the newer studies that show TPA is potentially more harmful than helpful?
Advanced boot course.
Yep.
I gave that caveat. There's this is such a controversial
Yeah, it
topic.
really is.
Yeah.
And I think that is again when you go outside of just the algorithm that you can have. All the initial stuff can be an algorithm. Get the CT, get the MRI, look for a major vessel occlusion, do your ABCs in your labs and then rule out the mimics. But this is when you just have to have that risk and benefits conversation with the family. Where I work, we're still doing TPA if people are within the window and are okay with doing that and consent for it. So I don't think we definitely have not reached a part where we're not offering that. That would
This
be kind of
horse
malpractice.
is so far out of the barn. It is like in Texas. This horse is long gone. So we had a window at some point to perhaps rein this thing in, but it is now
Yeah.
set in the guideline as accepted standard of care. And for that to get pried out of there is going to take a really long time. Don't do that on your own.
No, that's malpractice to not offer it.
Yeah, it is. It's just there, and despite all the people that have been railing against it for a long time, it's gotten shoved through, and it's just there.
definitely want to talk to neurology or stroke. And our guys do it, and we do a lot of intervention as well, but they're going to help make that decision, not just myself or just even the attendings I'm working with. We get all of us involved.
Yeah.
Yeah, I mean, Diane's right, Mike's right. You bring all these people in, don't do it alone. You have a crew of people that you can count on, get them involved. If podiatry wants to come down and consult on the TPA too, you let them come down, all right?
They're so nice. They probably
They
would.
are so nice. Has anyone ever met a
Podiatrists
mean
are just so
podiatrist?
nice.
No.
Never. They
Like
don't
urologists.
exist.
You have to have a sense of humor.
They're just so happy.
They just seem to be happy.
But one other note on TPA, if you really are interested in learning more about this specifically, our other faculty partner who unfortunately can't make it this trip because of Canada's rules,
And timing.
Ken Milne, he does a podcast. I think he releases one like every hour.
It seems to be.
He's-
It's a lot.
The Skeptic's
weekly.
Guide to Emergency Medicine.
really
He
good.
covers papers. He has faculty on the show. We talk about a lot of different things. And he covers TPA at great lengths. He's given grand rounds on TPA.
Done debates.
Please take a listen. It's worth the time. Ken Milne.
Milne, and it's the Skeptic's Guide to Emergency Medicine, SGEM.
SGEM.
It's very good.
All right, here's another good question, but not sure we know the answer to. Has the increased use of vaping caused an increased number of pneumo cases? And should they be higher on the risk scale?
I don't think so. So vaping is different than what people did when they smoked crack cocaine. The inhaling is not that kind of gulping kind of inhaling that happens with meth and cocaine. We do know that people that did crack cocaine did have increased risks of pneumopericardium, the whole shenanigans. It doesn't seem vaping, it's a different process when you smoke a vape. They definitely get lung problems. That's a whole different thing.
I actually talk a
But,
little bit about the e-cigarette vaping use associated lung injuries or the e-valleys, not tomorrow, but the next day. So we'll talk a little bit about it
And
then.
increased COVID risk if you vape as well.
Yep.
Just to add that to there.
Vaping is not a substitute for trying to quit smoking.
And you never know what they've got in there.
I
It
mean,
might be
kidding.
nicotine, it might be bath salts,
Yeah,
it might be
who knows?
mollies, who knows?
It could be poop. You don't know. Sure smells like it. Anyway, moving on.
Oh, that's the question.
Let's talk about this. It's actually a really sensitive question, and I'm not quite sure how we want to tackle it, but it was very upsetting to hear that someone experienced this. And if this was your question, give us some more information. Has Narcan been considered as the addition or an addition to pediatric BLS or ACLS? Asking because a 13-month-old came into urgent care unresponsive last month. We performed good BLS, however, she ended up passing on the following day from a morphine overdose from pills at her mom's house.
So Narcan is in.
It's in there.
In there. However, what's important in this case is this child was unresponsive and arrested. It is in there in consider Narcan in cases of a possible opioid overdose, which is all very reasonable, right? That's what we all do. I don't think that was something even considered in this child, at least initially. And once somebody has arrested, they actually say in the PEDS guideline that although Narcan can be considered in cases of cardiac arrest, there is no evidence of any benefit in giving Narcan. So if it had gotten to the point of the child arresting from an opioid overdose, the likelihood of Narcan making a difference is just nothing versus just doing good resuscitation and hoping for the best there. So, but yeah, it's in there. But I think just because opioids are everywhere.
And it's
Everywhere.
actually in the BLS stuff now, so
Yeah.
I teach as well, and now there's actually a video segment in the BLS training for everyone about thinking about opioid reversal.
But isn't part of BLS ventilation?
No, but it's in the education. It's not part of the ABC primary assessment, but it's in their education to consider Narcan.
Oh, I'm sorry, I was thinking of
Ventilation.
Yeah.
Yeah. That actually reminds me, Diane, when do you give your talk on thriving, not surviving?
Tomorrow.
That's tomorrow? I highly suggest paying extra attention because, we all need a lot of self-care. It's a great talk. I'm really excited for that talk, actually.
Okay, good.
That's where you talk about the
Whoever had
laughy
that case.
babies.
Yeah.
That's really challenging.
Those are heartbreaking
really hard
cases.
Motivation to come back tomorrow. Don't stay at the craps tables all night. Unless you are really, truly winning a lot, then don't ever
And then
come
share
back. Quit your job. Okay. Is there anything that we can do for an exposed partial fractured tooth other than a nerve block or referral? So I put up a nice little video of some Copac.
Oh, cool.
Copac's awesome.
So they actually make stuff called dental foil that you can
Dental
get,
foil?
Yeah.
and your pharmacy may have it. If not, it's like calcium hydroxide or some other chemical. It's
pretty cool.
But it actually could go probably buy it at most drugstores.
Yeah.
They sell it over the counter, but it just covers up the pulp and the dentin. Usually, once you cover that nerve root up, the pain gets so much better. And I may not have went into that a lot, but yeah, dental foil is really good.
It's actually,
really
if you want to
helps.
make friends back at your ER, make a dental box.
Yeah.
There's a few things you put together that are in a dental box. Oil of cloves goes in there because I can chew on there's like just like 6 things you put in there. It's awesome.
We have one at our hospital.
Yeah.
I think
That's
McCullough
in
made
there.
it.
Yeah, probably.
Yeah, she made it, and it's just like the go-to because
Yeah.
in the hospital everything's all spread all over the place, and you kind of forget what you need. And when it's just in this box, you're like,
And
all
it's
the
that.
tea.
It's the Copac, it's the
Actually,
dental
if your
foil.
hospital has a lot of money, they can buy you a dental box that comes with pictures on how to use it, all the equipment
Yeah.
in there and the like.
Make around.
That's getting fancy.
That's getting fancy.
$2.95.
And quite honestly, your best resource is your own dentist. Every time I go, I ask my dentist if I can film or video when he's doing an injection or anything on me, and he gives me great tidbits of what to do.
He tells
for-
stories about her all the time. There's when she comes in, brings her video. and-
You just okay, get your hand out of the way. Yeah, right there. Oh, that hurt. All right. I don't know why I sounded old.
I don't know.
also.
That's
Okay, another dental question. Is a dental abscess IND an indication for a dental block? And what are the other indications for a dental block? I like that question.
So I think definitely any painful process or painful procedure, these can really help. And whether you're doing just a localized tooth block or actually doing a facial block, that can really help. Sometimes with these little periapical abscesses, they're so tight,
Yeah.
all you can do is just touch it and it ruptures. And have plenty of suction available. And you may even need to anesthetize those. And usually once you relieve the pressure, just like your typical abscess, they feel a lot better anyway.
Yeah.
Yeah.
But sometimes you just take your scalpel, your 18 gauge, and just kind of poke it, and that's all it takes.
Have you seen that YouTube video site that puts the pictures of people popping the abscesses? Now, there are those, but this one puts like pictures of like cats and like little bears and kittens on the side.
What?
Yeah.
You spend too much time on the internet.
Well, I like to look at procedure videos.
With cats.
There's like little cat. Okay, never mind.
Next.
Next question. Based on PERC and the algorithm, all folks with dyspnea and greater than the age of 50 get a D-dimer. Is that how you all practice?
No, so I'm not sure exactly. That's kind of like everything's in there, but not all quite in the right place.
Yeah.
You start with risk stratification, period. And that's the very first thing that you do. PERC doesn't even come early on. PERC is later. And the initial risk stratification is, I don't think you have it at all. We're doing nothing. Then if it's low risk, that's when PERC comes in. And if somebody then, when they're in that low risk group, their PERC, they hit all 8, then you're done. You're finished. They're finished. But if they don't hit if any of them don't hit, then you have to go and do the D-dimer. So that's where the D-dimer comes in there. It has the dyspnea works into, do you think it's your risk stratifying part of that decision? It doesn't specifically take you right to a D-dimer.
Because then by thinking about it like that, then I mean COPD is getting a
Right.
D-dimer,
Yeah.
asthma exacerbations getting a D-dimer, some STEMIs are getting a D-dimer.
Yeah.
I mean, everyone's going to light up positive. I think you have to say, do I think this is a PE? Yes.
How much do I think it's
How
PE?
much do I think it's a PE? And if the answer is no, then this could be a 50-year-old with dyspnea, and you don't have to even
Right.
think about PERC.
You were doing it the Oprah way, and you get a D-dimer, and you get a D-dimer.
Everyone would be positive.
Everybody.
And I would shoot myself.
Yeah, it'd be a lot of CT
No,
scans.
no.
Okay, are you required to report suspected factitious disorder by proxy as a form of child or elder abuse?
Yes,
Yes.
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 Yep.
So when y'all order bedside ultrasound, you, the provider, are actually doing the examination with the butterfly. Yes, you are. And just a quick thing, you can record that image and make it HIPAA compliant and send it to your surgeon. So again, when I was working in rural medicine, I would do these DVT studies. I'd send them to the radiologist, or I'd send them to whoever needed them at the main hub hospital, our trauma center. I could do retinal detachment studies of the eye. Took me 2 seconds, send the little video. Another big one I like to do was appendicitis in kids. And so you just have it on your phone and you can just ship it right off. It's you're doing it. It's fantastic. Anyone else love it as much as I do?
I use the ultrasound for everything. I mean, I feel it's also dependent on like a lot of your training. I think my generation, we all got ultrasound training from the very beginning. And so there's still this, like, some people feel comfortable with it, some people don't. I think, I would say, another thing I frequently use it for is right upper quadrant pain. And I think that helps me figure out if I need to get a formal ultrasound, because a formal ultrasound takes a lot of time, right? My bedside takes 2 seconds. So if I have somebody that I think might have acute coli, if I do their ultrasound and I don't see anything, it's completely clean, empty, no pericholecystic fluid or edema of the gallbladder wall, and I look at their labs, they're not febrile, they don't have a white count, their LFTs are totally normal, then I'm like, okay, this is not acute coli. Now, if I am kind of on the fence about my ultrasound, I'm like, bad views, maybe difficult body habitus, and their labs are abnormal, then I'm getting the formal ultrasound because then I'm more concerned. But I think if I can go to bedside and be like, gallbladder looks great, their labs are totally normal, I stop there and I don't get a formal. But I think it also depends on your comfortability.
Yeah, so you have to, I think there's a big difference between somebody who's graduating now and somebody who took the ultrasound course just the other day across there, and somebody who's never had an ultrasound in their hand before.
Big difference.
So part of this is a comfort level, and you're not home free just because you learned it in residency either. You need to also have a system where there's a place to actually have it documented. Often you dump it into actually the true radiology system where you are. It actually is HIPAA compliant, gets put in there. So there needs to be an equivalent of a digital paper trail for these as well.
And even aside from just like whether or not you need to get the formal or not, for just an undifferentiated shortness of breath or an undifferentiated shock, it's just so helpful to like, is there tamponade? Yes or no? Like, is there a huge pericardial effusion? No. Moving on. Okay, I'm thinking that that's less likely. Is there a pneumo? Are there a bunch of B lines? Like, all that information, whether it's a formal ultrasound or not, you can do so quickly, and it helps narrow your differential in somebody that's very undifferentiated.
As long as you're good and you know what you're doing.
Yes.
You also have to know what to look for that's not normal. You might be searching or hunting for something, you feel very confident once you found it, but you could be like me when a lady stepped on a bunch of nails, and I did an ultrasound to look for the foreign bodies in her skin, and I sent the study, and I go, look, I found a nail, and he goes, well, did you see the other two? And I said, oh yeah, I see them now. So you have to make sure you know what you're looking at and be very confident with that, and have a good radiologist to take a look.
That's the downside to ultrasound. You feel omnipotent with that ultrasound. Honest to goodness, it's like, look at all this stuff I can see. It's so cool. And then all it takes is getting burned once, and you realize that thing it's not. Be careful.
And from the medical legal standpoint and administrative, make sure you have things in place policy-wise to support that you are truly credentialed, and you can use those. If you're not credentialed, then it's going to get into a gray area where can I use this truly as a diagnostic finding. This is more to really kind of guide me towards, hey, I'm going to do this versus do this.
Right.
Okay, speaking of more procedures for peds, such as suturing, et cetera, do you still suggest keeping parents in the room?
Sure.
Yeah.
If
I just
they're
think
in
it's
control
mean
of
that we send them
themselves.
out, as long as they're not
Well,
making
they're
things
so anxious
worse.
about, they hear their maybe their kid crying a little bit, and they
That's
wonder
just
what is
mean.
going
That's what
on,
they're
and I'm trapped. but in any case, yeah, absolutely.
Just make sure
bring
they're
everybody.
sitting down. Make sure they're sitting down. We've all had when
God,
the
yes.
parent goes down because it sounds like the
Oh,
bowling
yeah.
ball going down the bowling alley when their head hits the floor.
Boom.
It's like, I don't know. Make sure they're sitting down and not on their little rolling stool, a real chair. Put them on that, and then let them
Again,
stay.
this is where I like to bring in all my resources. I bring child life, I bring the nurse, I bring my friend, my colleague, my peer. I ask podiatry, I don't care. Anybody can come and help with that kid, help hold that kid.
And
right?
Oh, but
usually,
they get calmer.
that's what
Yeah.
And mom.
They feel more comfortable when mom or dad is
course.
in there, and you just have to ask, like, is there something you have on your phone? And they're like, oh my God, yes, 10 things. Like, they always know exactly what their kid's favorite thing's gonna be on their phone, so the parent doesn't even have to watch. They're just up here at the head of the bed, watching whatever show they like, and then
It's great.
everyone's in a happy place.
Yeah. All right, we got 2 minutes left. Let's do some quick yes/nos. Okay, first one. Can you use IV form of Zofran for little ones, for kids?
Yeah.
Yes.
Yeah.
Yes, but it tastes horrible.
So,
Oh, yes. You'll use it orally, yes. I haven't chugged it lately. Tastes bad?
I haven't, but I've had a friend who did after
Yeah.
some
I have a friend.
fun nights in Vegas, and yeah, it tasted bad.
It's like dexamethasone.
Exactly.
Oh, is that nasty?
The oral dexamethasone tastes terrible. The IV dexamethasone formula doesn't taste so terrible.
Why can't
did
you
we
just
do
use
that?
the disintegrating tablet?
Why did we do that?
Tastes fruity. Okay. Okay, I don't even know how to address this question, this next question about using hyaluronic acid subcutaneously in kids to infuse fluids. Has anyone else heard about this?
We actually were doing it for a while. Vets do it very often.
So you talking about crisis?
So actually injecting the hyaluronic acid in their back and then infusing fluids in the soft tissues.
Wow.
Veterinarians do this all the time with dogs.
Yeah, that's
And
called
so-
crisis. It's called crisis. They
Yes.
basically, your dog walks around looking like Quasimodo with a big
So several
lump
years
under their
ago, there
skin.
was a big push to start using hyaluronic acid in these kids, especially if you couldn't get an IV or didn't want to try to do an IV access.
Crazy.
I haven't seen it used in a while, but it was talked about, and there were products out there for using it.
Wow, it's fascinating.
Because you absorb the fluid through all that sub-Q stuff, but I don't know.
Just not
I have
something
never.
What color is considered purulent? Nasal discharge.
Not clear.
I was just
I
going
was
to
just
say
saying
that.
not looking.
Not
It's
clear.
opaque.
I just love people that like to call pus pussy. How do you spell that?
Oh yeah, be careful with that one.
Don't say
Purulent.
that.
Careful.
Do not. If you don't take anything
Purulent.
back from this
Just
course,
do
do not
purulent.
say that.
Just put purulent.
Okay.
Purulent.
Yeah, if you're dictating, that could
Yeah,
get
put
real
purulent.
weird
Yeah,
real
purulent.
fast.
Gross. Okay, do we want to tackle the echo bubble study versus? Should you get a bubble study to rule out a PFO? Yes or no?
So I think we were talking about this. I have to do a little bit of a deeper dive into the literature, but from what I can tell, if you use color Doppler, a cardiologist or ultrasound tech does this, then the color Doppler should actually be able to identify the PFO. My guess, and maybe I'm wrong here, my guess is that the bubble study would be more sensitive. If bubbles cross, you have a PFO. So I think probably you could do either study. I'm assuming the bubble study would be more sensitive.
Yeah, I
than
think that's why
ultrasound.
that's what the cardiologists
Yeah.
Yeah, that's
prefer.
what they want.
Yeah.
Yep. Of course, that's what the cardiologist wants, right?
Well, no, but I think it is more sensitive.
Yeah.
Yes. Well, I'm
And you really
saying
kinda
even
wanna
if
know.
it was
Yeah.
and if it was more expensive, wouldn't they want it also? I'm joking. I'm joking.
Cynic.
Okay. Is it okay to fix dragon-related dictation errors later after the encounter?
Ooh.
Often these errors go unnoticed and are picked up later or even the next day.
Or days
You,
later, or days later.
Or never.
I've-
Or never.
You should not read your dictations.
Exactly.
Do not read them automatically. I say I don't read my dictations. That's my practice. I never read my dictations. And it's been looked at whether Dragon's been involved in any lawsuits. The number of cases where the Dragon content has been involved, that where it was considered a part of the substantial part of the case, is counted on two handfuls from all the records that were looked at in this huge, humongous study. And because there were so few, the authors said, you should read all your dictations.
No.
Now, obviously, the data showed just the opposite, that you shouldn't read any of them. Yeah, there are going to be little changes, mistakes like that. You didn't take off the wrong leg kind of thing. It's not going to put right where it should have been left. So it's a waste of time. You've got better things to do than to
It's
read
an
your
easier
dictations.
defense in court to say it is my standard practice to not read my dictations. Then if an error is found, it's just an error made by the dictation. If you start to futz with your charts, then there's all kinds of doors that get opened. If you corrected that, well, why isn't that part corrected? And you're blaming that on it's just better to have a practice where you don't read them. And that bridles, I'm an editor of everything. So the idea that I wouldn't read it, it's like, are you kidding me? But it is really, honestly, you put it out there as cleanly as you could and then just let it go.
Should you include a disclaimer?
Well, I think
I
think
do.
you have it built into yourself.
Yeah.
Right? My standard practice is not to read. That's my disclaimer.
But some of that use voice dictation software may cause grammatical or phonetic errors.
Exactly.
Right? Like you have on your Siri. I dictated this into my iPhone. Sorry for typos,
Okay. Let's do
Last one?
This will be the last one here. Medical legal, more medical legal. When documenting your consideration against a disease, is it more protective to document overarching broad, or must you include specific diagnosis names and how your workup wasn't consistent with each diagnosis? Also, must you document why a disease wasn't in your differential?
Oh, God.
All right, well, we'll see you.
You're supposed to do more than one chart per day kind of thing. People really vary on that. The paragraph that I showed you, I think I tried to show you that everything could be taken apart in that paragraph in terms of, they say they ruled out PE because there was no hypoxia or tachycardia. Well, neither of those are in the majority of PEs. So, and to say you ruled out ACS because there's normal EKG and normal troponins, well, the fact is that that doesn't mean they didn't have unstable angina kind of thing. So I think it's very difficult, and I think that this idea of listing every organ in the abdomen that you've considered in terms of, I've considered diverticulitis, it's like this repetitive, everything that's wrong in the belly kind of thing, and it's like it doesn't seem to make a lot of sense to me, but some people do it, and the thing that I showed you is from a Medicare-approved paragraph.
I think two words to not put in your dictation ever are ruled out.
Yeah.
Put diagnosis unlikely because, or doubt diagnosis of X because.
Less likely.
Less
Considered,
likely,
but-
considered but unlikely. Because it ruled out, attorneys just jump on like crazy. Really? And how did you rule it out? Is that 100%? They just go nuts. Just don't even go there. And remember, what you're dictating here is for two reasons, right? One, well, actually, theoretically three. One is to convey medical concerns. One is so you get paid, which is why we add all this silly stuff in there in the first place. And then one is for medical legal protection. So you're trying to wrap all those three things into a medical decision-making blob here. So don't shoot yourself in the foot by putting ruled out in there. Don't put less likely or considered but feel unlikely, whatever. Put in the things that you really did consider so that people know that, and then make sure it's clear what you diagnosed and why.
I think it also becomes obvious when you use a lot of dot phrases. Like, dot phrases are helpful, don't get me wrong, but if you have this crazy dot phrase of like everything, like you're saying, in the liver and the kidney and the appendix and the ascending and descending colon, I mean, it's like going to be obvious that you don't
didn't.
write that individually for this one person.
Can I have the last three charts you wrote down?
Yeah.
Yeah, it's going to all look the same.
We do have one last talk called Odds and Ends in EM where we cover, we do the talk right before you leave and tell you a bunch of things, good little dot phrases and things for pain, things that are medically, legally appropriate. I had a lawyer look at a lot of them and approve them, so we'll go over that on the last day as well. So, dinner time.
Go forth and gamble. Have fun.
Be careful. Call a babysitter if you need one.
Thank you.
Type the adult babysitter.
Thank you.
I charge $100 an hour. No. I charge $1,000 an
Does
hour,
that come with a tattoo?
and it comes with a
That's okay,
tattoo.
leave that.
Leave them?
Yeah, we can't afford to have any.